So, good morning all. We are going to start with one of the very important topic today. That is going to be a chemotherapeutic and antimicrobial. Why this antimicrobial is important if you ask me. So, almost in your Tripathy textbook, it is going to be consisting of around 50 or 40 to 50 pages. It is going to be. And most confusing part, and definitely you will get at least 2 short notes, or if you are lucky enough, 1 essay. So almost 15 to 20 marks are reserved only with this chapter. And that is the reason why I'm starting with this chemo antimicrobial chapter. And I hope so I'm audible and my screen is visible. So in between, if you have any doubt, you can post it in the chat box, but I will be answering only at the end of each block because I don't want to delay the session as we have to complete it in a stipulated time today and tomorrow. That's all. Maximum I have to complete it by tomorrow afternoon. So you can anytime view it again when I upload in the YouTube. So no need to worry. So let me start with the antibiotics. So how do we classify the antibiotics? So for example, first take a bacteria. You will have a cell wall. Then you're going to have a cell membrane. After cell membrane, you're going to have a nucleus. This nucleus is the one that is going to have DNA, RNA. These DNA, RNA are the one that is going to secrete or synthesize proteins. These proteins are going to be packed into ribosomes. Okay, this ribosomes, which is going to pack your protein, are going to finally give an end product of enzymes. This enzyme is the one that is going to act and invade our cell, invade our immunity, etc. So what we are going to do is either we are going to inhibit the cell wall, or we are going to destroy the cell membrane, or we are going to destroy the nucleic acid. When we do this cell wall, cell membrane, nucleic acid synthesis is inhibited, that is going to destroy or kill your bacteria. That is why we call it as a bactericidal drug. That is why we call it as a bactericidal drug. Okay, so then comes your second group of drug, which is going to either inhibit the protein synthesis. Now the DNA is formed, there is a replication of your bacteria, but you are going to inhibit the proteins or the inflammatory substances that are secreted by your bacteria. And finally, the enzymes or antimetabolites secreted by the bacteria. This is called as bacteriostatic. So this is called as bacteriostatic. So what is the difference between bactericidal and bacteriostatic? When you're going to give a bactericidal drug, that is going to destroy the bacteria itself. Okay, whereas bacteriostatic, it is going to prevent the enzyme formation. It is going to prevent the complete replication of the bacteria. So it will prevent from multiplying into several number of bacteria. So that is the role of your bacteriostatic. Okay, so when you are going to combine bacteriostatic and bactericidal, what happens? Remember, we will never combine bactericidal drug and bacteriostatic drug. You may ask me, I'm going to give a bactericidal drug that is going to destroy my bacteria. I'm going to give a bacteriostatic that is going to inhibit the multiplication. Isn't it a good combination? No, it is not a good combination. Why? Because your bacteriostatic in turn will inhibit the action of bactericidal group of drugs. Your bacteriostatic inhibit the bactericidal group of drugs, and that is the reason both of them are not a good combination. They are going to act as an antagonist to one another. Hope you are clear with this. Hope you are clear with this point. Okay, now we will go one by one. Okay, next is your protein synthesis. I was just mentioning something called as protein synthesis inhibitor. How it happens. So this is just a brush up of whatever you were reading in your biochemistry. So you all know that there is something called as translation. So translation is a process by which there is an enzyme or a protein formation from individual amino acid. How is this mechanism going to occur? A very simple process. You are going to have a 30S ribosomal subunit and 50S ribosomal subunit. This 30S and 50S, what happens? This 50S is going to have a acceptor code. Okay, they are going to have something called as acceptor site, and there is going to be something called as replication site. There is an acceptor site and a replication site. So what happens basically, if you ask me, the first step of your replication is where there is going to be a mRNA coding, which is we obtained from your transcription. So during the transcription, you're going to have something called as mRNA coding. This coding is the one that is going to decide what protein is formed at the particular point. So proteins are nothing but the combination of amino acid. You have several amino acids circulating in your body. Now, what your body does is this amino acid comes to the acceptor site. Okay, this acceptor site will accept amino acid and will be building up your amino acid to form a protein. This is what you would have read in your biochemistry. இங்கேயும் அதே process தான் நடக்குது. So you're going to have a first P site, you're going to have the first starting codon. Okay, starting amino acid you're going to add. So start codon வந்துருச்சு. இப்போ என்ன பண்ணணும் next? You're going to add a codons to it. So how these codons are added? From the acceptor site. So அந்த acceptor siteல add ஆனதுக்கும் P siteல இருக்கக்கூடிய அந்த amino acidum combine ஆகணும்னா you need a peptide bond. And you also need a translocase. That translocase is an enzyme. What it will do is, it is going to transport your amino acid from your acceptor site. So acceptor site la irukka tRNA va navati pRNA ku kondu varadhukku you need translocase. Hope I am clear. Hope I am just giving you a brief idea about what is a translation is. Okay, now you are going to slowly add on your amino acid till there is going to be a stop codon that is going to come. So you are going to have your UA, UGA, UAG. So UAA, UAG, UGA. These are the three codons which is going to act as a stop codon. So once you're going to have a stop codon, stop mRNA codon is going to be there. There is going to be a stoppage of your amino acid building up and you're going to get a protein outside. Okay, this protein is very much necessary. This protein is very much necessary. Why do you need this? For the synthesis. Okay, for the synthesis of substances that are going to invade our immune system. So the bacteria require all these proteins. Why do they require? In order to inhibit our immune system, and it has to grow inside us. Second thing, simple way, it has to replicate and it has to maintain the continuity of the life in the human body, and it has to reproduce to form a new bacteria formed. Now what we are doing, we are going to inhibit this protein synthesis. How we are going to inhibit the protein synthesis? Either we can inhibit by binding with the 30s subunit. We have two subunit here, isn't it? We have something called as 30s ribosomal subunit. We have 50s ribosomal subunit. What they thought is, why don't we inhibit this 30s subunit and 50s subunit? So that's where there is a birth of protein synthesis inhibitor. What are those protein synthesis inhibitor? Let's see. Number one, 30s ribosomal subunit. In 30s ribosomal subunit, you're going to have the first one, that is going to be your tetracycline. Okay, so you have read this tetracycline many places, right? So tetracycline ennadu? They are going to be the 30s ribosomal subunit inhibitor. How do they inhibit? Very easy. So your ribosome, okay, you're going to have a 30s ribosome. Your 30s ribosome is going to have something called as acceptor site. Can you see it? So this acceptor site is the one that is going to accept the tRNA, which is going to carry the amino acid. What you are doing? You are going to inhibit this place. Who is going to inhibit this place? Tetracycline. So when the tetracycline is going to act, it is going to block this acceptor site, and therefore there is no replication going to occur. Okay, next one you're going to have is aminoglycosides. What does this aminoglycoside do? So you in the mRNA, you're going to have something called as initiator complex. Okay, in this initiator complex, only if this initiator complex comes and sit at the And what is another L? Linezolid. First write down this. I'll tell you how to remember each and every mechanism. So our main aim is, see, any antimicrobial you're going to take. Number one, what is the name of it? What is the group or family name? Then you have to know what is the mechanism of action. Then you have to know in which disease you're going to give it and what are the side effects and what are the contraindication. These are the 5 headings you're basically going to remember, not for just antimicrobial, for any drug per se in your exam if you're going to get. Even it is a essay, even it is a short note, you're going to write just this 5 headings very importantly without forgetting. So first we are seeing just the mechanism of action of all these drugs. So how we are going to remember? When you get this 50S ribosomal subunit, this 50S is going to be very small. So remember small c. S stands for streptogramin. MA stands for macrolide, L stands for lincosamide, and another L stands for linezolid, L stands for lifamulin, and you have the final C that stands for chloramphenicol. Okay, all these are going to be a 50S ribosomal subunit. This 50S ribosomal subunit has few important action. Number one, it is going to initiate it is going to cause elongation. Okay, so this is 50S is only going to move along your mRNA in order to elongate your amino acid. So it is going to have elongation, and in order to move, what I told you, it requires translocase enzyme that is also given by your 50S ribosomal subunit. So translocation is going to be done by your 50S ribosomal subunit. Third one is going to be initiation to bind with the 50S ribosomal subunit. You know that you have 30S. So 50S has to go and bind with the 30S. You know that aminoglycoside is the one that is going to inhibit the initiation of 30S ribosomal subunit. Similarly, you have 50S ribosomal subunit. There also you have some initiator site. That has to be inhibited. Who is going to inhibit? Your linezolid is going to inhibit. So remember, aminoglycoside is an initiator inhibitor in your 30S ribosomal subunit. In your 50S ribosomal subunit, it is going to be your linezolid. So two important you're going to weigh. One is going to be your aminoglycoside, which is going to be at the 30S ribosomal subunit. You're going to have the second one that is going to be your linezolid, which is going to inhibit the initiation of 50S ribosomal subunit. Hope you're clear with these two drugs. Okay, now what is the last C? Last LC is going to be your lifamulin and chloramphenicol. What does this lifamulin, chloramphenicol does? So in order to build up your amino acid to form a protein, what do you need? Between one amino acid and another amino acid, you're going to have a bonding that is going to be by a peptide bond. So you need a peptide bond. That peptide bond is inhibited by the last two, lifamulin and chloramphenicol. So repeat along with me. So I'm going to just tell again. So just close your eyes and repeat along with me. You have something called as protein synthesis inhibitor. They are going to be bacteriostatic in nature. You're going to have two units, 30S ribosomal unit, 50S ribosomal unit. Under 30S ribosomal unit, you read only two drugs. What are these two drugs? Number one, it is going to be tetracycline. Tetracycline is going to inhibit the tRNA at the acceptor site. Then you have aminoglycoside, which is going to inhibit the initiation of the translation in 30S ribosomal subunit. Then you moved on to discuss about the 50S ribosomal subunit. In 50S ribosomal subunit, what is the mnemonic I told you? Small LC. So S stands for streptogramin, MA stands for macrolide, and L stands for lincosamide. What is the other end stands for? Linezolid. What does the other end stand for? Lifamulin. And what does C stands for? Chloramphenicol. So now each and every mechanism we are going to see. Streptogramin, it is going to prevent the elongation. Streptogramin prevents elongation. Then your macrolides and lincosamide. Lincosamide is going to prevent translocation. Then we had linezolid. It's very similar to that of your aminoglycoside here, but it is going to inhibit the initiation of 50S ribosomal subunit. Then you have only two drugs more, L and S. The L stands for lifamulin and C stands for chloramphenicol. Lifamulin, chloramphenicol, both are going to inhibit what? Both are going to inhibit your peptide bond. Hope it is clear. So this is a very important thing. I want you all to take a screenshot of it. Okay, now you know all the important points regarding the mechanism of action of all these drugs. We have seen almost 8 drugs here. These 8 drugs mechanism of action, hope you all remember. Now what we are going to see is individually, let's see certain important things. See, for all the drugs that are going to be a 50s ribosomal subunit inhibitor, they are going to be bone marrow suppressor. Okay, generalized on our drug me. Okay, let it be Streptogramin, let it be Macrolide, let it be Linezolid, let it be your Lincosamide, let it be your Lefamulin, let it be your chloramphenicol. All are going to cause bone marrow suppression. Okay, if there is a bone marrow suppression, there is ample chances for the aplastic anemia. But if you ask me who is more prone for development of aplastic anemia, the one that is going to inhibit your peptide bond. Can you tell me the one which is going to inhibit your peptide bond? Can you tell me in the chat box which is going to inhibit your peptide bond? 2 drugs are going to inhibit your peptide bond. What are those 2 drugs? Can someone put what are the 2 drugs? It is in the screen. I just want to see how active you are all. That's all. Okay, it's just in the screen. Just a matter of seconds to copy it down and put it in the chat box. But that will give you a memory, long-term memory. That's the reason I'm asking you sometime to put in the chat box. Yes, it's a lefamulin and chloramphenicol. This lefamulin, chloramphenicol are more prone for aplastic anemia, and they are the one that is going to lead to a teratogenic effect. So if a mother who is in the first trimester of pregnancy, who is going to take chloramphenicol or lefamulin, more common as chloramphenicol than your lefamulin, they are going to cause a gray baby syndrome. So gray baby syndrome is nothing but they are blue-gray cyanosis in a lethargic child. Okay, you have other symptoms also, but just remember blue-gray cyanosis with lethargic child, that is called as your gray baby syndrome. Hope you all will remember. Next, we are going to see what is resistance. Sometimes what happens is there can be development of resistance to the chloramphenicol. What is the reason? Because of the inactivation of acetyl transferase. This acetyl transferase is an enzyme that is going to break down your peptide bond. Then you are going to give a chloramphenicol. Okay, now what happens when there's going to be development of resistance against chloramphenicol in a patient? There is going to be this acetyl transferase inactivation that is going to lead a resistance to chloramphenicol. Where will you use a lefamulin? Remember, lefamulin we are going to use in the community acquired pneumonia. So lefamulin is used in the community acquired pneumonia. Okay, we will see individually about tetracycline aminoglycoside. Don't worry, because everything is a short note asked in your exam. So I'll just try to cover every single topic. Okay, now coming to the topical protein synthesis inhibitor. Just you are going to have 2 drugs, mupirocin and puromycin. Mupirocin, it is nothing but it is going to be an inhibitor of isoleucine tRNA synthesis. They are very specific. They are going to inhibit the isoleucine tRNA synthase. Okay, synthetase enzyme. And what is puromycin? Puromycin is going to be like an antagonist. Okay, it's going to be like a duplicate key. So what happens is the puromycin, they are going to resemble your tRNA. What it does, it is going to go and insert into the acceptor site. Now, when it goes and attaches to the acceptor site, it is not going to allow further attachment with tRNA. Rather, this cannot be moved to the next one by your translocase enzyme. That is the reason why puromycin is an effective topical protein synthesis inhibitor. Okay, so topical protein synthesis inhibitor, rendu drug da. You are going to remember your entire Tripathi textbook for your topical protein synthesis inhibitor. You are going to remember just 2 drugs, mupirocin, puromycin. Mupirocin is very specific isoleucine tRNA synthetase inhibitor. Then you are going to have your then you're going to have what? Then you're going to have the second one, that is going to be your puromycin, that is going to resemble your tRNA and insert into the protein synthesis, and premature termination of your protein synthesis occurs. Now coming to the individual group of drugs. As I told you, we will discuss about the individual group of drugs. First one is going to be your tetracycline. Can you tell me what is the mechanism of action of tetracycline? What is the mechanism of action of tetracycline? All the mechanism of action, now you're going to answer me. Okay, just let me know what is the answer. So what is the mechanism of action of tetracycline? Tetracycline is a broad spectrum. Why we call it as broad spectrum? What is the mechanism of action? It is going to inhibit what? Can you tell me? It is going to inhibit what? 30S ribosomal inhibition. Very good. In 30S ribosome, what it is going to inhibit? It is going to attach to the acceptor site. Remember, this is going to attach to the A site of 30S ribosomal unit. So that is going to be inhibited. So because of that, what happens? There is going to be a protein synthesis is going to be inhibited by your by the bacteria. Now the problem which is going to occur is, this is when you're going to take this. This is going to act on all the bacteria that are going to be present. That means that this is going to also inhibit. It is also going to inhibit your normal GIT flora. So when the normal GIT flora is inhibited, that leads to super infection. So why that is a super infection? Because there is going to be a decrease in the production of your WBC, RBC platelets. So that can be one problem. But in renal specifically, what happens is you're going to have Fanconi syndrome. Can you tell me what is Fanconi syndrome? So you have your glomerulus. Okay, you would have read this is going to be a glomerulus. This is going to be your proximal convoluted tubule. You're going to have proximal convoluted tubule, and you're going to have your loop of Henle. In proximal convoluted tubule, you're going to have absorption of majority of your proteins, majority of amino acids. Everything is going to be absorbed in this proximal convoluted tubule. But what happens is, okay, here what happens, because of eating a expired tetracycline, this expired tetracycline is going to block your PCT. When there is a blockage in your PCT, what happens? There is going to be a problem in absorption of sodium. There is going to be a problem in reabsorption of your glucose. There is going to be a problem in reabsorption of your H+, because here you're going to have a carbonic anhydrase enzyme. We will be discussing them in the diuretics chapter. Don't worry. Today, by the evening, we will be discussing diuretics. That time I will tell you. But remember, for now, Fanconi anemia, Fanconi syndrome is nothing but there is an inhibition of your proximal convoluted tubule cell that is going to be caused by the expired tetracycline. First point, they are not safe in the renal. Why? Because all your tetracyclines are going to get excreted by the renal. Everyone are water soluble. So any drug that is water soluble gets excreted by your kidney. Any drug that is lipid soluble gets excreted by your bile. So here you are not going to give in the renal failure. Even if it is a renal failure, you can give two drugs. What are those two drugs? Doxycycline, minocycline, tetracycline. Okay, this doxycycline, minocycline, tetracycline tetracycline. Why we are giving? Next question you will ask me. Because as I told you, these three are going to be a bile elimination. These three are going to be eliminated by bile. Okay, doxycycline, minocycline, tigecycline. Three are eliminated by bile. Therefore, we are giving. And you have something called as demiclocycline. So, tetracycline la nama ennalam paakrom. Tetracycline nama start pannadhula we are seeing number one. Tetracyclines, what are the drugs we are seeing? Number one, we have seen your doxycycline, minocycline, tigecycline, domicycline. Tigecycline, then we are seeing the last one, that is domicycline. So domicycline, they are going to be having an important side effect, that is nephrogenic diabetes insipidus. Why there is nephrogenic diabetes insipidus? I told you, always question why for each and every side effect. Because that your demiclocycline is going to cause CD cells. Okay, it is going to produce your CD cells. They are going to inhibit your ADH hormone. They are going to be making your ADH receptor insensitive. When the ADH receptor becomes insensitive in the CD cells, that is your collecting duct. In the collecting duct, what happens? So there is going to be a inhibition of your proximal tubule leading to Fanconi syndrome. Your demiclocycline is going to inhibit your collecting duct leading to nephrogenic diabetes insipidus, and that is going to cause polyuria. Okay, we have seen three important problems. Number one, we have seen super infection. Number two, chelation of calcium. Number three is going to be your renal side effect. So renal side effect, doxycycline, minocycline, and your tigecycline can be given by your in the renal failure. Whereas why? Because they all are going to be bile eliminated. Domiclocycline you are going to avoid. Why? Because they are going to inhibit your CD cells leading to nephrogenic diabetes insipidus. Now coming to the fourth point, photosensitivity. So it is going to be causing a photosensitivity. Demiclocycline more common than your doxycycline. Now coming to the fifth one, minocycline. So minocycline, there is going to be a blue-black skin pigmentation. In minocycline, you're going to have a blue-black skin discoloration or pigmentation. There is going to be a rise in the intracranial pressure. Whenever the intracranial pressure rises, that leads to pseudotumor cerebri. And finally, you're going to have something called as vertigo. Then coming to this sort. Now, can you tell me what are the 5 side effects? One by one, can you tell me all the 5, those who are in the chat box? Those who are in the class? Can you tell me? Just put one by one, even if it is repeating, no issues. Just put what are the side effects which we discussed. 5 important side effects. This is going to be your immediate memory. Testing your immediate memory. Super infection. Very good, Dinesh. Next one. Super infection. Very good, Dinesh. Next one. Adil, others. Can you tell me? Number 1 is super infection. Number 2. Teratogenic, excellent. So they are going to be teratogenic. What type of teratogenicity you're going to have? That is going to cause a bone and teeth defect because of decrease in the calcium absorption. Why? Because of calcium chelation. What is the third one? Third one. Can you tell me the third important side effects you're going to have without any order? Renal side effect. Very good. In that, Fanconi syndrome is going to be there. Excellent. So what is the second thing? Second thing what? So it is also going to cause what type of diabetes insipidus? What type of diabetes insipidus? Nephrogenic diabetes insipidus. Very good. Nephrogenic diabetes insipidus. Why it is caused, or which drug mainly causes? Which drug mainly causes? What drug mainly causes among tetracycline, which drug? Demiclocycline. Excellent. Can you tell me what are the 3 drugs which is not going to be problem in a renal failure as they are going to be bile secreted? What are the 3 drugs which we discussed? They are safe in the renal failure. Safe in the renal failure. Can you tell me what are the 3 drugs? Number one, doxycycline, minocycline, tigecycline. Okay, tigecycline. It's not tigiclocycline, it's a tigecycline. That's all. Doxycycline, minocycline, not minicycline. It's a minocycline, doxycycline, minocycline, tigecycline. Okay, so now you know something about your tetracycline, everyone. See, okay, now we are going to discuss about the last one, that is going to be your photosensitivity. Who is going to have a more photosensitivity? Can you tell me? Which one has more photosensitivity? Which drug has more photosensitivity in your tetracycline? Which drug has more photosensitivity in your tetracycline? Minocycline, illa. No. Photosensitivity. It's going to be again your demiclocycline. Demiclo more than your doxy. But demiclo, doxy, both are going to be a photosensitive one. But demiclo more than your doxy. And now last one, minocycline. In minocycline, what are the 3 important other characteristics you're going to have? Minocycline is safe in your renal failure, accepted. But what are the other important problems? 3 important problems you're going to have with minocycline. Can you tell me? What are the 3 important problems? Number 1, they are going to cause a blue-black pigmentation. Number 2, it is going to cause a rise in the intracerebral pressure. Number 3, it is going to cause vertigo. Intracerebral pressure rise, achna, it leads to pseudotumor cerebri. So we have completed with the side effects. Now coming to the usage. So where all you're going to use? Remember, doxycycline, one of the important drug of choice in many conditions. Okay, among your tetracycline, what you should never forget is your doxycycline, because doxycycline is a drug of choice in rickettsia. So doxycycline is a drug of choice in rickettsia. In rickettsia, especially your typhus or Rocky Mountain fever or Q fever. So doxycycline more common than azithromycin, more than your chloramphenicol. Why do I give azithro in the case of rickettsia? Because azithro is also going to help, but azithro is going to be can be given in the pregnancy, whereas doxy cannot be given in the pregnancy. As you all know, tetracycline causes calcium defect and intrauterine growth retardation because of your tetracyclines. Therefore, what you will give, azithro is given in the pregnancy and in the children. Okay, in everywhere, if you're going to see who is going to be the alternative for doxycycline, it is going to be your azithromycin. Okay, then chloramphenicol can also be given. This is regarding rickettsia. Then comes your cholera. Cholera enna drug kudupenga? Again, doxy, more common than azithro. Azithro epa kudupenga? Pregnancy and children. Number 2, if at all there is going to be any bacterial infection that is going to be recurring, that is going to be resistant, that is going to be resistant to what? That is going to be resistant to your that is going to be resistant to your doxycycline. Then you can give. And what is the prophylaxis for cholera? Write it down. Just put a box and write it down. Prophylaxis of cholera, as per the recent guidelines of WHO, you do not require any prophylaxis for cholera. No need for any cholera for the travelers. And only if there is going to be a close contact, you are going to provide with doxycycline, or else there is no fixed prophylaxis needed for cholera. So rickettsia, then we have discussed about the cholera. Now the third one is going to be your brucellosis. What is brucellosis? What you are going to give? Doxy plus streptomycin. You can give doxy plus streptomycin. That is going to be your drug of choice. But if you ask me what is the WHO guidelines for brucellosis, it is doxy. Along with doxy, we give rifampicin. So along with doxy, streptomycin is going to be the drug of choice. But what is the WHO recommendation? That is going to be doxy. Along with doxy, you are going to give rifampicin. Now, what is going to be the next one? Prophylaxis of malaria. Yes. So in the prophylaxis of malaria, any plague, leptospirosis, cholera. So especially cholera வந்து பாத்தீங்கன்னா close contact we will be giving prophylaxis of malaria, plague, cholera and your leptospirosis, but cholera only close contact. So remember, now we had a flood in Chennai, flood in Thoothukudi, flood in Tirunelveli and in Kanyakumari. Every place there was a flood. In a flood, what is the most important infection that can spread? That is going to be either leptospirosis can spread, okay, plague can spread, malaria can spread, cholera can spread, isn't it? So even though we are not giving just for cholera, we will be giving a doxy prophylaxis in all the flood prone areas. That is because, remember, that is because it is going to prevent all these important diseases that are possible to spread in the flood. That is why we give doxycycline as a prophylaxis. Clinical implicated question that can be asked in your upcoming exam because of incidence of this flooding in all the areas. Now the university can ask you this question. Next, coming to your leptospirosis. So leptospirosis, we divide into mild, moderate and severe. I am not going to explain you in detail about leptospirosis. Just a brief note. Leptospirosis spreads from the rat urine, dog urine, all the canine urines, as well as your dog urines. You're going to have leptospirosis. So this is common in the rice field, among the farmers, among the rainwater, among the flood water. So there is going to be a chances of leptospirosis. If it is a mild leptospirosis, if you're going to just see, if you're going to suspect a mild case, you're going to give doxycycline. Whereas in severe case, you go for penicillin or ceftriaxone. So in microbiology, you would have read that severe leptospirosis is called as Weil's disease. In Weil's disease, what is going to be your drug of choice? In Weil's disease, the drug of choice is penicillin or ceftriaxone. Penicillin or ceftriaxone. Hope you are clear with the sixth point. What is the seventh point? Minocycline. Yes, minocycline can be given as a drug of choice in case of leprosy. In leprosy, especially the patient, if they have a restriction of movement, if the patient is going to have a restriction of movement, you are going to go for minocycline drug. Okay, how to remember? I told you, right, how to remember this. RCB plays cricket to lose match without any, there is no grudge against any team, but this is just a mnemonic. You can remember it using this mnemonic. It will never forget for you. So tetracycline is going to be a important drug, but it is not given most commonly. Why? In a OP setting, we are not, because they have some side effects. Since they are going to have side effects, we are not going to give the drug commonly like RCB. RCB has a potential, but preferred in these days because there is a resistance to doxy. What does B stands for? What does B stands for? RCB B stands for what? Brucellosis. Excellent. So brucellosis, what happens to the brucellosis? Brucellosis is going to, you're going to give two important regimens are there. One is going to be your doxy plus strepto according to your drug of choice, but the WHO recommendation is doxy plus rifampicin. Can you tell me what does P stands for? P stands for, what does P stand for? Prophylaxis. So just not prophylaxis of malaria alone. Prophylaxis, remember, you're going to have malaria, plague, leptospirosis and cholera. Malaria, plague, leptospirosis and cholera. But remember, cholera, only close contacts you're going to give, not for travelers according to the latest notification by WHO. Now coming towards the place is over cricket. C stands for, what is your C stands for? What does C stands for? C stands for your 1, 2, 3, 4, 5. Just 5 seconds for everything. Chlamydia, excellent. So prophylaxis of chlamydia. You are going to have lymphogranuloma venereum. In the lymphogranuloma venereum, the drug of choice is going to be a doxy. Okay, doxy is drug of choice than your azithromycin. But remember, in the trachoma urethritis cervicitis are local infections. So in the local infection, you're going to give either azithro single dose or doxy for 7 days. So remember, the dosage is going to be doxycycline 7 days you're going to give. So what is the dosage? Doxycycline you're going to give for 7 days. Next coming to the leptospira. Okay, leptospira, you're going to give, okay, L stands for leptospira. So you're going to give mild in a doxy. What you will give for severe leptospirosis or Weil's disease, can you put in the chat box? What is going to be the drug you're going to give in the severe? What is the drug you're going to give in case of severe? What is the drug you're going to give in case of severe? Can you put in the chat box? In severe, you're going to give penicillin or ceftriaxone. Excellent. You're going to give penicillin or ceftriaxone. And coming towards your minocycline, you're going to have the restriction of movement. Leprosy, you're going to give minocycline. What is the dosage? 100 mg, you're going to give doxycycline BD. By dose, you're going to give for 7 days. This is the normal drug regimen which we are following in the OPDs, which I prescribe and every other practitioner is prescribing us. Doxycycline 100 mg twice a day for 7 days. This is going to be the regimen which is prescribed for your doxy. Now coming towards your resistance. See, your doxy is going to have a very important thing. Okay, every bacteria is going to have a tetracycline efflux pump. This tetracycline efflux pump, especially in your pseudomonas, they are going to have a TC pump, effective TC pump. Okay, so what is this? Tetracycline efflux pump. So in the tetracycline efflux pump is going to be, okay, is there. Now what you can do, you have to make sure that the tetracycline is not going to pumped out by your bacteria outside. So you are going to give a tetracycline, that tetracycline is going to enter into a bacteria. But if this tetracycline efflux pump is there, it will be pushing your tetracycline outside. In order to prevent that pushing out of tetracycline outside, you are going to have a glycyl group attached with your tetracycline. When you are going to add your glycyl group with your tetracycline, what happens? Glycyl and cycline is going to join, and this is called as tigecycline. T lande tetracycle lande TA எடுத்துறீங்க, glycyl lande GE எடுத்துறீங்க, tigecycline name வைக்கிறீங்க. Now you can understand, right, what is tigecycline? Tigecycline is nothing but tetracycline. Along with tetracycline, what you are doing? You are going to add a glycyl group. Along with tetracycline, what you are doing? You are going to add a glycyl group. This is called as tigecycline. Clear, right? Now you will know what is tigecycline, isn't it? So that is the reason tigecycline is going to be given very effective in case of tetracycline resistant bacteria. Tetracycline resistant bacteria. But also remember that this tetracycline resistant bacteria la kudukala tigecycline. But again, this tigecycline is going to be having a resistance in case of pseudomonas. So pseudomonas la tetracycline you cannot give, tigecycline you can't give. And remember, tigecycline is excreted through what way? By the bile excretion. That's what we read in the side effects when we are going to read what are the 3 drugs that are going to be excreted by your bile. What we told, number 1, we read about the doxycycline, minocycline, tigecycline. So these 3 are going to be the effective in case of renal failure. Also, we can give safe in renal failure. So this tigecycline is safe in renal failure, and usage is going to be mainly in the skin infections or intra-abdominal infection if there is going to be a IV. So if you're going to have an intra-abdominal infection, you're going to give by IV. Skin infection, you can give either by tablet or by a ointment route also. Now, there are new tetracyclines that are arrived into the market. What are the new tetracyclines? You have iravacycline and omadacycline. Iravacycline and omadacycline. Now, iravacycline and omadacycline. Hope you have copied. Now, the last, that's all we have completed. Now, can you just list out what are the drugs we saw in case of your tetracycline? Just list out. Just put whatever drug you remember under the heading of tetracycline. Can you put in the chat box so that now we will accumulate everything. Whatever we read, all the tetracycline, we are just going to just memorize it. Can you put in the chat box what are the tetracyclines you know? Just put randomly, not an issue. Come on. So what are the doxycycline? Excellent. Number 1. Minocycline. Number 2. Doxycycline, minocycline. Third one, we read doxycycline, we read minocycline, we have demiclocycline, excellent. Tigecycline, 4 is over. Doxy, mino, demiclo, tigi. What is the other one? Doxy, mino, tigecycline, demiclocycline. What are the other cycline we read? What are the other cycline? Ivarocycline. It's a ivarocycline, excellent. And iravocycline, then omadacycline we read, omadacycline. Then what are the other one we read? Omadacycline we read. Is there any other cycline we read? Is there any other cycline we read? No, that's all. Okay, so these are the cyclines which are there under under your tetracycline group of drugs. So these are the cyclines which you have to remember under the your tetracycline group of drugs. So at least you have to remember this, if not everything, at least, because these are the drugs which are commonly used. So people will be, examiner will be expecting only these drugs. Okay, now how to present? Now the final 2 minutes you are going to take for this tetracycline. How we are going to present this in the exam? You are going to start with tetracycline, any tetracycline, let it be your doxycycline, let it be your minocycline, let it be your any cycline. If they are going to ask you, start with number 1, what is going to be the drug? What is going to be the mechanism of action? What is going to be the usage? You know that any tetracycline is used all these 7 places, but except your minocycline restricted to your leprosy. Okay, your doxycycline restricted to other drugs. Like that, you have some extra points about each individual drug. Instead of mugging up for all the drugs, all the side effects, all the clinical usage, just mug up or memorize the uses of one group of family and importance of individual drugs. Like Tetracycline, you know, that is used in the restriction of when there is going to be a resistance to doxycycline, use Tetracycline. So when the Tetracycline is asked in the exam, write that point extra. Other points you're going to just copy it down, whatever you read. Okay, even if they're going to ask you iravacycline, you don't know what is iravacycline, you haven't read about iravacycline or omadacycline, but you know what is the mechanism of action, where all the tetracyclines are used, what are the common side effects of tetracycline, you can just write that. Is it clear? If you have any doubt, you can post now in the tetracycline. If not, I will move towards the next point, that is going to be your macrolides. Remember, in macrolides, you're going to have three important group of drugs. What we are going to do is just compare this three important group of drugs. Now, can you tell me what is going to be the mechanism of action of macrolides? Can you tell me what is the mechanism of action of macrolides? Can you tell me what is the mechanism of action of macrolides? Mechanism of action, we read in the first starting of the day, we read about the mechanism of action of macrolides, whether they are going to inhibit the 30S or 50S ribosomal subunit, at which place they are going to inhibit your 50S ribosomal subunit. Can you recall and tell me your macrolides? Exactly, it is a 50S ribosomal subunit because it comes under the small ls. Okay, so what exactly it is going to do? In 50S, what it is going to do? It is going to inhibit your movement. If it is going to inhibit your movement, which enzyme it is inhibiting? What is going to be the enzyme or thing which is going to be inhibited by your macrolides? It is going to inhibit the translocase. Exactly. Translocation is inhibited by two drugs. Apart from your macrolide, it is also going to be this translocate is also going to be inhibited by ML. L stands for lincosamide. Even your lincosamide, macrolide, both are going to inhibit. Clear, right? Now, moving on to talk about the three important macrolides in your life. That is going to be erythromycin, clarithromycin, azithromycin. So, if you see, commonly we are writing AZ 500, AZ 500, AZ 500. This is a very common thing which many general practitioners, even you will be taking in the over-the-counter drug whenever you are going to have a throat pain or whenever you are going to have a pharyngitis. Correct. So, you have to know what are the side effects of it, where all you are going to use these drugs. See, first started is going to be a erythromycin. Erythromycin is the first drug. Remember, all the drugs will be having a mycin ending. So, how cycline is going to be the last letter for your macrolides. Here you go, sorry, for your previous one, that is going to be your tetracycline. Here you are going to have macrolides which ends by the letter MYCIN, mycin. So, erythromycin, clarithromycin, azithromycin. Okay, so they are going to be mainly acting on the gram-positive organisms. So, all your erythromycin, clarithromycin, azithromycin, mainly they are going to act in the gram-positive organism. They are not acting in the gram-negative organism. That is why, in case of any UTI infection, okay, or any problem in the lower stools, passage of stools, diarrhea, angala, we are not going to give azithromycin. Azithromycin is mainly given the URTI. Why? Because URTI is the most commonly caused by your gram-positive organism. Now, what are the erythromycin was the first drug. They are going to act on the gram-positive organism, and it is a drug of choice in case of number one. It is going to be a drug of choice in case of pertussis and diphtheria. It is going to be the drug of choice in pertussis. It is going to be the drug of choice in case of diphtheria. What is the treatment of diphtheria? You are going to give Penicillin G or erythromycin. So it is going to be given with Penicillin G or erythromycin. For carriers, especially, we go for erythromycin. Clear, right? That's all about your erythromycin. மீதி எல்லாமே நீங்க எழுதுற ஸ்டோரிஸ் தான். இதுதான் keyword. So erythromycin, they are going to act on the gram-positive organism. You know the mechanism of action, right? The mechanism of action. Then we will discuss about the side effects later. You are going to add on with that. So, but what you are going to remember very particular to erythromycin, they are still the drug of choice in pertussis. They are still the drug of choice in case of your diphtheria, especially diphtheria. First preference is going to be your Penicillin G. Then second preference is going to be your erythromycin. But if it is a carrier, then you are going to give erythromycin. Next, coming to the second one, that is going to be a clarithromycin. Clarithromycin is going to have an increased activity on the gram-positive organism again, but this is going to have much more effect than your erythromycin. This is used in case of H. pylori eradication. Okay, in case of leprosy, in case of atypical TB, in case of atypical TB. Now, what is this atypical TB? They are nothing but your Mycobacterium avium complex. So this Mycobacterium avium complex, they are going to be having drugs that are going to be used in the treatment and prophylaxis. For treatment, remember RAS, RAS. Okay, so you're going to remember REC, Regional Engineering College, like that you remember. So MAC infection, you're going to have this REC as treatment. So what is REC? R stands for rifabutin, E stands for ethambutol, and C stands for clarithromycin. So whenever I ask you here on about the atypical Mycobacterium tuberculosis or atypical AVM Mycobacterial AVM complex, what is the treatment in Keta? What should come to your mind? REC. What is REC? Rifabutin. A stands for your E stands for your ethambutol, and C stands for your clarithromycin. And what are the prophylaxis drug? Again, clarithromycin daily or azithromycin once a week. Clarithromycin daily or azithromycin once a week is going to be given in case of prophylaxis of your mycobacterial avian complex. Now coming towards your azithromycin. Azithromycin is given in all your URTI infection, atypical bacteria, atypical pneumonias, where you cannot suspect what is the common cause of the infection, because when I'm going to sit in the OPD, I have to give a broad spectrum, I have to give a drug that is going to inhibit all your gram-positive organisms. So that is the reason I personally use azithromycin. Az500 is a drug which we are commonly giving. So this is going to be inhibiting the atypical actions on the atypical bacteria like your mycoplasma, like your Campylobacter jejuni, cholera, chlamydia, cancroid, gonorrhea. Then even we are giving in case of your atypical pneumonia and your Legionella pneumonia. So this is, since this is going to inhibit your atypical bacteria, there are some atypical bacteria that are also going to be a cause of gonorrhea, sexual transmitted disease, etc. So even that case, what we are giving, we are going to give azithromycin. Hope you are clear with erythro, clarithro, azithro. Do you have any doubt in this? Now, coming to the fourth one, spiramycin. What is spiramycin? Spiramycin is given in only one condition, toxoplasmosis in pregnancy. So when there is a toxoplasmosis occurring in pregnancy, you are going to give spiramycin. And remember, we have some immunosuppressants like your tacrolimus, everolimus. So we have some drugs like tacrolimus, everolimus, all these. So they are going to be structurally similar to macrolide. Okay, therefore I'm just giving you an introduction here. So in the immunosuppressants, when I'm going to discuss, I will talk about the tacrolimus, everolimus, etc. So that time you should remember that what is the structural similarity? Tetracyclines is going to be having a structural similarity. They are going to be the immunosuppressants. Hope you are all clear. Now we have discussed what are the three important macrolides, what are the actions, uses of the three important macrolides. Coming to the side effects, as I every time tell you, side effects you are going to remember as a bulk. You are going to remember for all the drugs together, so that you will never forget. If you have any specialized side effect or any particular drug, I will tell you. Otherwise, remember it as a group of drugs. So if you're going to ask me the group of drugs, number one, what is going to be the side effect for your macrolides? Number one, it is a motilin receptor stimulator. Since it is going to stimulating your motilin, it is going to cause diarrhea. Okay, motilins are going to be the one that is going to be aligned along your GIT. When this receptor is going to be stimulated, what happens? That is going to cause diarrhea. So this is used in case of any gastroparesis or paralytic ileus. Though in paralytic ileus or gastroparesis, there is no infection that is going to be causing. But even then we are going to give macrolides. Why? Because we are utilizing the other action of macrolides. That is going to be, it is going to cause gastrin motilin receptor stimulator. Therefore, it is used as a drug of choice in case of what? It is what are the non-infectious uses of your macrolides? If they are going to ask you, the answer is going to be number one, gastroparesis. Number two, paralytic ileus. It is also going to cause a increase in the QT interval. Okay, remember, macrolides are going to cause a rise in the QT interval. Your erythromycin and your azithromycin. Cholestasis. So remember, erythromycin is going to get converted into erythroestolate. Erythroestolate. This erythroestolate la irukkoodiya and estolate அப்படிங்கற அந்த part, they will be forming a stones, and they will be causing a retaining of your bile in your gallbladder. That is why it is going to lead to cholestasis and cholelithiasis. Both will be formed, cholestasis and cholelithiasis. Okay, wow. Sir, how far, what topics are covered? No, for so far we have covered only, we have started with your antimicrobials. I have explained about the protein synthesis inhibitors. Then I have given you the tetracycline is covered, and we have covered macrolides. We are just covering now. We are in the edge of completing macrolides. Okay, Kavita. So now we are going to move towards the first one. What are the side effects we are seeing? Number one, it is going to be a motilin receptor stimulator. Number two, QT interval prolongation. Number three, cholestasis and cholelithiasis. And number four is going to be your deafness or tinnitus. Deafness, tinnitus is caused by your erythromycin specific. Okay, erythromycin specifica, it will cause us deafness, tinnitus. Cholestasis is specifically caused by your erythromycin. QT interval, azithro, erythro, rendume, motilin receptor stimulators, all your macrolides. Okay, now we have something called as your theophylline, statin, warfarin. See, remember, theophylline, warfarin, statin, all these drugs are going to be metabolized by the enzyme cytochrome P3A4. Okay, cytochrome P3A4 is a drug that is going to be metabolizing your theophylline, statin, and warfarin. If you are going to give erythromycin or clarithromycin, this is called as drug interaction. When you are going to give erythromycin or clarithromycin along with your or any macrolides, along with your warfarin, theophylline, or statin, what happens? They will be causing decreased metabolism of theophylline, statin, warfarin. This will lead to the toxicity by your theophylline, statin, and warfarin. So theophylline toxicity and warfarin toxicity is caused by erythromycin, clarithromycin giving along with it. So, okay, so this is called as drug interaction. In your Tripathi, you will have a heading called as drug interaction where we will be discussing this. With this, we are completing the second group of drug, that is going to be your macrolides. So if you see in the small LC, we have already covered tetracycline, which is a 30s ribosomal subunit. In your 50s ribosomal subunit, you have around 6 drugs. In that 6 drugs, we have completed macrolides, and now we are moving towards the lincosamide. You know that macrocide as well as lincosamide, both are going to cause translocase inhibitor. That is what I was telling you. So it has a very similar action. Macrolides and lincosamide is going to have very similar action. In lincosamide, you're going to remember only one drug that is also going to end with mycin, like your erythromycin, clarithromycin. This is also going to end with mycin, that is clindamycin. Okay, now you will be able to understand, right? Yeah, erythromycin, azithromycin, clarithromycin, as well as clindamycin, all are going to have very similar role, that is going to inhibit your translocase enzyme in the 50s ribosomal subunit. Even then, we are going to differentiate this clindamycin into separate family. Why do we differentiate into a separate family? Because the structurally they are going to be different. So that is called as your lincosamide. So where all your clindamycin is going to act. So we all know that your azithro, clarithro, erythro is going to act on gram-positive organism as well as your atypical organism. But this clindamycin is going to act in the anaerobic bacteria and protozoa. It is going to act on the anaerobic bacteria and protozoa. So what is the usage? Number one, it is going to be used in the gram-positive organism, that is going to be your staphylococcal. So remember, whenever there is going to be any methicillin-resistant staphylococcal aureus, so we will discuss about this penicillin, methicillin and all later, because that is a very lengthy, that's why I started with protein synthesis inhibitor. Remember, methicillin is going to be methicillin gets resistant in certain staphylococcal aureus. In the resistant case of staphylococcal aureus, you go for this clindamycin. So this is a very important drug of choice in case of toxic shock syndrome. But if you ask me what is the ultimate drug of choice in case of toxic shock syndrome with the MRSA pattern, the answer is going to be vancomycin and not clindamycin. Vancomycin is going to be the drug of choice if there is going to be a methicillin resistant staphylococcal aureus. Hope you are clear with that. So toxic shock syndrome, what is the drug of choice in case of methicillin resistant staphylococcal aureus? It is going to be your vancomycin plus clindamycin. And second thing we told us, anaerobic infection. In anaerobic infection, where you are going to give, see, anaerobic infection, நம்ம ரெண்டா பிரிக்கலாம். ஒன்னு diaphragmக்கு மேல, இன்னொன்னு diaphragmக்கு கீழ. Can you tell me what are the infection possible above the diaphragm? Let me see who is going to tell. Above the diaphragm, what infection is most commonly occurring? Most commonly occurring infection above which organ affects above your diaphragm? Above your diaphragm, which organ affects? Can you tell me in the chat box? Lungs, very good. So lung infections, okay, and your dental infections. Lung infections and dental infections are the drug which is are the organism or the organs which is going to be affected above your diaphragm. What is the organism that is going to be occurring above your diaphragm in case of anaerobic organism? So we told anaerobic bacteria or broad group கொடுத்திருக்கோம். அதில் above the diaphragm you have your lungs, you have your dental area. So இது ரெண்டுத்தையும் இன்ஃபெக்ட் பண்ற ட்ரக் பேர் என்னன்னா Peptostreptococcus. Peptostreptococcus. Write it down. Peptostreptococcus is okay. It is going to be the organism that is going to be occurring above your anaerobic organism that is going to be occurring above your diaphragm. Okay. So what is the drug of choice here? The drug of choice is going to be your clindamycin. So clindamycin is going to be the drug of choice in case of any lung or dental infection caused by your Peptostreptococcus. Peptostreptococcus. Okay. Then comes your beta-lactam. What is the other alternate for your okay clindamycin? That is going to be a beta-lactam group of drugs. So beta-lactam group of drugs then afterwards I will discuss. Okay, now remember there is one important point you need to understand, that is this clindamycin has a poor blood-brain barrier penetrance. This clindamycin cannot penetrate your blood-brain barrier and enter into your brain. Okay, they cannot go into your blood-brain barrier and they cannot go into your brain. That is why I told lungs, I told dental infection, but I haven't told CNS abscess. In CNS abscess, clindamycin does not have any role. In CNS abscess, clindamycin does not have any role. Then what will you give in the CNS abscess? In CNS abscess, the drug you give is going to be your metronidazole. The drug you are going to give in your CNS abscess is going to be your metronidazole. Clear, right? This is going to be all about above the diaphragm. Now coming to below your diaphragm. Below your diaphragm, you are going to have an intra-abdominal infection or pelvic infection. Remember, intra-abdominal infection, pelvic infections are most commonly caused by bacterioids. And the Peptostreptococcus, above the diaphragm it's Peptostreptococcus, below the diaphragm it is going to be your bacterioids. So what is going to be the drug of choice? Drug of choice in category, it's not clindamycin. Drug of choice is going to be your metronidazole. But if you see above the diaphragm, drug of choice is going to be your clindamycin. Below your diaphragm, the drug of choice is going to be your metronidazole. But you can also go for the clindamycin. Clear, right? Now clindamycin order two important uses பார்த்தோம். Number one, MRSA group of drugs. Number two, anaerobic infection. Number three, in case of acne. Do you all remember? So most of them, most of the boys, you would have got acne problem in your teenage. So that time what happens? You go to the doctor, dermatologist, and dermatologist will be prescribing you with a Clinda gel, 1% Clinda gel. That is nothing but your clindamycin. It is going to act against the Propionibacterium acne. That is going to act against your Propionibacterium acne. Now coming to the fourth one, that is going to be a protozoal infection. So it is going to act against malaria and babesiosis. Malaria, though it is not a drug of choice. Though malaria, it is not drug of choice because you will be using quinines. Okay, you will be using quinines and okay, artemisinin, arteether, quinines, okay, chloroquinone, okay, other you will be using all these drugs. But clindamycin can be used as a other alternative drug. Coming to the babesiosis, you have a drug of choice. So your babesiosis or a drug of choice, either you can go for azithro plus atoroquinone or you can go for quinine plus clindamycin. Since the first line drug of choice, one of the regimen which we are following is your quinine plus your clindamycin. So the drug of choice in babesiosis is going to be your clindamycin. Okay, now can you tell me what are the four important uses? Can you put in the chat box? What are the four important uses one by one without any order? Can you put? Without any specific order, can you put what are going to be the uses of your clindamycin? What are the uses of clindamycin? Number one, what are the uses of clindamycin? MRSA, excellent. Acne, excellent. Third one, lung infection, excellent. What is the organism in the lung infection? What is the organism in the lung infection, Kavita? What is the organism in the lung infection and your dental infection? Organism in your lung infection and your dental infection? What is the organism that is present below the diaphragm? Can you tell me? Organism present below the diaphragm. Can you guys tell me? If I'm audible, yes, it's a bacterioids. So bacterioids, they are going to be present in case of bacterioids. It is going to be present in case of any pelvic or intra-abdominal infection. So we have completed, and last one is protozoa. So which protozoa is going to get affected? In which protozoa you are going to give it as a drug of choice? Clindamycin is given as a drug of choice in which protozoa? In which protozoa you are going to give clindamycin as a drug of choice? Malaria, number one, excellent, but it is not given as a drug of choice. It is given as what? It is given as an alternate to your quinine. Along with quinine, you are giving clindamycin. But which one? Excellent, babesiosis. In babesiosis, along with what drug you will give your clindamycin? In babesiosis, what is the drug you are going to add on along with clindamycin, which is going to be the drug of choice? So you have two drugs in your clindamycin. What are the, one is your, so in your babesiosis, one is your clindamycin. Can you tell me the other one? Can you tell me the other one? Can you tell me the other one? Come on, you all know. You all know the answer. It is going to be your quinine. So we are going to use quinine along with your clindamycin in your babesiosis. Hope you are clear with this. Now we are going to move towards the side effects of your clindamycin. Remember, your clindamycin is going to cause a neuromuscular conduction blocker. So your clindamycin will be acting as a neuromuscular conduction blocker. So since it is going to act as a neuromuscular conductor blocker or conduction blocker, so it is going to worsen the symptom. Remember, that will be causing worsening of symptom that leads to myasthenia gravis. Okay, that leads to myasthenia gravis. And very important. I'm just giving you 5 to 6 stars here. You will be most commonly asked with the pseudomonas or your pseudomembranous colitis or Clostridium difficile colitis in your either in your exam or in your viva, because this is recently updated by WHO. I want you all to remember this. See, in the case of eating antibiotics. Okay, so now what happens? Over the counter, many people are buying and eating antibiotics. So when they are going to have a repeated URTI, what they will do? They will go to the pharmacy and they will ask for the antibiotic. And the pharmacy person also, which drug has highest margin, he will give that drug for the patient. Now, that drug is going to be your third generation cephalosporin. When the third generation cephalosporin is constantly going to be taken up by the patient repeatedly, what happens? That leads to this disease called as pseudomembranous colitis. Pseudomembranous colitis is nothing but you have some inherently in your GAT, you have a flora. That flora will be preventing the Clostridium difficile to stay and the Clostridium difficile to invade your GAT mucosa. Now what happens? When you're going to repeatedly take your third generation cephalosporin ampicillin, that is going to destroy your gut flora. That will give a space for your pseudomembranous colitis or your Clostridium difficile to come and sit there, and that leads to inflammation of entire colon. That is going to cause a severe diarrhea, profuse diarrhea. So patient now comes to you with a severe or profuse diarrhea. One of the most worsening problem in these patients are you cannot go for any other drugs. Okay, clindamycin போக முடியாது because that is one of the cause. Third generation cephalosporin போக முடியாது. Ampicillin you cannot give. Cefixime you cannot give. So you cannot give any drug for this. So the only drug that you can give is going to be your vancomycin. Okay, followed by your fidaxomicin. But now, initially what happens, we're going to see, I don't know whether in your textbook also it is updated. Oral vancomycin was initially given as a drug of choice in case of your pseudomembranous colitis or your Clostridium difficile colitis. But this year, what happened? Okay, in 2023, around January or February, there is a new drug which is going to be made into made into the pharmacological use. That is going to be your fidaxomicin. If you won't believe, this was a question asked in the recent INICET 2023 November AIMS or entrance exam. The question asked was, what is the drug of choice in case of Clostridium difficile colitis? Why? Because they are asking this question because this is a new drug which is going to be there. So in same way, you can also be asked in your viva or you can also be asked in your theory MCQ also. Remember, the drug of choice in case of pseudomembranous colitis or your Clostridium difficile is going to be your fidaxomicin. Now you know fidaxomicin and your vancomycin, they are going to be the drug of choice. And what is the cause? The cause is going to be your third generation cephalosporin, ampicillin, and clindamycin. The other alternate drug which you can give in these patients are metronidazole and rifaximin. Okay, metronidazole and rifaximin can also be given. What is this fidaxomicin? Write it down here itself. Fidaxomicin are RNA polymerase inhibitor. What they are going to do? They are going to inhibit in the nucleus. They are going to be a nuclear inhibitor. So RNA polymerase inhibitor is going to be of fidaxomicin. They will be preventing the relapse of pseudomembranous colitis. So what happens? Even if it is going to be a relapse, again you are going to give a prolonged fidaxomicin or vancomycin, or you can go for a bezlotoxumab. So this is going to be an antibody against the toxin B of your Clostridium difficile. Okay, so anganga we will try to insert some random questions also, so that it won't be a burden while reading your book. Okay, so please try to follow the way I am just trying to move, because antimicrobial is a very big chapter, so it will be very confusing. So try to interrelate and read. இது மட்டும் படிச்சாலே போதும், you can get a you can get a distinction or honors or whatever. Okay, this is what required from your Tripathi textbook, and that's what I'm just extracting the content, prepared and notes and explaining you. Okay, now we have completed this we have completed this lincosamide. Now, what are the drugs which we have completed? We have completed tetracycline, we have completed macrolides, we have completed lincosamide. What is the fourth group of drug? A very important group, that is going to be a linezolid. Linezolid is also called as oxazolidinone. Okay, oxazolidinone. Oxazolidinone. It is going to be the family name. What it is going to do, which we have already seen, it is going to be a inhibitor of. It is going to be a inhibitor of what? Initiation inhibitor. So they are going to be inhibiting the initiation. Who is initiation inhibitor in your 30S ribosomal subunit? Can someone put in the chat box which drug is going to act as a 30S ribosomal initiation inhibitor? Let's see who is going to remember and tell me. Let's see who is going to remember and tell me. Which is going to act as an initiation. Excellent, aminoglycoside. So aminoglycoside is in the 30S, linezolid is in the 50S. Just remember, initiation inhibitor of 50S ribosomal subunit. What it is going to do? It is going to act on the gram-positive bacteria, especially in the resistant organism. Especially in the resistant organism of gram-positive bacteria, this linezolid is going to act. Where all? In your methicillin resistant staphylococcal aureus, in vancomycin resistant staphylococcal aureus. So, highest drug na enna sonna vancomycin. ஒருவேளை vancomycin, if it is going to be resistant, in that case you can go for linezolid. In that case you can go for linezolid. Linezolid has both oral as well as IV administration. Okay, oral is going to be safe in renal failure also. What is the drug of choice? 600 mg linezolid BD oral. You are going to give 600 mg linezolid oral BD. You are going to give. Okay, so you have to remember, this is not used commonly. This is not used commonly in the OP setting. We are going to use linezolid in a ICU setting, where there is going to be a methicillin or vancomycin resistant staphylococcal aureus, enterococcus, all those species. We are going to use linezolid. What is the mechanism of action of linezolid? They are going to inhibit the initiation of 50S ribosomal subunit. Clear, right? Now coming to the side effects. What are going to be the side effects? They are going to inhibit the bone marrow suppression, bone marrow production. So, bone marrow suppression panna, very important thing what you have to do. Whenever you are going to administer a patient with linezolid, the first and foremost important thing you are going to do in that patient is going to be, you are going to check for the total count. You are going to check for the neutrophil. You are going to check for the platelet count. Okay, we are going to check for the platelet count and your neutrophil count. Okay, comparatively platelet count more commonly they are going to be decreased. Thrombocytopenia can occur more commonly than your neutropenia. Neutropenia or thrombocytopenia more commonly occur. So platelet and your WBC count has to be monitored. Second thing is going to be your mitochondrial damage. So this is going to cause a mitochondrial damage or toxicity. You all know that in mitochondria, okay, from your there is going to be a very important thing. What? So glycolysis and Krebs cycle. Krebs cycle occurs in your mitochondria. So everything is interrelated, guys. It is not nothing is separate. So in biochemistry, whatever you read, you are going to just recollect here. So you know that glycolysis occurs in your cytoplasm. Mitochondria and the Krebs cycle is going to occur. Now just recall and tell me, wait, your mitochondria is not functioning. Mitochondria is damaged. What happens? From your Krebs cycle, the pyruvate is not going to convert into a malate, and they are not going to convert to oxaloacetate and continue in your Krebs cycle. Because of that, what happens? The pyruvate is going to be diverted to the lactic acid synthesis. Because of that, there is going to be a lactic acidosis. Number one. Number two, what happens? Whenever there is going to be a lactic acidosis, okay, whenever there is going to be lactic acidosis, whenever there is going to be any there is no availability of ATP, because of unavailability of ATP, and because of unavailability of conversion of your all your products of your TCA cycle, what happens is there is going to be a damage to the nerves. What nerves damages? Especially all your peripheral nerves gets damaged. That's called as your peripheral neuropathy. So whenever you're going to give linezolid, the side effect is going to be your lactic acidosis. Number two is going to be your peripheral neuropathy, and third one is going to be your optic neuritis. Your nerves are going to be affected. Optic neuritis. You all know what is the mechanism of action. Can you tell me what is the mechanism of action of your linezolid? They are going to inhibit the initiation of 30S ribosomal, 50S ribosomal subunit. So because of that, what happens is, it is also going to lead to, can you tell me what is cheese reaction? Can someone tell me what is cheese reaction? Let me see who knows this. Cheese reaction. Can you tell me what is cheese reaction? It is going to inhibit cheese reaction. Can you tell me? You have some enzyme called as monoamine oxidase. Note it down if you don't know. So what is a cheese reaction? It is nothing but a monoamine oxidase. So what happens is this monoamine oxidase is also a mitochondrial enzyme. Whenever monoamine oxidase is going to be inhibited or decrease in the action, that is going to lead to cheese reaction. What are the drugs which is causing cheese reaction? Can you tell me what are the drugs that are going to cause cheese reaction? The drugs that are going to cause cheese reaction. Do you know? Anyone? What is the drug that is going to cause cheese reaction? Any drug that is going to be having tyramine. Any drug that is going to be having tyramine. Okay, so tyramines whenever you are going to take any food rich in tyramine, when you are going to give a MAO inhibitors, what happens? They will be preventing your tyramine converting into tyramine getting converted into a norepinephrine. So norepinephrine convert agadu. Okay, tyramine gets converted to norepinephrine. Appa and the tyramine inhibit pandrathu yaru? Okay, MAO. Appa MAO illana enna more amount of tyramine gets converted into norepinephrine. When more amount of tyramine gets converted to norepinephrine, there is going to be increase in the contraction of your smooth muscles of your blood vessel. That is going to be your vascular constriction. So that leads to vessel constriction, leading to hypertensive crisis. That is called as your cheese reaction or your serotonin syndrome. That is going to be called as your cheese reaction or called as your serotonin syndrome. What is going to be the drug of choice? Do you know what is the drug of choice if you are going to have a cheese reaction? What is the drug of choice when you are going to have a cheese reaction? Do you know? The answer is phentolamine. You have to give phentolamine in the patient who is going to have a cheese reaction. You are going to give phentolamine who is going to have a cheese reaction. Are you all clear with? Now, can you tell me what are the MAO inhibitors? Can you tell me what are the MAO inhibitor drugs? If you know, can you tell me what are the MAO inhibitors you know? So you have this silagilin, rasagilin, okay, all this gilin group of drugs. Saligilin, rasagilin, okay, all these gilin group of drugs are going to be MAO inhibitors. And along with it, you're going to add another drug today. What is the another drug you're going to add now? That is going to be a linezolid. Remember, your linezolid is also going to be causing cheese reaction. Hope I have cleared what is cheese reaction, what is linezolid, what is MAO inhibition, etc. Now coming to the fourth important problem. The fourth important problem you're going to have is, okay, so you're going to have the fourth important problem you're going to have is, I'll tell you, the fourth important problem you're going to have is the patient will also have a metabolic acidosis. At the end of the day, patient will have metabolic acidosis. So you also have to check what? You also have to check what is the test you do for checking the metabolic acidosis? Can you tell me? What is the test you do to check the metabolic acidosis? metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. In all these four things, what is the test you do? Arterial blood gas analysis, ABG. So you have to monitor the patient with ABG. So that's all about your linezolid. Now you have certain new linezolid that is going to be your TD-zolid, TED, tedizolid. What is tedizolid? Number one, they are safe with the renal failure patient. Very similar to that of your linezolid. Number two, they have less bone marrow suppression. Here the main problem which we had is a bone marrow suppression. This has a less bone marrow suppression. And number three is going to be your T off is going to be longer for tedizolid. Therefore, if you are going to give linezolid, you have to give BD. Whereas, 600 mg BD is your linezolid. Whereas tedizolid, you are going to give only, can you tell me what is the dosage? You're going to give only once a day. That's all. Now we have completed your small SMA, LL, S. Okay. In that we have completed linezolid. We have completed linezolid and we have completed macrolides. We have completed macrolides. We have completed lincosamide. We have completed lincosamide. So what are the remaining one? Can you tell me? Streptogramin is remaining. Lipopeptides is remaining, chloramphenicol is remaining. Lipopeptides, chloramphenicol, and your streptogramin is remaining. Let's go with the first one, that is your streptogramin. So what is streptogramin? Streptogramin are going to be a synergetic combination of quinipristine and your delphopristine. So it is going to have a two important combination. One is your quinipristine and other is going to be a delphopristine. So quinipristine, delphopristine or a combination, the streptogramin. Can you repeat along with me in your mind? Number one, your quinipristine. Number two, you're going to have delphopristine. Quinipristine and delphopristine, or the combination is going to be your streptogramin. Okay, when there is going to be action of your quinipristine and your delphopristine separately, they are going to cause bacteriostatic action. Whereas when you're going to combine the quinipristine with deflopristine and you're going to get a streptogramin, they are going to cause bactericidal. They are going to be bactericidal in nature. Hope you can understand. Okay, so remember this is given in case of a resistant gram-positive bacteria. So what is the route of administration? Route of administration is going to be by IV route. And what is going to be about the renal failure? Yes, you can give this in renal failure. Now coming to the two important group which is going to be present in your streptogramin. That is going to be your quinipristine and delphopristine. Quinipristine and delphopristine, these are the two group of drugs that is going to be present in your streptogramin. So let's see one by one. The first one is going to be your quinipristine. Remember, quinipristine is going to be just 30%. Okay, they are going to cause inhibition of chain elongation. Whereas 70% it is going to be causing daflopristine. So you have quinipristine and daflopristine. Quinipristine 30% causes inhibition of chain elongation. The second one is going to be a daflopristine. What do daflopristine do? Daflopristine is going to bind with the 50S ribosomal subunit. Okay, and it is going to cause what? It is going to cause conformational change. It is going to cause conformational change, and what happens? It is going to cause conformational change and makes your quinipristine bind. Okay, wow. So inge yaar appa vandu going to do a role. Your quinipristine is going to do a role. Quinipristine is the one that is going to do a role, but what does your daflopristine do? Daflopristine helps in the conformational changes and binding of quinipristine into your 50S ribosomal unit. That is the action. So எந்த இடத்துல bind பண்ணனும்னா, it is going to sit on the elongator. They are going to be different. So you are going to have your different types of cell in your ribosomal subunit. You are going to have promoter site. You are going to have elongator site. So what it does is, it is going to sit on the elongator site. So it is going to prevent elongation. Clear, right? So what are the side effects? The number one side effect is arthralgia. The only side effect you have in streptogramin is arthralgia. In which drug you are going to give? In which infection you are going to give? You are going to give in the resistant cases. So you are going to give this in the case of resistance. So whenever there is a resistance, what you will do? You will give this. Now coming to the aminoglycoside. Okay, what is the mechanism of action of aminoglycoside? Can you tell me what is the mechanism of action of aminoglycoside? What is the mechanism of action of aminoglycoside? Can someone put in the chat box? What is the mechanism of action of aminoglycoside? What is the mechanism of action of aminoglycoside? Can you put in the chat box? Very good. Initiation inhibition of the 30S ribosomal unit. So, on the initiator, in your 30S ribosomal unit, it is going to be at 16S. So, it is going to be present at 16S. Whereas, in your 50S ribosomal subunit, it is present as 23S. There's just additional information. If you want, you can write it down. Otherwise, just remember initiation inhibitor of your 50S, 30S ribosomal subunit. Okay, it is going to prevent the initiation. About what it is going to do? It is going to provide, it is going to be a bacteriocidal in nature. And this aminoglycoside, they are going to be bacteriocidal in nature. What is the mechanism of action? They are going to be a gram-negative aerobes. Okay, they are going to inhibit the gram-negative aerobes. They don't have any action on anaerobic organism. Can you tell me which drug we read till now has action on anaerobic organism? Can you tell me which group of drugs has anaerobic organism action? Which group of drug add anaerobic against the anaerobic organism? Which group of drug add? Can you tell me? What is the group of drug that is going to be acting against anaerobic organism? Lincosamide. Excellent. What is the example of lincosamide? Clindamycin. Now coming to the action. So this does not have any action on anaerobic organism, and they also have resistance in the streptococcus and streptomycin and gentamicin. So remember, in aminoglycoside, you're going to have your streptomycin, gentamicin class. It is going to be having a resistance. Okay, why? Because gentamicin and your streptomycin are going to be inactivated by bacterial enzymes. But remember, you can go for amikacin. Amikacin cannot be inhibited by this bacterial enzyme. So therefore, you can have amikacin. So now we have seen 3 drugs under this and aminoglycoside. What are the 3 drugs we have read till now? Gentamicin, streptomycin, amikacin. So these are the 3 drugs you're going to remember under the heading of aminoglycoside. What is going to be the mechanism of action? That is going to inhibit the initiation of 30S ribosomal complex. So what are going to be the uses? So it is used in case of gram-negative aerobes. Now, this has a increased water solubility. Okay, this has an increased water solubility. They are not having a lipid solubility. Because of that, they have a poor CNS penetration. And since whenever I told you, right, whenever there is an increased water solubility, they will be excreted in the urine. Therefore, what happens? It is not safe in the renal failure patient. So, your you're going to have a problem in your streptomycin, gentamicin, amikacin. Streptomycin, gentamicin, amikacin kudukadhula enna problem? They are going to go by the water solubility. Whenever there is a water solubility, they are going to be very problematic in the renal failure patient. Now coming towards the side effects. So number 1, ototoxicity. So why we are avoiding streptomycin nowadays? The reason is very simple. They are causing ototoxicity. Okay. So therefore, you should never combine with furosemide. You know that there is a diuretic called as furosemide. This furosemide is also going to cause ototoxicity. Therefore, you are not combining with furosemide your aminoglycosides. Now coming towards the toxicity, they are going to cause irreversible damage to the ear. They never so you should never combine with your furosemide. So they are going to cause problem in your cochlea as well as your vestibule. So cochlear defect என்ன பண்ணும்னா deafness cause பண்ணும், tinnitus cause பண்ணும், loss of high frequency sound. This is maximum with amikacin and kanamycin. All your high aminoglycoside. So high end aminoglycoside எல்லாத்துலயுமே தானிய erythroma in your streptomycin and gentamicin, they are going to have problem in your amikacin and your kanamycin. And vestibular defect is very high in case of streptomycin. Therefore, aminoglycoside per se, we are not using nowadays more. Okay, and remember, it is going to affect both cochlea as well as your vestibule. Okay, so that is going to be also your tobramycin. So tobramycin is going to affect both cochlea as well as vestibule. So now what are the drugs? Now we have seen 5 drugs under the heading of your aminoglycoside. What are those 5 drugs? Number 1, streptomycin. Number 2, gentamicin. Number 3, amikacin. Number 4, we read about the kanamycin. Number 5, tobramycin. Clear, right? These are the 5 group of drugs. Sixth drug is going to be in this is neomycin. Remember, N stands for nephrotoxic. N stands for nephrotoxic. So remember, neomycin is a maximum nephrotoxic group of drug. Okay, among the aminoglycoside, your neomycin is going to be maximum nephrotoxic. N stands for N. Nephrotoxic stands for neomycin. You can remember like that. Minimum in the streptomycin. Minimum in the streptomycin. Clear, right? So now coming towards the third one, they are going to block your neuromuscular conduction. So whenever the drug that is going to block your neuromuscular conduction will be worsening the myasthenia gravis. Can you tell me which is the other drug we saw today that is going to worsen your myasthenia gravis? Let me see who is going to answer. The other drug which we saw, which is going to worsen your myasthenia gravis. Which is going to worsen your myasthenia gravis. Can you tell me? The other drug which we saw today, worsening your myasthenia gravis. What is the other drug? Excellent, lincosamide. Excellent, lincosamide. Very good. So your lincosamide is also going to worsen. Okay, what are the other drugs? Any other drug we saw? No, that's all. Clindamycin. And now you're going to remember, whenever I'm going to tell what are the drugs that are going to worsen your myasthenia gravis. First drug which we read is clindamycin. Second drug today which we read is your aminoglycoside. Okay, what it does is, it is going to cause apnea. Okay, so what is going to be your drug of choice in case of apnea caused by myasthenia gravis? Your apnea caused by your aminoglycoside, it is going to be calcium gluconate. Okay, now coming to teratogenic effect. So this is going to cause fetal ear defect. It is going to cause fetal ear defect. Are you all clear with this? Next, which the TB drug is going to be, okay, which is going to be absolutely contraindicated in pregnancy? If you are going to ask me, that is going to be a streptomycin. Streptomycin, you all know that it is previously. Now in the current regimen of HRZE, S is taken out. S is not given. In case of even the initiation phase, your streptomycin is not given nowadays in the recent current guidelines of the National Tuberculosis Elimination Program. But previously we were using streptomycin as a first line of drug, which is a only injectable drug in your anti-TB drugs. Okay, this streptomycin is absolutely contraindicated in case of TB. Now, you all will ask me, right? So I have told you 2 drugs now. I have told you about the aminoglycoside. I have told you about the clindamycin. Now you will be asking me how to remember the drugs that are going to worsen the myasthenia gravis. I'll give you a mnemonic. Latest MCQ, augment BP. Latest MCQ, augment BP. So this is if you want, you can remember by this. Otherwise, you can just remember the names. That is your wish. But if you want, you can remember this mnemonic. Along with the mnemonic, also remember the drugs which are going to worsen your myasthenia gravis. L stands for local anesthesia, lignocaine. L stands for local anesthesia, lignocaine. MCQ, like M stands for your macrolide or clindamycin. Okay, macrolide or clindamycin. Okay, C stands for cure-like changes. Okay, it's going to be cure-like drugs like your muscle relaxants, and Q stands for quinine, A stands for aminoglycosides, B stands for botulinum toxin, and P stands for penicillamine. So now we have read about the drugs that are going to worsen the myasthenia gravis. The drugs that are going to worsen the myasthenia gravis. Can you tell me RCB plays cricket to lose match? இது எந்த நிமோனிக்கு எதுக்கு நம்ம யூஸ் பண்ணோம்? Can you tell me? RCB plays cricket to lose match. I'll be revising all your mnemonics which I am teaching also in between. Tetracycline. Can you tell me what R stands for? Just 5 seconds we will revise. What is R stands for? R stands for? R stands for? So this is tetracycline uses. In which all condition I am using. So RCB play cricket to lose match. R stands for rickettsia. Very good. C stands for? What does C stands for? C stands for? C stands for? Cholera. B stands for? What does B stands for? B stands for? Brucellosis. What does C? P stands for? Place. P stands for? P stands for? Single word. It is going to be standing for prophylaxis. What does your cricket C stands for? C in cricket stands for? C in cricket stands for? Chlamydia. Excellent. L stands for? What does L stands for? L stands for? L stands for? Leptospira. Okay, L stands for leptospira and M stands for minocycline, which is going to cause leprosy. You can remember leprosy also, but minocycline causes leprosy. Remember, like that loose match, leprosy caused by minocycline alone. Whereas under L, that is going to be your leptospira, you're going to give doxy. So minocycline, you're going to give leprosy, you're going to give minocycline. In your leptospirosis, you're going to give doxy, or what is the other drugs which you give in Weil's disease? Penicillin G and ceftriaxone. Now the second mnemonic today, which we have discussed, okay, is going to be your latest MCQ augment BP. That is for the drugs that are going to worsen your myasthenia gravis. L stands for local anesthesia, M stands for macrolide, C stands for clindamycin and Crurer drugs, Crurer-like drugs, and Q stands for quinine, and your A stands for your aminoglycoside, B stands for botulinum toxin, and P stands for penicillamine. Clear, right? So these are the drugs that are going to worsen the myasthenia gravis. Next is going to be your uses. You're going to remember the uses of your what drugs which you are going to be discussing now. What drugs we are discussing now? The drug is going to be your aminoglycoside. What is going to be the use of aminoglycoside? Number one, streptomycin. Remember, the first line of choice in streptomycin is going to be, okay, streptomycin used as first line of choice in TB previously, but not now. I told you, right? Previously in TB, we are using streptomycin as drug of choice. Next is a plague. Plague la streptomycin, gentamicin is used as a drug of choice. What is the other, where we use plague? Where are the other places where in the plague we are going to use other drugs? What are the drugs we use other than the streptomycin and your gentamicin in plague, which we discussed already? In plague, what is the other drug which we are going to use as a prophylaxis? What is the drug used as prophylaxis of plague? Treatment of plague is going to be a streptomycin, gentamicin. Prophylaxis of plague is going to be, what is going to be the drug used? Tetracycline. So remember, plague, what is going to be your treatment of choice? The treatment of choice is going to be your gentamicin or streptomycin. What is going to be the prophylaxis? That is going to be a tetracycline. Very good. Tetracycline is going to be a prophylaxis of plague. Tetracycline is used as a prophylaxis of plague. Clear, right? Next we are going to discuss about, next we are going to go into the Franciella. So in Franciella, okay, so remember Franciella, pertussis dampa erythro. Erythrola P stands for pertussis, not plague. Okay, Dinesh, plague is not a prophylaxis of plague. We are going to use only tetracycline and not erythromycin. Clear, right? So you're going to use gentamicin and streptomycin as a treatment of choice in plague. Next is a Franciella. Do you remember what is a disease caused by it? Tularemia or rabbit fever. Tularemia or rabbit fever. There also we can go for streptomycin as a first line of drug. But remember, the drug of choice in case of tularemia is going to be your Amphotericin B. Amphotericin B is used as a drug of choice in case of tularemia. Clear, right? Then you are going to have next one, brucellosis. Now tell me where all streptomycin is used. Streptomycin previously used in TB. Number one, we are going to use in case of plague as drug of choice. Number three is going to be a tularemia, and number four is going to be brucellosis. Okay, these four areas, first line of choice. It's not drug of choice. Only drug of choice is for plague. மற்ற எல்லாத்துக்குமே வந்து பாத்தீங்கன்னா streptomycin is used, but plague gentamicin and streptomycin, okay, both are used as drug of choice. Others all first line of drug we use streptomycin. Next is going to be a paromycin. I told you, right? Paromycin. Can you tell me paromycin where we read? Can you recall and tell me paromycin where we read? No, we haven't read yet. What is the drug we read very similar to this? That is your puromycin. Do you remember? Puromycin is a topical protein synthesis inhibitor. Mupirocin and puromycin. So this is going to be paromycin. It's not puromycin. So paromycin is used as a drug of choice in case of, okay, we are going to use as a drug of choice. Remember paromycin. Kala azarla we use paromycin, but again very similar to tularemia. The drug of choice here it's going to be Amphotericin B. The drug of choice which you use here is going to be Amphotericin B. Next is going to be your cryptosporidiosis. In cryptosporidiosis, there is a diarrhea which is the most commonly occurring in AIDS. The drug of choice is going to be nitrosoxanide. So Zoxanide, Zoxanide, but then we will be using Pharmacomycin also. Pharmacomycin also is used, but nitrozoxamide is a drug of choice in case of cryptosporidiosis causing diarrhea in AIDS. Next is a luminal amibicide. Luminal amibicide is going to be, again, Pharmacomycin can be used, but drug of choice is going to be diloxanide furoate. So diloxanide furoate is going to be a drug of choice. Okay, so that you have to remember. Okay, yes, exactly. Pharmacomycin is a topical. It's not topical. It is going to be oral route. Whereas paromycin, okay, puromycin, which we used, puromycin, that is going to be topical application. Paromycin is not topical application. It is going to be a oral. Okay, then comes the third one, neomycin. So first is streptomycin, gentamicin, we know. Then we have gone to paromycin. Now we are going to go to neomycin. Neomycin, oral drug. So, but the problem is going to be, this is going to be causing hepatic coma. Okay, it is going to be used in hepatic coma. Neomycin, it is going to be used in hepatic coma. Okay, but especially it is best with lactose. So along with lactose in hepatic coma, we will be giving neomycin. And finally, anti-pseudomonas. Can you tell me which drug is going to be not useful in pseudomonas? Can you tell me which drug is not useful in pseudomonas? I told you. Pseudomonas la use agada drug per enna. Which drug is not useful in pseudomonas? You can never give Pseudomonas one drug. What is the drug? What is the drug? Dimiclocycline. Okay, any tetracycline. Remember, any tetracycline you cannot give in case of your Pseudomonas. Okay, even your digicycline also cannot be given in case of Pseudomonas. So Pseudomonas, what is the drug you are going to give? So the drug given in case of Pseudomonas, remember tag. So what are the drugs? Togromycin, amikacin and gentamicin. Togromycin, amikacin, gentamicin. இதில் togromycin என்ன பண்ணும்னா, they are going to inhibit the togramase enzyme. Togramase enzyme. Okay, remember togramase enzyme. Togramase enzyme. Togramase is an enzyme that is present. This togramase enzyme, since this togramycin is inhibiting, this is killed in case of, so it is going to be helpful in killing your Pseudomonas. Pseudomonas typically occurs in cystic fibrosis. Why? Because there is a reduction in the secretions. Okay, there is a reduction in the secretions in all the glands. So because of that, what happens? There is going to be accumulation of Pseudomonas. So Pseudomonas infection occurring in cystic fibrosis. What is the drug of choice? Togramycin. So togramycin, what it does? It inhibits the togramase. You also have amikacin. You also have your gentamicin, which is given as drug of choice in anti-pseudomonas. Finally, you're going to have your enterococcal endocarditis. Enterococcal endocarditis is going to be a drug of choice in case of, okay, yeah, ampicillin and gentamicin is going to be the drug of choice in case of enterococcal endocarditis. So enterococcal endocarditis, enna pannona, ampicillin is going to act as a bacteriocidal. Gentamicin is also going to act as bacteriocidal. But the problem with why we are not giving ampicillin alone is, ampicillin, they can act only on the surface of the bacteria. Whereas gentamicin, they are going to go inside and they are going to inhibit the nuclear synthesis. It is going to inhibit your translation. That is why you are going to give a combination of ampicillin, gentamicin in case of enterococcal endocarditis. Are you all clear with all the protein synthesis inhibitor? Oh, I have covered all the protein synthesis inhibitor. Can you just recall what are the protein synthesis inhibitor? We have two types: 30S ribosomal subunit inhibitor, 50S ribosomal subunit inhibitor. In 30S, you add tetracycline aminoglycoside. In 50S, we add small LC. S stands for streptomycin, MA stands for macrolides, L stands for lincosamide, other L stands for linezolid, L stands for lifamulin and chloramphenicol. I told you about lifamulin and chloramphenicol already. They are going to be peptide bond inhibitor. Lifamulin is used in the community acquired pneumonia, and your chloramphenicol, what is the side effect? They are going to be causing bone marrow suppression, aplastic anemia, and gray baby syndrome. Okay, gray baby syndrome na enna? Blue-gray cyanosis and lethargic child. What happens? There can be a resistance to chloramphenicol. Why? Because of the acetyl transferase inactivation. Because of acetyltransferase inactivation, there is going to be a resistance. So with this, we are completing the entire protein synthesis inhibitor chapter. Are you all clear with this? If you have any doubt, you can post it in the chat box. I will be ready to answer. If not, we are going to move to the next one. That is going to be your cell wall synthesis inhibitor. So you know that the cell wall of any bacteria is going to be made up of peptidoglycan. Your peptidoglycan, there are two types of peptidoglycan. Number one, N-acetyl muramic acid. Number two, N-acetyl glucosamine. So what are the two amino acids which are present in your peptidoglycans which are present in the cell wall? Number one, it is N-acetyl muramic acid. Number two, N-acetyl glucosamine. So N-acetyl muramic acid, N-acetyl glucosamine. It is arranged like your D-ALA, D-ALA. ALA is nothing but your alanine. Okay, so in that எல்லாமே இருக்கு வரிசையா you also going to have a muramic acid and glucosamine, muramic acid glucosamine, muramic acid glucosamine. இந்த மாதிரி ஒரு alternate arrangement இருக்கு. Between your muramic acid of one side to the muramic acid of other side, you are going to have a bond. What is the bond that is going to be present? That is a glycopeptide bond. That is going to be your glycopeptide bond that is going to be present. Okay, or we can call it as a transpeptidase. So between two peptide, muramic acid is one peptide, glucosamine is one peptide. You're going to have a peptide bond, transpeptidase. There's going to be a bond between the M and G. Okay, it's a bond between your M and G. Now what happens? You're going to give a drug which is going to inhibit one cell wall synthesis, இன்னொன்று cell wall integrity. இது ரெண்டுத்தையுமே நம்ம என்ன பண்றோம்? We are going to inhibit. We are going to interfere with the cross linking. We are going to interfere with the cross linking. How do we do it? Number one, any glycopeptide antibiotic like your Vancomycin, Ticloplanin. Okay, so they are going to inhibit the chain elongation and interfere with the cross linking. இந்த இடத்தை affect பண்ணும் your vancomycin. Number two, your penicillin, cephalosporin, carbapenem and monobactam. So இதான் ஒரு பெரிய chapter. Can you, if you're going to go and see in your Tripathy textbook, this chapter is a very big textbook that is going to be beta-lactam antibiotics. So I got a penicillin, cephalosporin, carbapenem and monobactam. இது நாலுமே together we call it as beta-lactam antibiotics. Beta-lactam antibiotics main வேலை என்னன்னா, they are going to inhibit the transpeptidase enzyme. Transpeptide enzyme inhibit பண்ணது because of the cross linking is not going to occur. Okay, because of this cross linking does not occur. Because cross linking does not occur, there is going to be a losing of structural integrity of your bacteria. So your bacteria loses the structural integrity. That is what called as your cell wall inhibitor. Are you clear with this? Are you clear with this? Remember, what about your vancomycin? The problem is, okay, why there is a development of resistance of the drug. See, your vancomycin will not be able to bind to your D-ALA. When it is D-ALA, there is no problem. Your vancomycin and Ticloplanin can go and bind. When it is going to be D-ALA arrangement. If it is going to be D-ALA D-lactate, okay, D-ALA D-lactate because of the mutation in the VAN-A gene in your enterococcus. Whenever there is going to be a VAN-A gene mutation in your enterococcus, what happens? This ALA gets converted into a lactate. Because of this conversion, what happens? There is going to be a vancomycin resistant enterococcus. This vancomycin resistant enterococcus, what happens? First, எங்க நடக்கும்னா enterococcusல தான் vancomycin resistant நடக்கும். அதுக்கப்புறம் this is going to transfer by gene conjugation. This is asked as a MCQ once. This is asked as a MCQ1. By what method your vancomycin transfers the resistance from the enterococcus to staphylococcus? From enterococcus to staphylococcus by the method called conjugation. Hope you all know this in the microbiology first chapter. General microbiology, you will have read what is conjugation. Okay, what is this? All those mechanisms you will be reading. Okay, so அதுதான் நான் இங்க சொல்றேன். So there is a conjugation method by which vancomycin resistance by your enterococcus is going to be transferred into your staphylococcus. Clear, right? So you're going to have your staphylococcus schizouri. So staphylococcus schizouri அப்படிங்கிற okay, இது வந்து mechanism of vancomycin resistance. What I told you is mechanism of vancomycin resistance. This will be a frequent viva question. In fact, I got this in my UG days. As a mechanism of vancomycin was asked as a viva question in my exam. So I'm asking you also to read this. So this can be asked in the exam. Next is going to be your staphylococcal crucis. So scusi. So in your staphylococcus curie, what happens? There is going to be a mutation in the penicillin binding protein. Penicillin binding protein is called as MCCA. So in the MCCA, there is going to be a mutation. Because of this, what happens? Now your staphylococcus curie is going to have a mutated penicillin binding protein. Now this is going to be transferred to your staphylococcal aureus. By what? It is going to be transferred by your transduction. It is going to be transferred by your transduction, which leads to MRSA. Now, what is a VRF? What is vancomycin resistant staphylococcal aureus and methicillin resistant staphylococcal aureus? Both are different mechanism. Why there is going to be methicillin resistant staphylococcal aureus? Because of the mutation occurring in the protein binding site of your staphylococcus curie. SCIURS curie. What happens at the site of MCCA? There is going to be a mutation. Now what happens? This MCCA gene is transferred to the staphylococcal aureus. By whom? By the transduction. Whenever there is going to be transfer of MCCA gene into staphylococcal aureus by transduction method from your staphylococcal curie, what happens? You are going to get a methicillin resistant staphylococcal aureus. Whereas whenever there is going to be a mutation at the VAN-A site, at the VAN-A gene in the enterococcus, what happens? There is going to be development of a vancomycin resistant enterococcus. This is going to get transferred to the by the conjugation method into your staphylococcal to form vancomycin resistant staphylococcal aureus. Okay, methicillin resistant staphylococcal aureus and vancomycin resistant staphylococcal aureus. These are the two important mechanisms that you must remember. Okay, that you must remember. Is it clear? So now the question is asked, what is MECA? What is MECA? Okay, it is nothing. It's MCCA is nothing but it is a mechanism. It is a mechanism. Okay, MC stands for mechanism. Okay, MC stands for mechanism of mutation in the mechanism A gene and mechanism C gene. Okay, so it is nothing but mutation at mechanism A gene and C gene and A gene. That is what we call it as MCCA gene. Okay, it is nothing but MECA, MECC. These are the two genes which is going to be associated with the methicillin resistant staphylococcal aureus. So together we call it as MCCA gene, mechanical C and mechanical A gene. They are going to be the gene which is responsible for penicillin binding protein. When there's a mutation, what happens? There is going to be a change. If this MCCA is going to be transduced into the MRSA, that is going to lead to methicillin resistant staphylococcal aureus. Are you clear with this, Dinesh? Are you clear with this? What is MCCA? Did you get the point? Yes, right? Yes. Now we are going to go into the beta lactam group. Now what you are doing is just take a 1 minute break. Exactly 1 minute. Just take a water, sip of water, because we are going to continue for the next 1 hour. Almost till 1:15 to 1:30 we will be continuing and completing your beta lactam group of drugs. Beta lactam group of drugs la cephalosporin classification or the most confusing part. So what I suggest you is take a sip of water now, so that we will start with your cell wall inhibitors. I will also take a sip of water. This doubt till now, do you have any doubt? Because moving into this, I want to make sure if you guys have any doubt, kindly put in the chat box. Kavita, Afif, Dinesh, Jnanashri, Revati, everyone, do you have any doubt? Till this protein, okay, whatever we read, protein synthesis inhibitors. Do you have any doubt in that? No, right? Okay. So I have sent you many important questions, MCQ, because many asked MCQs from where should we refer, sir? You are asking me. I have prepared around 150 to 160 MCQs are there in that question bank. So those 160 MCQs will be covering all type of questions in all chapters. Only that 160 MCQs is more than sufficient for even final revision. Okay, so I have prepared like that. So you can go through those MCQs which are put in the chat in our group later. Okay, now moving on to discuss about the beta-lactam group of drugs. Remember, beta-lactam blocks cell wall from growing. What is the mechanism? Beta-lactam group of drugs are going to block the cell wall from growing, isn't it? So take this as mnemonic. Beta stands for beta-lactam group of drugs. Block, B stands for bacitracin. So B stands for bacitracin. And cell wall larka C stands for cycloserine. B stands for cycloserine. C stands for cycloserine. And F stands for phosphomycin. F stands for phosphomycin. And G stands for glycopeptides. G stands for glycopeptides. Clear, right? So you're going to remember by beta block here. Beta-lactam blocks cell wall from growing. B stands for beta-lactam. Another B stands for bacitracin. C stands for cycloserine. F stands for phosphomycin. And G stands for glycopeptides. Okay. So now coming to the bacitracin. Bacitracin is used as a topical ointment. They are used as a topical cell wall blocker or cell wall precursor inhibitor. It is going to be inhibiting your cell wall precursor of your bacteria. Now coming to the cell wall, C stands for cycloserine. Cycloserine is nothing but a alanine racemase inhibitor. So they are the inhibitor of alanine racemase. Alanine racemase inhibitor. They are going to be given in case of resistant TB. Drug resistant tuberculosis, you will be giving alanine racemase inhibitor. What is that alanine racemase inhibitor? That is going to be your cycloserine. It is an anti-TB drug. Next, you are going to have phosphomycin. So commonly given drug in case of UTI infection is phosphomycin. So what is the mechanism of action of phosphomycin? It is going to inhibit enol pyruvate transferase. Enol pyruvate transferase. Enol is nothing but lipid. So lipids are required for the cell wall synthesis. So what this does is it is going to inhibit the enol pyruvate transaminase. So enol pyruvate transaminase inhibit pandrom. When it is going to inhibit, that is going to cause, that is going to be your phosphomycin. UTI infection like you will be using. Next is your glycopeptide. Glycopeptides, so they are going to be a one that helps in binding of your D-ALA. So between your D and ALA, that is going to be your glycopeptide, whereas the one that is going to be acting between your G and G, between M and M, that is going to be your transpeptide. That is going to be a transpeptide. So a transpeptide inhibit பண்றது beta lactam ஓட வேலை. Beta lactam what it does, it inhibits your transpeptide. So transpeptide, it is going to be inhibitor, and that inhibits your cross linking. That you need to remember for beta lactam drugs. Whereas glycopeptide, that inhibits your D-ALA. This one is going to be inhibited between your D part and your ALA part. Clear, right? Now moving on to talk about your penicillin. Penicillin is going to be your, I can give as aqueous penicillin G, or it is going to be in the form of crystalline penicillin. Either it is going to be in the form of aqueous penicillin, or it is going to be in the form of crystalline penicillin. So aqueous penicillin, crystalline penicillin, they have certain limitation. Okay, why penicillin is not used nowadays? The answer is very easy. One is they are acid labile. If it is acid labile, can you give it by oral route? No, because oral route la kudutha enna agum, penicillin is going to be destroyed by your body. So adinala what our scientists thought, so they are very intelligent than us. They were finding a solution instead of reading a theory. Okay, what they thought, okay, this is having a resistance. Now what I have to do? I have to bring a solution. How do they bring the solution? By making the penicillin acid stable. Now they are going to make the penicillin acid stable. What are the acid stable penicillin example? Penicillin 5, penicillin B. Okay, what it does is it is going to have a phenoxymethylpenicillin. So this phenoxymethylpenicillin is going to be acid stable. So this can be taken orally. Very good. The first problem is over. But the second problem, what you add? Penicillin has a shorter duration of action. Therefore, if you want to give out for a treatment, penicillin has to be given in IV only, because oral route is not possible. In IV also, you have to give 4 times a day. Now, can you tell me, every day 4 times, if you're going to puncture the patient, if you're going to give by IV, will the patient be happy? No. or you have to hospitalize the patient. You have to hospitalize the patient, and I am going to repeatedly giving the patient a medication. Will the patient comply with you? The patient will be will be happy with you? No, of course they won't be complying with the patient, doctors. Therefore, they found a solution where there is a long acting penicillin and which can be given in the IM format instead of IV. ஐஎம்னா அவங்க வீட்டுக்கு போயிட்டு கூட வரலாம். So they can go once in a day, they can come to you and you can give IM penicillin. If it is going to be IV, you have to admit the patient in the hospital, or every time you have to put a butterfly venflon or your SV set and you are going to give the patient. That is literally not possible. Therefore, they found a long acting IM penicillin. Example is a procaine penicillin G or benzathine penicillin G. Procaine penicillin G as well as your benzathine penicillin G, they can give you given, procaine penicillin G is given once a day, whereas benzathine penicillin G is given weekly. It is given weekly, okay, or once is enough. Next, coming to the third one, narrow antibiotic spectrum. So the third problem which we had with penicillin is they had a narrow antibiotic spectrum. They can act only on the gram-positive organism, then they couldn't act on the gram-negative organism. So what you have to do? You have to do by extending the spectrum of penicillin. How did you extend the spectrum of penicillin? By giving penicillin, aminopenicillin. What are the example of aminopenicillin? A stands for ampicillin. So penicillin penicillin எடுக்கிறீங்க. From amino you are going to take am. So it's a ampicillin. It's a ampicillin or amoxicillin. So all your ampicillin, amoxicillin are nothing but A stands for amino and penicillin stands for penicillin. So your amoxicillin and ampicillin, they are going to be your, yes, they are going to be your aminopenicillin. Okay, so they are going to be acting against your salmonella, they can act against your hemophilus, they can act against your E. coli, etc. Therefore, they are drug of choice in case of enterococcal infection or listeria infection, neonatal meningitis. Everywhere what happens, you will be giving this penicillin. You are going to give with amoxicillin or ampicillin. They are the drug of choice in case of neonatal meningitis. They are the drug of choice in case of your enterococcal infection. Moving on to discuss about your ampicillin. Ampicillin is going to be E. coli, salmonella, hemophilus we can give. The side effect is they have a increased rashes. Rashes vandhudu. Again, diarrhea is there. So what are the other extended spectrum penicillin? The second extended spectrum penicillin is going to be your carboxypenicillin. What they did is, instead of adding amino group, what they added now? They added carboxy group. So this carboxy group example is going to be your carbicillin. So you're going to have carnicillin, ticarcillin. So ticarcillin, carbicillin, car, CAR stands for your carbon. Okay, so carboxypenicillin, aminopenicillin like you have A. So in the carboxypenicillin, you're going to have car, CAR. So ticarcillin, carbenicillin, that comes under carboxypenicillin. Next is going to be uridocillin. So uridopenicillin is going to be azolopenicillin, mesloxilin, and your piperacillin. Piperacillin is a very commonly used ICU drug, antibiotic. I can call it as ICU antibiotic because the patient who is under severe sepsis, we will be using piperacillin linezolid. Piperacillin linezolid we are going to use more commonly. Piperacillin is going to be a extended beta-lactam group of drugs which has a maximum activity. Next, uridopenicillin, carbopenicillin. Now, enna pantona uridopenicillin add panto, carboxypenicillin add panto, like ticarcillin, piperacillin. When will you do that? You are going to do that in the case of anti-pseudomonal penicillin. So when you are going to act against pseudomonas, they require two type of drugs. One that should act against the carboxy. There should be a carboxypenicillin and one should be uridopenicillin. So combination of this can be given in the anti-pseudomonal patient or pseudomonas patient. Penicillin G is going to be broken up by the penicillinase enzyme. You have streptococcal aureus. The streptococcal aureus என்ன பண்ணுது penicillinase enzyme வச்சு they are going to break down your penicillin. அப்ப penicillin G வெறும்னா கொடுக்க முடியாது. Penicillin G cannot be given alone. So what happened is we started giving a penicillinase resistant penicillin. So what is this penicillinase resistant penicillin? So whenever the staphylococcal aureus is going to secrete penicillinase, so what you did is you are going to give a drug that is going to prevent your penicillin G from action of penicillinase enzyme. What are those drugs? Methicillin, oxazolidine, cloxacillin, okay, nampicillin, flucoxacillin. In the மாதிரி இருக்கிற எல்லா ட்ரக்கும். So இதுல இருக்கிற drugs எல்லாமே you have to remember one or two, but the mechanism you should never forget. So fluoxacillin, methicillin, oxacillin, cloxacillin, flucloxacillin, இது எல்லாமே they are going to be helping you by adding the penicillinase secreting pseudomonas aureus, you're going to add a coverage. Penicillin resistant ஆகுறீங்க. So, but the side effect with this is everyone are going to be going through the urine. So what happens? They can cause nephrotoxicity. They can cause nephrotoxicity and nephritis. Okay. Now coming to beta lactamase inhibitor. ஒருவேளை இப்ப வந்து பாத்தீங்கன்னா beta lactamase அப்படிங்கிற enzyme இருக்கு. Okay. So Staphylococcus aureus you're going to give. They have some enzyme called as beta lactamase. This beta lactamase, what happens is irrespective of, okay, they are going to either you are going to prevent penicillinase enzyme or there can also be beta lactamase enzyme. The beta lactamase enzyme inhibit பண்றது யாரு? That is your sulbactam, clavulanic acid, tazobactam. All these drugs, they are going to inhibit your beta lactam. Beta lactamase inhibit பண்ணிட்டீங்கன்னா then you won't have any problem. So அப்ப என்ன பண்றோம்னா with ampicillin, with piperacillin, we are going to have another drug. Ampicillin na sulbactam ஓட சேர்ந்து கொடுப்பீங்க. Amoxicillin na clavulanic acid ஓட சேர்த்து கொடுப்பீங்க. Piperacillin na tazobactam ஓட சேர்ந்து கொடுப்பீங்க. Combination அப்படிதான் வரும். Why? In order to prevent the beta lactamase from destroying your antibiotic. Therefore, what you are going to do? You are going to give a combination drug. Ampicillin, sulbactam, amoxicillin, clavulanic acid, piperacillin, tazobactam. Will you forget this? Piperacillin, tazobactam, amoxicillin, clavulanic acid, ampicillin with sulbactam. Clear, right? So these are going to be the problem which is faced by. So limitation, acid labile problem solve பண்ணிட்டோம். Short duration of action, we made into long duration of action. Narrow antibiotic இருந்தது, we made into broad spectrum antibiotic. Penicillin G is going broken by penicillinase or beta lactamase. That is also overcome now. Fifth problem we have is going to be your hypersensitivity. So no penicillin is available without allergy. There are variety of penicillin, maximum of them are allergic. So you have to be very sure whether the patient, you are going to ask the patient whether they have any allergy for penicillin. If yes, you are not going to give penicillin for those patients. Now coming back to the uses of penicillin. So let's see the uses of penicillin. Uses of penicillin. Number one is penicillin G. Remember, penicillin G is used in case of syphilis. Syphilis la only drug which we are going to use is penicillin G. Only if there is a resistance to penicillin, you go for doxycycline. Otherwise, penicillin G is going to be the drug of choice in case of syphilis. Primary or secondary or tertiary or early latent, late latent, neurosyphilis. In the condition andalo. Okay, in the condition andalo you go for penicillin G. Clear, right? First degree, second degree, early latent na you are going to go for benzathine penicillin 2.4 million unit international unit once. Okay, otherwise if it is a tertiary syphilis or latent syphilis, you go for benzathine penicillin G 2.4 million international unit once a week for 3 times. Okay, you are going to give 7.2 million international unit. அப்ப எப்படி யூஸ் பண்ணுவீங்க? 3.4 million international unit into 2.4 million international unit you're going to use for 3 times. That is going to be 7.2 million international unit. 3 weeks you are going to give. 1 weekly once, 3 weeks you are going to give. Neurosyphilis we go for aqueous penicillin G. In neurosyphilis we go for aqueous penicillin G. Now moving on to the secondary penicillin. Okay, syphilis, secondary syphilis. Remember, secondary syphilis is going to be causing a severe leptospirosis. Okay, in severe leptospirosis, secondary syphilis, you are going to use a similar drug that is going to be your penicillin G. Okay, what happens because of penicillin G? See, penicillin G in case of secondary syphilis or in case of severe leptospirosis, when you are going to give, that is going to cause death of your leptospira or death of your treponema. So when there is a death, what happens? There is an antigen antibody reaction. This antigen antibody reaction is going to cause fever and rash. This is called as JH reaction. Anyone know what is the full form of JH reaction? Anyone know full form of JH reaction? It's going to be your Jarisch-Erzimus reaction. Jarisch-Erzimus reaction. Write it down, guys. That is nothing but your Jarisch. Okay, Jarisch-Erzimus. reaction. Nothing but when you're going to give a penicillin, that is going to cause rapid death of your treponema as well as your leptospira. That is going to lead to fever and rash because of antigen antibody reaction. This is called as Jarisch eczemus reaction, where you are going to give NSAID as a drug of choice. So, but penicillin reaction should be penicillin treatment should be continued irrespective of this reaction. Okay, congenital syphilis, what is the drug of choice? Aqueous penicillin G is a drug of choice. Now coming to the prophylaxis of rheumatic fever. So first we saw syphilis, second we saw is your secondary syphilis and your severe leptospirosis. Third is going to be your rheumatic fever. So prophylaxis of rheumatic fever is drug of choice is benzathine penicillin. Remember, benzathine penicillin G is a drug of choice in case of prophylaxis of rheumatic fever. You would have read in the pathology, once 3 to 4 weeks, you are going to give. If there is a history of allergy, what you will do? You go for erythromycin or sulfadiazine. You go for erythromycin or you go for sulfadiazine. Clear, right? Then you have something called as rat bite fever, actinomycosis, anthrax, and severe leptospirosis. Remember, RAAS, RAS. Okay, it is going to be RAAS, RAS. Okay, SP, RAS. We will be remembering SP, RAS. Okay, S stands for syphilis and secondary syphilis. P stands for prophylaxis of rheumatic fever, and you're going to have your RAS, RAAS. Okay, remember RAAS. So rat bite fever, actinomycosis, anthrax, severe leptospirosis. Anthrax, severe leptospirosis. In all these cases, the drug of choice will always remain penicillin G. Remember, penicillins are eliminated in urine via tubular secretion. Therefore, they are not safe in the renal failure. Except there are few drugs again. So, can you tell me what are the exceptions of drug which we saw in tetracycline? Tetracycline, what are the drugs that are safe in the renal failure? Can you tell me in the chat box? What are the drugs that are safe in the renal failure in the tetracycline group of drugs? Exactly. Toximinotigicycline. Similarly, here your Nafcillin, Noxacillin, Cloxacillin. Remember NOC. So NOC. So NOC are the group of drugs. They are going to be safe in case of renal failure. Now, okay, NOC are going to the group of drugs that are going to be safe in case of renal failure. So in case of your in your penicillin group of drugs and your beta-lactam group of drugs, what are they? Number 1, Nafcillin. Number 2, Oxazolidinones. Number 2, Cloxacillin. Among this, Nafcillin is going to be very safe. Nafcillin is going to be very safe. Can you tell me what is going to be the nephrotoxic drug in case of your macrolides? No, aminoglycoside. Can you tell me what is a nephrotoxic drug in your aminoglycoside? Nephrotoxic drug in case of aminoglycosides. N stands for, I told, neomycin. Excellent. So your neomycin is going to be aminoglycoside which causes nephrotoxic. Inge nephrosafe, which is going to be the drug Nafcillin. Idhu N la da start agum, but Nafcillin, which is the most safe drug in case of your renal failure. Now, what happens? Now our scientist, we started to think penicillin is a very important drug. Penicillin is a very important drug. Okay, we know penicillin is very important drug. But in the penicillin, they are going to be not renal safe. Okay, so what we can do? Now the doctors started to think, scientists started to think. So what they did is they added along with penicillin another substance called as probenicid. Probenicid, when you're going to add along with penicillin, they are going to have a decreased elimination in urine. Okay, whenever there is going to be decrease in the elimination in urine, what happens? They will be having a lots of concentration in the plasma. Plasma concentration increase agudhu. Plasma concentration increase ana, the time it is going to remain in your blood is going to be more. Therefore, they have a wide therapeutic index. They are going to have wide therapeutic index. That means they have a wider duration of action. They have wider duration of action. So, penicillin or problem enna, they are rapidly excreted in the urine. So, other prevent pannungadhukaga what they did is they added probenicid along with the penicillins. So, probenicid add பண்ணும்போது they had a wide therapeutic index. They are going to have a longer duration of action. Okay, but one more problem what it had is this probenicid. Okay, problem illa probenicid eppadi function ஆகுது அப்படின்னு பார்த்தோம்னா இந்த பென்சிலினை வந்து செக்ரீட் பண்றது into urine யாருன்னு பார்த்தோம்னா organic acid transporter. So what your probenicid is going to do, they are going to inhibit this organic acid transporter. When they are inhibiting this organic acid transporter, your penicillin is not going to go to your urine, therefore it is going to remain in the plasma. Hope you are clear with the action of probenicid. Now, so these are the important uses of your penicillin. Are you clear with penicillin uses? 7 uses we read. Syphilis, again there is going to be a secondary syphilis. Again you are going to have your third one, that is going to be your prophylaxis for rheumatic fever. Then you have RAS. R stands for rat bite, A stands for actinomycosis, and A stands for anthrax, and S stands for severe leptospirosis. Clear, right? Now we are going to move into the resistance part. Remember, so how do this penicillin develop resistance? I told you already, either they are going to develop resistance by developing a penicillinase or beta lactamase. In the enzymes மூலமா develop ஆகலாம். அப்படி இல்லைன்னா I also told you another one, mutations. So MRSA ல எப்படி mutation ஆகுது? Can you tell me what is going to be the gene affected in the MRSA organisms? Gene affected in the MRSA organism, can you put in the chat box? MEC-A and MEC-C. So now we call it as MCCA. MEC-A, MEC-C is the one that is going to be affecting. Hope you are clear with this. Now we are going to move towards the second group of drug, that is going to be a cephalosporin. Cephalosporin, they are divided into 5 generations. First generation, second generation, third generation, fourth generation, fifth generation, 5 generation irukku. So now what will be your next question is how to remember all the 5 generations. Sir, it is very difficult to remember all the 5 generations. How to mug up, how to memorize. These are the questions which I get commonly in my chat box, in my personal messages from the people who are wanted to memorize this cephalosporin. Remember guys, mugging up cephalosporin is very difficult. But what can be the other alternative is at least remember 1 or 2 drugs, or we can remember by using some tricks. I'll tell you these tricks. Don't worry, I'm going to tell you. Okay, first one, first generation. Okay, first generation is going to be a cephazolin. Okay, remember the first generation is going to be your cephazolin. First generation is going to be your cephazolin. Okay, so cephazolin la endha doubt vena adu first generation. Okay va. So you have other drugs also like cephalexin, cefdroxil, cepharaxil. Okay, what are the other drugs? Cephalexin is there and you have cefadroxil is there. Okay, but remember, don't need to remember these two. These two are oral drugs. Nowadays, it is not taken. So, currently, இது கிடையாது. அப்ப cephazolin மட்டும்தான் we have some importance. That is, it is a drug of choice still in case of surgical prophylaxis. What is going to be the importance? They are going to act only on the gram positive. Only on the gram positive. Gram negative தொடாது. Okay, first generation, they are going to act only on the gram positive organism. They are going to act only on the gram positive organism. So this you are going to remember. First generation la you will have either FA இருக்கும். ஓகேவா? ஸோ செஃபசோலின் அப்படின்னு இருக்கு. ஸோ பட் இது வந்து நிமோனிக்கா ப்ரீவியஸாக யோசிச்சு வச்சிருந்தாங்க. Okay, so how you can remember is in first generation and second generation. Both in first generation as well as second generation. Okay, at least you can remember like this. You have either FA or PHA. FA, PHA இருந்ததுன்னா அது first generation இருக்கணும் இல்ல second generation இருக்கணும். ஓகேவா? கிளியரா? Either it should be first generation or second generation. Cephalexin or it is going to be cefadroxil, cefaclor, cephomycin. So these are the first generation or second generation group of drug. Like that, at least remember. I'll tell you maximum how you can remember. I will tell you. See, so first generation is going to be a cephazolin, cephalexin, cefadroxil. Either no use at all. So just cut down these two things. Just remember in your life, you're going to remember just one cephazolin. It is given as a parenteral IV. What is going to be there? This is going to be a drug of choice in case of surgical prophylaxis. Second one is a second generation. Remember, second generation is going to be both gram positive as well as gram negative. Ana gram negative is going to have more role than your gram positive. So you have two important things: cefaclor and cephomycin. Cefaclor, cephomycin. Cefaclor is a oral drug. Cefuroxim is an oral drug. So Cefaclor, Cefuroxim, both are going to be oral drug. Both are going to have a Pha. Okay, remember this Pha or Pha, PHA is going to be there. Cefaclor or Cefuroxim, these are the two drugs which you have to remember. Okay, Cefuroxim, Cefaclor. So these two are going to be oral in nature. These two are oral in nature. Cefuroxim can also be given in a IV. Cefuroxim can also be given as a IV drug. Clear, right? Then you have Cephomycin. What are these Cephomycin? You have three drugs under Cephomycin. Cefoxitin, Cefophyton, and Cefmetazole. Cefoxitin, Cefophyton, Cefmetazole. இது நம்மளோட கேட்டகரியில வராது. அதனால நம்ம இது ரெண்ட மட்டுமாவது அட்லீஸ்ட் நான் வச்சுப்போம். Cefoxitin, Cefophyton. All ends with 4. Okay, FO. Okay, Cefoxitin and Cefophyton, you're going to remember. So what is the action? They are going to be having anti-anaerobic action against your bacterial fragilis, bacteroides fragilis, and it is used in the intra-abdominal infection and peritonitis. But commonly used பண்றது எதுன்னு பாத்தீங்கன்னா we are using third generation. So what is the common drug which you are using? So third generation is a common drugs which you are using. Third generation எப்படி நீங்க வச்சுக்கிறீங்கன்னா 1 it is end with 1 or it is going to end with 10 or it is going to end with IME. Okay, either 1 or 10 or IM. Okay, let's see one by one. First one is going to be a ceftriaxone. So ceftriaxone is ending with 1, right? So it is going to be your third generation cephalosporin. Clear, right? So you're going to have ceftriaxone. What is the drug of choice of ceftriaxone? Cancroid, gonorrhea, typhoid. So cancroid, gonorrhea, typhoid is the moonly ceftriaxone is going to be your drug of choice. So gonorrhea, remember only ceftriaxone. There is no other drug available. So there is no other drug available. Only a ceftriaxone is going to be available. So remember, ceftriaxone is the only drug which is given in the gonorrhea. There is no combination treatment. Now coming to the typhoid, you should not add any other combination in your ceftriaxone. Okay, single best drug is going to be ceftriaxone. Now coming to the typhoid. Why I am repeatedly telling this? Ceftriaxone is the only drug which you give in case of your gonorrhea. You are not going to add any other things in it. Why I am specifying? Can you just guess why I am specifying this again and again? Can you tell me why I have specified this again and again? Okay, in your microbiology, if you're going to go, you will be reading something called as syndromic management of your syndromic management of gonorrhea. You will be reading something called as syndromic management of gonorrhea. In that, what we will do is we will be like dividing all the diseases into certain symptoms, and we are going to give drug based on the symptom. அதுல வந்து பாத்தீங்கன்னா you have gonorrheal diseases. So gonorrheal diseasesல you will be giving only your ceftriaxone. So gonorrheal diseaseல you don't need to add any combination in your gonorrhea. Gonorrhea only treatment, single treatment you're going to go is you are just going to give ceftriaxone. That is the reason why I was repeatedly telling. Okay, next is going to be your typhoid. Typhoid, drug sensitive typhoid, you go for ciprofloxacin. Drug sensitive, you go for ciprofloxacin. But if it is drug resistance or even in drug sensitivity, you can go for ceftriaxone. So, up a safer side, which drug you go for in typhoid for a safer side. So we don't know whether the patient is drug resistant or drug sensitive. So for safer side, we go for which drug? Can you put in the chat box? Which drug we go for? In a drug sensitive as well as drug resistance in your typhoid. We go for the drug called as ceftriaxone, ONE. It is a third generation cephalosporin. Remember, in a typhoid, what is going to be the drug of choice? First is going to be ceftriaxone, followed by azithromycin, and third only your ciprofloxacin. So remember, any drug, what is going to be azithro acts as a drug of choice. Okay, second line drug in case of your ceftriaxone. Can you tell me? Similarly, we saw azithromycin is going to be alternate drug for which drug? So which drug we give azithromycin as alternate? We saw one drug. So நிறைய conditions நாம பார்த்தோம். Doxy, excellent. So doxic supplement or alternative, we go for azithromycin. That's what I want from you all to remember. And now, what is the fourth important disease you're going to go for? That is your bacterial meningitis. Can you tell me in which type? We have read one more meningitis previously. In meningitis, one more meningitis, neonatal meningitis. What is the drug we give? So in a neonatal meningitis caused by listeria, specifically, if it is caused by listeria, what was the drug I gave? What is the drug I gave? I think answer is here itself. But someone, can you put in the chat box? What is the drug you give? Ampicillin. So ampicillin la we give listeria infection la ampicillin is going to be given as a drug of choice, but ceftriaxone and vancomycin is a drug of choice in case of bacterial meningitis. Ceftriaxone and vancomycin is going to be a drug of choice in case of bacterial meningitis. Therefore, in any patient with neonatal meningitis, what are the 3 drugs you are going to give? You will be giving ampicillin so that it is going to cover your listeria. You are going to give ceftriaxone so that other broad spectrum antibiotic. It's going to cover all your bacterioids. So you're going to give ceftriaxone and you're going to give vancomycin. Vancomycin is given to cover all your resistant drugs. Okay, so these are the 3 drugs which you give in the bacterial meningitis. If you're going to suspect a gonorrhea, okay, you're going to give ceftriaxone. But if in case you're going to suspect gonorrhea, chlamydia, and chlamydia, there will be a vaginal discharge or urethral discharge. Gonorrhea, it can be a vaginal discharge or urethral discharge. It's going to be that is going to be LGV, lymphogranuloma venereum. Therefore, you will be giving a combination of ceftriaxone along with doxycycline. So, ceftriaxone doxycycline combination is given when the patient suspecting of gonorrhea as well as chlamydia, when the patient have a urethral or vaginal discharge. Hope you are clear with ceftriaxone. Can you tell me what are the 4 important diseases where you are going to go for ceftriaxone? Can you put in the chat box? What are the 4 important drugs? First drug, okay, ceftriaxone is given as a drug of choice in case of what are the 4 important diseases? Can you tell in the chat box? Ceftriaxone is given as a drug of choice in 4 important diseases. Can you tell me what are the 4 important diseases? Number 1, it is given in case of gonorrhea. Excellent. Number 2, it is given in the case of. Number 2, it is given in the case of. Number 2, you are going to give it in the case of. Can you tell me? Number 2, you are going to give it in the case of. Only gonorrhea. Remaining 4 patho. Ippada just patho. What are the other things which you are going to give? In case of cancroid. In case of cancroid, you are going to give. What is the third one? In case of typhoid, you are going to give. What is the fourth one? Bacterial meningitis. Remember, these are the 4 important conditions where you go for ceftriaxone. Number 2, that is going to be our next drug, ceftazidime. Can you tell me? So I told you 3. 1, or if it is going to end with PN, or if it is going to end with IME. Okay, only exception for drug ending with IME. Can you tell me? That is going to be your IME where and the drug may end except your cefuroxime. Cefuroxime is a 2nd generation antibiotic. Cefuroxime is going to end with IME. Cefuroxime is 2nd generation. So you're going to remember only IME drug, cefuroxime. So only IME drug, cefuroxime. Cefixime I will come. It is not in the. It is going to be a part of not your 1st generation or 2nd generation. I will talk about cefixime. Don't worry. I will talk about cefixime. For now, remember cefuroxime. IME landagara cefuroxime is going to be again a 2nd generation. Except cefuroxime, all the drugs that end with IME, they are going to be your 3rd generation, including your cefixime, including your cephalosporin, including your ceftriaxone, including your ceftazidime. Ella IME drugs, so they are going to be coming under 3rd generation, except one drug that is going to be a cefuroxime comes under 2nd generation. Except cefuroxime that comes under 2nd generation. Clear, right? Yes. Now moving on to the ceftazidime. Ceftazidime is going to be having an anti-pseudomonal action. Therefore, when you're going to have a bacterioid pseudomeli causing a melioidosis, anga you will be giving ceftazidime. Ceftazidime is given in case of melioidosis, bacterioid pseudomeli. And the important disease la you're going to give melioidosis la you will be giving ceftazidime. Third one is going to be your cephalosporin. Third drug which you are going to see is cephalosporin. So in the drugs la you should never forget. There are many drugs, but in the drugs you should not forget. Cephalosporin, this is going to be safe in the renal failure. They are going to be anti-pseudomonas again, and they have disulfiram-like reaction. What is disulfiram-like reaction? Can you tell me? In the alcohol, when you're going to take alcohol, so when you're going to take alcohol, you're going to have disulfiram. You are going to give disulfiram. What is disulfiram? What is disulfiram? So what happens is, at a therapeutic dose of disulfiram, alcohol consumption will be resulting in the increased serum acetaldehyde that will be causing diaphoresis, palpitation, okay, your vertigo, nausea, hypotension. Adhe madriye, there are some drugs which will be causing disulfiram-like reaction. So do you want me to name it? Okay, how you are going to remember? So disulfiram reaction will be causing a problem with alcoholic. You all told, right? Dinesh, right? Kavita. Now, how I am going to remember all the disulfiram-like reaction. There are some drugs which will be causing disulfiram-like reaction. Remember, with the mnemonic, nice people cut down gin consumption. Okay, nice people cut down gin consumption. Gin consumption. Okay, so your N stands for nitrofurantoin. Remember, N stands for nitrofurantoin. Okay, number 2, P stands for procarbazin. What is your C stands for? C stands for chloropropamide. Okay, what is the fourth drug? Fourth drug is going to be your disulfiram. Again, your disulfiram itself will be causing disulfiram reaction. And what is the G stands for? G stands for griseofulvin. Is antifungal. We will be discussing later. And C stands for cefoperazone. Okay, clear. So you're going to remember these are the drugs which is going to cause this disulfiram-like reaction, aversion therapy, etc. Okay. Clear? So remember these drugs alone. So don't get confused with metronidazole or other drugs. So these are the drugs which causes disulfiram-like reaction. Only importance is these drugs only. Okay, just remember these drugs. Okay, so next one on the you are going to have hypoprothrombinemia. So in the drug they cause hypoprothrombinemia. They are going to cause hypoprothrombinemia. Okay, clear? So these are going to be the drug. So what are the other drugs which causes prothrombemia? Cefotetam. So you have your drug called as cefotetam. Cefotetam is also going to be another cephalosporin drug which is going to cause hypoprothrombinemia. There is going to be decrease in the prothrombin. Whenever there is a decrease in the prothrombin, they causes bleeding. Now tell me, now I am going to have a warfarin patient. So warfarin consuming patient irukanga, anticoagulant. Avangalukku, shall I prescribe cephalosporin? Can I prescribe cephalosporin? No, cephalosporin is going to be again a bleeding disorder. Okay, so that is going to cause again a hypoprothrombinemia with already warfarin consuming patient. This will lead to increase the bleeding. Okay, along with it, what are the other drugs you are going to remember? Cefixim, cefpodoxim, cefdinir, cefibutane, ceftametpivoxil, ceftatoxim, you have ceftriaxone, ceftriaxone, ceftazidime, cefoperazone. இது எல்லாமே அதுல importance வந்து இதெல்லாம் தான். Okay, whatever we saw is important. Apart from it, all your third generation group, like your cefixim, like your cephalosporin, everyone are going to act against gram negative as well as gram positive. That is the reason this has a wide broad spectrum, and you're going to give commonly you will be seeing, even when I'm sitting in the OP, I will be prescribing cephalosporin or cefixim for the patient, third generation cephalosporin, because they have a wider range of action. So adila importance வந்து எது எதுக்குன்னா, we have importance of your ceftriaxone, we have importance for cephalosporin, we have importance for ceftazidime. That is why I discussed these three drugs in detail. Are you all clear with that? Next is going to be a fourth generation drug. Fourth generation, I told you, remember that all your fourth generation drug will have PI in it. So we'll have PI in it. That is going to be cefipim and cefipirome. Cefipim and cefipirome. So இது வந்து பாத்தீங்கன்னா, they will be having a very high action on gram negative bacteria, like even your pseudomonas, like your Klebsiella. So pseudomonas, Klebsiella, this is going to have its action. This is going to have its action. Remember, now coming to the last one, that is going to be a fifth generation drugs. That is going to be a fifth generation drugs. So fifth generation drugs, how you are going to remember? Fifth generation drugs are very easy. How you are going to remember the fifth generation drug? Everything will have ROL in it. Okay, so ceftaroline, ceftobiprole, So you have ROL in it. ROL you will be having. Ceftaroline. So you have ceftaroline and you have ceftobiprole. Okay, so these two drugs are going to be fifth generation. They are the only beta-lactam antibiotics which will be effective even on MRSA. So only fifth beta-lactam antibiotic which will be effective on MRSA is going to be your ceftaroline and ceftobiprole. Because what is the drug of choice for your MRSA? Can you tell me? What is the drug of choice in case of MRSA drug? MRSA la enna drug of choice? Can you tell me what is the drug of choice in case of MRSA? Let me see who is going to tell. Already we discussed it. In MRSA, what is going to be your drug of choice? In MRSA, what is going to be Vancomycin? Excellent. Is there any other drug apart from Vancomycin which we read? Is there any other drug which we read apart from your Vancomycin? Can you tell me? Apart from Vancomycin, is there any other drug? Linezolid, excellent. Even linezolid is going to act against MRSA. So linezolid and vancomycin are the two important drugs which is going to be used here. Streptogramin, excellent. Streptogramin can also be used, but most commonly used is going to be your vancomycin, and we are going to use your linezolid. But even streptogramin, as you told, they can be given in case of resistant cases you can give. But the most common most common it's going to be linezolid and your vancomycin. Hope you are clear with this. Okay, now we have completed the biggest headache of you all, that is going to be cephalosporin. Can you all repeat along with me? Close your books. Can you repeat along with me? What is the first generation cephalosporin? First generation cephalosporin is the one that is going to end with Pha and Pa. Both first and second generation is going to end with Pha and Pa. What is the only drug you are going to remember in your first generation? That is going to be a cefazolin. Where will you give cefazolin? In case of a surgical prophylaxis. So in case of a surgical prophylaxis, okay, you will be giving your cefazolin. Second generation, what you are going to remember? Cefaclor, and you are going to remember cefaclor and cefuroxim. Cefuroxim is going to be used in a advantage. In the advantage you having a second generation is going to be, the second generation will have a increased gram negative action. Third generation is going to be your ceftriaxone, and you are going to remember ceftazidime and cephalosporin. Apart from that, you have cefixim, cefpodoxim, ceftibuten, ceftametpivoxil. You have many other drugs which you can mug up. But the thing is, basic idea, you're going to remember these three drugs. And fourth generation, you have anything that is going to be ending with, okay, third generation, it is going to be finished. Fourth generation, they are going to be ending with PI, cefipim. Okay, you have cefipin, cefpirom, cefipim and cefpirom. And fifth generation, anything that has role in it, ROL, ceftaroline, ceftobiprole. Clear, right? Now we are going to move towards the next group of drugs, Carbapenems. Carbapenems are also again a broad spectrum antibiotics. So they are going to act on gram positive, gram negative anaerobes. மூணு பேர்லயுமே act பண்றாங்க. Gram positive, gram negative anaerobes. மூணு பேர்லயுமே act பண்றாங்க. But the problem of carbapenem which they had initially is they are going to be broken down by your dihydropeptidase. So since they are going to be broken up by your dihydropeptidase, our scientist got a bulb over their face. Okay, like your Einstein gets a bulb, right? So like your Einstein is getting a bulb, and like all the scientists who gets a bulb, whenever we are going to see that cartoons and all. Same way, you are going to have a scientist who found this carbapenem. He had a problem that this is breaking dihydropeptidase. It is broken by dihydropeptidase. But advantages, it is going to act on gram positive, gram negative anaerobes. So what he did, he started with giving with another drug called as cilastatin. Cilastatin oda imipenem, carbapenems add panona, it is not going to be broken down. So that was an advantage which he found. So the only side effect is with this is seizures. They are going to cause seizures. Now your task is how we are going to avoid the seizures. How we are going to avoid the seizures? By asking the history of epilepsy. If the patient had a previous history of epilepsy, you are going to avoid this carbapenems. If not, you can give carbapenem. You have one drug which is can be given only oral, that is going to be ferropenem. Others all can be given by IV. Mean that which is going to be long acting. Ferropenem only oral. You have meropenem which is commonly given, doripenem, imipenem and ertapenem. So what are the penem group of drugs? started with a meropenem, then we had imipenem, then we had doripenem, then we have ertapenem. Ertapenem is the longest acting. Remember, ertapenem is longest acting. Then we have ferropenem. Ferropenem is a only oral drug. Ferropenem is only oral drug. Now, where all you started using this? What are the drug of choice? See, we are using this in the enterobacterial infections. You know that many enterobacterial are anaerobic in nature. Aerobes la mattum act pandra drug, can you tell me? Which drug acts only on aerobes? I told you, right? Which drug acts only on aerobes? Which drugs acts only on aerobes? We discussed many drugs. So in that I specifically told that one drug which acts only on aerobes, not on anaerobes. Can you tell me? Which drug acts only on aerobes? It does not act on anaerobes. Which drug acts only on aerobes and not anaerobes? Can you tell me? Which drug acts only on aerobes and not anaerobes? It doesn't act on anaerobes. Which drug? Can you just recollect and tell me? Can you just recollect and tell me? Aminoglycosides. Excellent. So aminoglycosides, they are going to be acting only on gram-negative aerobes. They don't have action on anaerobic bacteria. So, okay. So aminoglycosides, they have only action on gram-negative bacteria. But this carbapenems, they are going to act both in the aerobes as well as anaerobes, both in the gram-positive as well as gram-negative. Evlo broad spectrum is it. Adanala the enterobacterial infections, which is going to have an anaerobic. We are going to give in that, and we are going to also give in the species which is going to produce ESBL. Can you tell me what is ESBL? Can anyone tell me what is ESBL? What is ESBL? What is ESBL? They are extended spectrum beta lactamase. So initially what happened is we started to target beta lactamase. So you know, right, what is the drug? What is the addition which we do to inhibit the beta lactamase enzyme? Can you tell me what is the addition we do to inhibit the beta lactamase enzyme? Beta lactamase enzyme inhibit pandra drugs enna? Can you tell me what are the drugs which inhibit your beta lactamase enzyme? Number one, it is going to be your sulbactam, clavulanic acid, and tazobactam. Sulbactam, tazobactam, clavulanic acid. So now what happened is, இது வந்து beta lactamase inhibit பண்றது. Okay, so அதோட சேர்த்து, but அதை inhibit பண்ணிட்டு அதை கொடுத்துமே, there is a extended beta lactamase spectrum. அப்ப அதை break பண்றதுக்கு what you are going to add? You are going to add, that is going to be your carbapenem. So carbapenem is an excellent drug that is going to given in case of a extended spectrum beta lactamase, because extended spectrum beta lactamase, they will be breaking your cephalosporin, they will be breaking your monobactams. So monobactams break panidum, they will be breaking your fourth generation cephalosporin also. So therefore what you do is you will give carbapenem. But there is one advantage of piperacillin and tizobactam. Okay, if your carbapenems are not available, to some extent your tizobactam, they can act on the extended spectrum beta lactamase. Though this your tazobactam is going to be also acting upon your beta lactamase enzyme, they also have an extended spectrum action on the beta lactamase. Therefore, piperacillin tizobactam can also be given. But first important drug of choice is carbapenems. Next, you are going to have the last one, that is going to be your monobactams. Remember, monobactams, you are going to have two astrionum. So one drug which you have to remember in your monobactams is going to be your astrionum. Astrionum, they least cross react. So allergy reaction on the rumba kammi. So it is the safest beta lactam in patient with allergy. Okay, monobactam group of drugs are the safest drug which is going to be given in case of allergy, because they are very leastly, they will be cross reacting. Therefore, they have very least action on allergy. So verum ore drug da irukku monobactam la, that is going to be your astrionum. Carbapenem la we have imipenem, meropenem, ferropenem, doripenem, ertapenem. Okay, whereas in your monobactam, it is going to be just astrionum. So astrionum is the only drug which we are going to see. Okay, right? Now we are the last group in your antibacterial. Antibacterial almost we are going to complete. Okay, antibacterial we are going to complete. We are going to have just very few group of drugs which are left out. Okay, so we are left out with antimetabolite. We are left out with a glycopeptide. Do you remember in the first I told, right? So all your so when just go back to the first discussion where we discussed about your, we discussed with that image, right? Do you all remember? We discussed in the beginning of today with the image in your, just hold on, I'll just show it. So only then you will be able to understand. See, so in this, we have seen all your penicillin, cephalosporin, carbapenem, monobactam, எல்லாமே முடிச்சிட்டோம். இப்போ பாக்கி இருக்கிறது என்ன? We have and glycopeptide antibiotic. We are going to have glycopeptide antibiotic. We are going to have something called as cell membrane acting. So cell membrane lack பண்ற antibiotic we are left with, and we are left with the antimetabolites. We are left with the antimetabolites. So let's see one by one. Let's see one by one. So first thing we are going to see now is going to be a glycopeptide. After glycopeptide, we will go for a lunch break and we will be coming back around 2:15. So 2:15 we will be coming back. Okay. So after 2:15 you have to come back. So we will try to complete this glycopeptide, one page alone extra. So that is going to be your vancomycin or teicoplanin. What is vancomycin? What is teicoplanin? Vancomycin has a shorter TF. Teicoplanin has a longer TF. But then both are going to be having a similar mechanism of action. Can you tell me what is the mechanism of action of vancomycin and your teicoplanin, which we have already discussed? Can you put in the chat box? Can you put in the chat box what is the mechanism of action of vancomycin and teicoplanin? What it is going to inhibit? It is going to inhibit your glycopeptide. So D-ALA. So D-ALA. இந்த இதை வந்து inhibit பண்ற வேலை யாருது? Your glycopeptide inhibitors, that is your vancomycin and your teicoplanin. So they are also having a mechanism of resistance. How do they have mechanism of resistance? By conjugation. From your enterococcus, vancomycin resistance can be transmitted to the staphylococcus. Do you all remember? That is going to be the mechanism of action of resistance. Are you all remember? Are you all clear? Right now, coming to the side effects. Side effects of vancomycin is red man syndrome. The one of the side effects of your vancomycin is red man syndrome. They are going to release histamine from your mast cell. From the mast cell, it is going to release histamine. It is going to release histamine. And do you all know that we will be discussing anyway about histamines also today? But remember, histamine is going to cause redness. It is going to cause inflammation. It is going to cause inflammation. That is the problem with this histamine release. Clear, right? Now coming towards your ototoxicity. So remember, your glycopeptide vancomycin again causes ototoxic. Again, it is going to cause nephrotoxic. Remember, how do you dose your vancomycin then? We will be dosing according to the weight divided by creatinine clearance. According to the creatinine clearance and weight, we have something called as Matt's case normogram. This Matt's case normogram is used for vancomycin dosing in case of nephrotoxic patient. In case of renal failure patient, you go with the creatinine clearance, which you will be measuring in the graph, and you will be giving your glycopeptides. And what are the uses? So this you are going to give in the MRSA, as I already told you, and bacterial meningitis along with ceftriaxone. You remember, like ceftriaxone we will be giving, vancomycin. What is the third drug we will be giving? Can you tell me what is the third drug you give in neonatal meningitis? Along with ceftriaxone and your vancomycin, what is the third drug you will give in case of a neonatal meningitis? Can you tell me? Ampicillin. Excellent. Ampicillin is going to be the third drug which you are going to give. Excellent, excellent. Now coming to the oral drug. Oral, when you will give, when it has to act over in the gastric area. So in case of colitis, Pseudomonas colitis, staphylococcal enterocolitis, they will have a direct action. So oral drug கொடுத்தோம்னா they will not be absorbed. Remember, vancomycin will never get absorbed. Vancomycin will never get absorbed. So vancomycin systemica வேணும்னா you should not give oral route. Vancomycin, when they want to be destroyed, so vancomycin நம்ம போறப்ப என்ன ஆகும்னா they will be destroyed in your colon itself. But destroy ஆனோம்னா colonல அது function ஆயிடும். Like your pseudomembranous colitis, staphylococcal enterocolitis. அந்த கேஸ்ல you can give. Next, coming towards your MRSA, you now know what is MRSA. I believe that you all know what is MRSA. Beta lactams are ineffective in the MRSA, except your what? Can you tell me which drug is going to be effective in beta lactam? MRSA. Can you tell me the only beta lactam group of drug which is effective in case of MRSA? Can you tell me in the chat box? Can you tell me in the chat box? Which generation cephalosporin? Which generation cephalosporin and what drug? Fifth generation. Can you name the drug? Can you name the fifth generation drug? Ceftaroline and what is ceftaroline and what is the other drug? Ceftaroline one. What is the other drug? Can you name it? ceftobiprole. So ceftobiprole. Loss of potassium ions. So whenever there is a loss of potassium ion, what happens? It causes bactericidal. It causes bactericidal. So mechanism of action, depolarization of the cell membrane. So there is a depolarization of the cell membrane. What are the side effects, guys? Side effects, myopathy. You're going to remember the side effects is myopathy. Never added to statins. So you should never add statins along with daptomycin. And they are not used in pneumonia. So remember, they are not used for pneumonia. They are not used for pneumonia. Surfactant action. So so it is going to have opposite action on surfactant. Your daptomycin is going to have a opposite action on the surfactant. So therefore you are not using. So you are not using when you are going to take a statin. You are not going to use when there is going to be a pneumonia in the patient, and they are used in the MRSA and VRSA gram positive bacteria. So they can be used in the MRSA, VRSA gram positive bacteria. Now you're clear what is daptomycin, isn't it? So daptomycin is over. Next one, you have to know what is this telavancin. So what is this telavancin? They are the lipoglycopeptide. So glycopeptide is one, that is going to be a vancomycin and your vancomycin and your teicoplanin. Teicoplanin. Now you are going to have your telavancin. What is telavancin? They are going to be lipoglycoprotein. So adinala enna, what is the dual target? It is going to target your cell wall as well as your cell membrane. So cell wall, you're going to have your cell wall which is going to get targeted by your lipopeptide. Okay, lipopeptidase enzyme. And then you're going to have the second one, that is going to be your cell membrane. Cell membrane target பண்றது யாரு? உங்களோட vancomycin. So now you know what is going to be your lipoglycopeptide. Third one, polymyxin B or colistin. So இது வந்து polymyxin B you would have seen and the powder formatல ஒன்று வரும். Most probably you would have seen. Okay, Nebo-self powder. You would be your mother and your grandmothers would be using that. They add in their home itself. So it was very previously used as whenever there is going to be any injury, to avoid the bacterial contact, they'll be using this powder. So polymyxin B is one such topical applicating powder which is used. And colistin is going to be used as a last option for multi-drug resistant. So vancomycin use agala, linezolid use agala, 5th generation cephalosporin use agala. Then you come for the colistin. So colistin is a very last drug. So they are going to be called Klebsiella, Pseudomonas, and the infection you can give. But the only problem is going to be they will be causing superbugs. So when you're going to use this colistin in the initial days itself, what happens? They will be becoming even resistant to all those vancomycin, linezolid, colistin. So you cannot treat that patient. So that is a problem with that. And what is the side effect? You have nephrotoxicity and neuromuscular conduction inhibition. So these are the side effects. So we have already seen protein synthesis inhibitor. Do you remember? Linezolid, streptogramin, clindamycin, okay, mupirocin, okay, all this will also act on the MRSA. Similarly, you have something called as dilafloxacin and rifampicin. So rifampicin is used in the anti-TB drug, isn't it? So rifampicin as well as your dilafloxacin, they are also going to be acting against the MRSA. Are you clear? Now we have completed most important topic, that is going to be in your antibiotic. Antibiotic most important topic is already over. Now we are left with only the important thing is antifungal is left with. We have left with antiviral and some anti-metabolite drug. Anti-metabolite, then we go for antifungal and antiviral. So அதுக்கு முன்னாடி fluoroquinolones அப்படிங்கிற ஒரு topic also left with. That also I will teach. Okay, let's come back at around okay, let's come back around 2:15 p.m. Let's come back at 2:15. We will start discussing with this topic. Okay, so clear? I will not close the meeting, so don't worry, I will not close the meeting. The meeting will be still on. So if you want, you can leave it as such and go. Otherwise, what we will do is we will come back at 2:15, then we will start discussing. Okay, thank you. So good evening, good afternoon once again. So we're going to start with the next group of drugs, that is going to be your anti-metabolite. So when I'm going to tell anti-metabolite, okay, so what is that anti-metabolite? So metabolic function of a cell. Okay, we have discussed at the starting of antimicrobial. Do you remember? At the starting of antimicrobial, I was telling, right? I was telling that you are going to have a cell wall inhibitor, cell membrane inhibitor, nucleic acid inhibitor, ribosomal inhibitor, and then we have anti-metabolite. This anti-metabolite basically is going to inhibit your enzymes. Okay, so you have many enzymes. These enzymes are going to be inhibited. So for example, okay, so you are going to have a PABA, you are going to have your pteridine, you are going to have glutamate. PABA, pteridine, glutamate. These are going to be, when given in a bacteria, what happens is they are going to be taken up by the bacteria for the folic acid synthesis. So you're like human being. Even the bacteria requires folic acid for synthesis of DNA. Okay, in order to synthesis DNA, what is the basic metabolites which are required? You require a PABA, you require a pteridine, you require glutamate. So all these substances taken up by a bacteria, and there is going to be a folic acid synthase enzyme. This folic acid synthase is going to be obtained. Okay, so when it is going to be obtained by human, you know, it is obtained from the food. So when we are eating, we will be getting that folic acids, all the byproducts are got, and then we will be synthesizing folic acid. Similarly, okay, your bacteria also, they are going to take this dihydrofolate reductase, they will be getting this folate, and this FH4 is used for the DNA synthesis, very similar to that of the human. So what we are going to do is, we are going to either inhibit the folic acid synthase enzyme. Okay, either we are going to inhibit the folic acid synthase enzyme, or the second thing is we are going to inhibit the dihydrofolate reductase. So if you want to inhibit the folic acid synthase, what is the drug you are going to give? Sulfonamides. So sulfonamides are the drug which is given in folic acid synthase enzyme. So that is going to be bacteriostatic. Okay, they are not able to reproduce, they are not able to multiply. So therefore, we are calling it as a bacteriostatic. And then you are going to have your pyrimethamine and your trimethoprim. These are going to be the drug that is going to act by inhibiting the dihydrofolic reductase. So you have three drugs I am talking here. Number one is your sulfonamides. Number two is going to be a pyrimethamine and trimethoprim. So all these three are going to be anti-metabolite drug. So the one which I call it as anti-metabolite are nothing but number one, it is going to be sulfonamide. Number two, pyrimethamine, and number three, you have trimethoprim. So what happens when you are going to do this? I'll tell you. So you have something called as sulfadiazine. When you're going to combine sulfadiazine along with your trimethoprim, what happens? Remember, sulfadiazine is going to be a bactericidal. So it is going to be a bactericidal. Now you are going to, along with that, you are going to have trimethoprim. This will help in the toxoplasmosis. So what is going to be the drug of choice in toxoplasmosis? It is going to be your sulfadiazine and pyrimethamine. But we read already that in pregnancy for toxoplasmosis, we are going to take spiromycin. This is the one point I told before the lunch. Okay, so spiromycin is a drug of choice in pregnancy for the toxoplasmosis. But in the normal cases, what is the drug of choice in toxoplasmosis? It is going to be sulfadiazine plus pyrimethamine. Okay, second one, sulfadoxin. Sulfadoxin, all these are the sulfonamide group of drugs. Sulfonamide group of drugs. So sulfadoxin is also added with your pyrimethamine, where in malaria, do you remember the malaria drug? So sulfadioxin and pyrimethamine is going to be the drug of choice in case of malaria. You are going to give that in case of malaria. Number three, where else will you use? Number three, we are going to use In case of sulfamethoxazole with trimethoprim, we will be using as cotrimoxazole. Now, do you remember? So, you have a drug which commonly available in the market, that is going to be a cotrimoxazole. This cotrimoxazole is nothing but they are the combination of sulfamethoxazole. Sulfamethoxazole is a sulfonamide. What it is going to do? It is going to inhibit your folic acid synthesis. Then folic acid synthase. Then it is going, what is your trimethoprim? That is going to inhibit your dihydrofolate reductase. Dihydrofolate reductase. So when you're going to combine these two drugs when you're going to combine, that is called as cotrimoxazole. The next question that you have to ask me is, what is the combination? Okay, what is the amount or what is the combination of your cotrimoxazole? So it's a sulfonamide and trimethoprim combination. Sulfonamide 600 mg almost. So 400 mg sulfamethoxazole and trimethoprim around 80 mg. 400 mg and 80 mg. Sulfamethoxazole or your that is going to be around 400 mg, and you are going to have your trimethoprim that is going to be around 80 mg in 5:1 ratio. Okay, cotrimoxazole is used as a drug of choice in case of pneumocystis jirovecii pneumonia. Can you tell me atypical pneumonia? What is a drug of choice? What is a drug of choice in atypical pneumonia? We saw before the lunch. What is a drug of choice in case of atypical pneumonia? Atypical. When I tell atypical pneumonia, what is the drug of choice? Can someone let me know in the chat box? Atypical pneumonia. I think Revati, Kavita and all had come back. So hopefully they will remember, I guess. So what is the drug of choice in case of atypical? Yes, of course, very good. Macrolides. Which macrolides in particular you will be giving? Atypical bacteria, which macrolide you will be giving specifically? Can you tell Afif? Can you tell which bacteria will you give? Azithromycin, excellent. So azithromycin is a drug of choice in atypical bacteria, whereas in pneumocystis jirovecii bacteria, the drug of choice is going to be cotrimoxazole. So drug of choice is going to be cotrimoxazole. That's all. That comes to the end of discussion of your sulfamethoxazole. Second one is going to be your nocardiosis. So nocardiosis also we will be using, and cyclospora we will be using. Remember, if you want to give a prophylaxis for your pneumocystis jirovecii. In which condition pneumocystis jirovecii is most common? Means in case of AIDS. Okay, in AIDS you have this pneumocystis jirovecii which is more common. So AIDS when the CD4 count is going to be reduced than 350, or when the patient is going to be developing a WHO stage 3 or stage 4 HIV, then what you're going to do? You're going to give a cotrimoxazole as a prophylaxis in case of pneumocystis jirovecii. Clear? Okay, clear, right? So now we have completed what is cotrimoxazole. Okay, we have completed what is sulfamethazine or sulfa group of drugs, sulfonamide, and you have completed pyrimethamine or trimethoprim. Now one question to you all. How does this, okay, sulfa group of drugs gets metabolized? Can anyone tell me how does this sulfa group of drugs gets metabolized? This is a very important drug, guys. Why I'm asking this is one of the previous year MCQ that has been asked, and this is going to be a very important question from your general pharmacology. Anyone? Anyone? Do you know how does the sulfa group of drug gets metabolized in the phase 2 reaction? Acetylation, excellent. Can you tell me what are the other drugs of acetylation, Kavita? What are the other drugs that are going to be metabolized by acetylation? What are the other drugs that are getting metabolized by acetylation? I'll tell you a simple mnemonic to remember. Kindly note it down. SHIP. Remember SHIP. S stands for sulfa group of drugs. H stands for hydralazine, and I stands for isoniazid, and what does P stands for? Procainamide. So, okay, why this is important, I'll tell you. In SLE, okay, so SLE, that is going to be a systemic lupus erythematosus, you should never give drug that is metabolized by acetylation. That will cause us increased, or they can worsen the SLE. So that is why you are not giving the SHIP drug. So what are the contraindication in the SLE? The contraindication are all the SHIP drugs, sulfa drug, hydralazine, isoniazid, and procainamide. Okay, they causes drug eruption in the skin. They are going to cause sulfa allergy. They will be causing a drug eruptions in the skin. Okay, so you have to remember that. Now, moving on to talk about the fourth use. First use we discussed, that is going to be in the toxoplasmosis. Second use in malaria. Third, cotrimoxazole used in 3 conditions. Okay, in pneumocystis jirovecii, nocardia, and we discussed about the cyclospora. Now coming to the fourth important, where we are going to use, that is going to be your topical use. Where we are going to use this topical drug, we are going to use in case of burns. Do you remember Bernol? In the earlier days and all, it will be like reddish in color, coming in a red color the box, or it comes in a red colored iron or a steel box. Do you remember? So that is nothing but your silver sulfadiazine. Silver sulfadiazine, mephenide, sulfacetamide, all these are the usage in the topical application. Silver sulfadiazine and mephenide is used as a cream in burns and infection, whereas sulfacetamide is used as an eye drop in trachoma. Is it clear? Next, we are going to move towards the second. So we have completed 4 important drugs. What are the 4 important drugs? Sulfadiazine plus pyrimethamine used in toxoplasmosis. Sulfadioxin and pyrimethamine used in the malaria. Sulfamethoxazole and trimethoprim used in the cotrimoxazole, used in the pneumocystis jirovecii, nocardiosis, cyclospora. And finally, topical application, we have silver sulfadiazine, mephenide and sulfacetamide. Clear, right? Now, what are the side effects? I already told you the side effects. Sulfa allergy. Fixed drug eruptions occurs in the skin. And in pregnancy, if you are going to give sulfa drug, what is the problem? This sulfa drug will be displacing your bilirubin. Displacing your bilirubin, leading to kernicterus. They will be displacing your bilirubin from your bilirubin binding protein, and that will be leading to kernicterus. Free bilirubin level narayaidu. Free bilirubin is going to go and attach to the blood-brain barrier, and they are going to cause kernicterus. And third one is acute attack of porphyria. When there's acute attack of porphyria will be occurring when you are going to give sulfa drug. Not only sulfa drug, but alcohol, barbiturate, ketamine will also cause acute attack of porphyria. And finally, you're going to have the hemolysis in G6PD deficiency. In G6PD deficiency, hemolysis will be occurring. And drugs causing SLE, you already know, sulfa-containing drug, hydrolazide, isoniazide, and procainamide. And finally, drug eruption in the skin. Can someone tell me in the chat box what is procainamide? Where will we use procainamide? What is the application of procainamide? Can someone tell me in the chat box? We are going to discuss anyway today in detail about procainamide. But can you tell me what is this procainamide? What is the action of procainamide? Can someone tell me what is the action of procainamide? What is going to be the role of procainamide? It is actually an anti-arrhythmic drug. Anti-arrhythmic drug. When we are going to read the central, when we are going to read cardiovascular system, I'll be telling you procainamide is nothing but it is an anti-arrhythmogenic drug. It's an anti-arrhythmogenic drug. So we will discuss. Don't worry, we will discuss about that anyway. Now moving on to discuss about the drug eruptions in the skin. So drug eruptions will also occur in the skin. Now we are left out with the nucleic acid inhibitor. Now we have discussed all others. Now the only thing left out is going to be your nucleic acid inhibitors. So nucleic acid inhibitors, like I already told you, the RNA polymerase inhibitor is going to be 2R. Rifampicin and rifabutin. Rifampicin and rifabutin are the RNA polymerase inhibitor. Then second one, they are not going to bind to any RNA or any nucleus. But what it is going to do is they are going to cause a free radical injury in the nucleus. When there is a free radical injury in the nucleus, what happens? The nucleus dies. So the example of free radical damage is nitroimidazole. I think Dinesh is not there. So Dinesh was constantly asking me about one drug that is going to be your metronidazole. So what is this metronidazole? Metronidazole is nothing but it is a free radical damaging drug. So what it basically does is it's a nitroimidazole group of drugs. They are going to be metronidazole that is going to cause damage to the nucleus by inhibiting the DNA synthesis by the free radical injury. Clear, right? That is going to be the mechanism of action of your nitroimidazole or metronidazole. Where all you're going to use is metronidazole, though it is antibacterial in nature. So they are not classified as under antiparasitic or anti-helminthic. We will not classify. But then metronidazole is a only antibiotic that is also used as an anti-parasite. So they are going to be used against the amoebiasis. In amoebiasis, you are going to use in case of a giardiasis, in case of trichomonas vaginalis, in case of bacterial vaginosis. In all these 4 conditions, we are going to have the usage of metronidazole. You're going to have the usage of metronidazole. So what in amoebiasis, what happens? In amoebiasis, there is going to be a tissue Okay, tissue level drug is going to enter. When they are going to enter at the level of tissue, what happens? It is going to kill the trophocytes. Okay, so it is going to kill the trophocytes. Similarly, luminal na another cyst. So it is going to kill the cyst also. So which is going to be the drug of choice for killing the trophocyte? So killing the trophocyte, you have to have your metronidazole. Metronidazole is a drug of choice for killing the trophocyte. But for killing the cyst, which is the drug of choice? For killing the cyst, the drug of choice is Paromycin. For killing the cyst, the drug of choice is going to be Paromycin. Paramycin. Where else we saw Paramycin? Can you tell me? What is your Paramycin? Can you tell me which group Paramycin comes under? Which group your Paramycin comes under? Can you just recall and tell me? In which group we read Paramycin? Come on guys, in which group we read Paramycin? Can you tell me exactly? Very good. Aminoglycosides, streptomycin, paramycin, neomycin. There did we what we read? Paramycin is a drug of choice for Kala Azar. Okay, it's a first line of drug for Kala Azar. It's a first line of drug for the cryptosporidiosis. It's a first line of drug for your luminal amoebiasis. But what is the DOC of luminal amoebiasis? I told you to note down there. Can you recall and tell me what is the drug of choice in luminal amoebicide? Which is the drug of choice of luminal amoebicide? Can you tell me what is the drug of choice of luminal amoebicide? I told you to write down there. Can you tell me what is going to be the luminal amoebicide drug of choice? It is going to be your dilenzoxide furet, diloxonide furet. Do you remember? Yes. The very good Kavita, it's diloxanide furet. Diloxanide furet is going to be the drug of choice. Okay, but it will act as a luminal antibiotic. Similarly, okay, even in this metronidazole, they are going to act as a luminal amoebicide. But which is going to be the drug of choice? Paromycin is a drug of choice. Okay, you can also have the diloxanide, but remember, diloxanide is going to be a drug of choice in India. If you're going to see India, diloxanide is a drug of choice. But if you're going to write a USMLE or PLAB exam in your future, the drug of choice is going to be paramycin only. So that's what I want you all to remember. Paramycin is drug of choice elsewhere in the world, but in India, it's going to be a diloxanide furet. Now coming to the Trichomonas vaginalis is there, giardiasis is there. Giardiasis, we give tinidazole more common than the metronidazole. Than metronidazole, we go for tinidazole, and Trichomonas vaginalis also we go for metronidazole, and bacterial vaginosis. How do you confirm a bacterial vaginosis? Can you tell me what are the features? What is going to be the clinching feature of bacterial vaginosis? Can someone tell me how will be the smell appear? How will be the odor appear? In bacterial vaginosis, clue cells, okay. What will be the order? So how the patient comes and tells you, how you will have the order? What is the characteristic order you will get in a bacterial vaginosis? Can you recall and tell me? You know that. You all know the answer. Can you recall and tell me? In your microbiology, you would have read. Very good, very good. It's a fishy order. So you're going to get a fishy order. It's a characteristic feature. You're going to get a clue cells. What is clue cells? Have you ever questioned what is clue cells is? Have you ever questioned what is clue cells, which you are going to have? What is a clue cell? Anyone know what is clue cells are? They are nothing but the squamous epithelium is there, right, in your vagina. Into the squamous epithelium, there will be a intranuclear inclusions. These intranuclear inclusion bodies of your squamous cells are only called as your clue cells. This most of them don't know. Right now, you will be the use 4 will be the person who will be knowing in your class itself. So just try and ask your friends. They might not know this. Remember, it's nothing but a squamous intranuclear inclusion cells. They are your clue cells. Clear? So what is the drug of choice in that? Bacterial vaginosis, it is going to be again metronidazole. And in your anaerobic infections, and when there is going to be drunken closis, so in the drunken closis also, guinea worm, there also you're going to give this metronidazole as drug of choice. Clear? So now first one we saw is RNA polymerase, rifampicin and rifibutine. Second one, free radical damage, you're going to have metronidazole. The third one is going to be your DNA gyrase inhibitor. Remember, DNA gyrase inhibitor is nothing but they are going to remove the supercoiling. So removing supercoiling is going to be done by your DNA gyrase. And the supercoil removal process inhibit பண்றது வந்து DNA gyrase inhibitor. Example is going to be your fluoroquinolone. They are bacteriocidal in nature. They are also bactericidal in nature. Okay. Now, coming towards the first generation, second generation. So, fluoroquinolones is classified into first generation and second generation. What is first generation fluoroquinolone? Very easy. First generation fluoroquinolone are nothing but norfloxacin, ciprofloxacin, and ufloxacin. Norfloxacin, ciprofloxacin, and ufloxacin. They are going to be inhibitor of DNA guidase. Okay, they are going to be inhibitor of DNA guidase. They act on gram-negative bacteria. So they are going to act on gram-negative bacteria. Very important. What are the uses of it? See, very important. Listen carefully. The uses which you are going to give is first one, UTI. Okay, we already know bacterial vaginosis will lead to UTI only. So there can be two type of UTI. One, it can be a uncomplicated UTI. When you will call it as uncomplicated UTI, when it is going to be just cystitis in a female, or when it is going to be when there is going to be a bleeding. Okay, when there is going to be bleeding, when there is going to be involvement of your kidney, then all this you call it as a complicated UTI. So in uncomplicated UTI, what is the differential? What is going to be your treatment of choice? It's cotrimoxazole, nitrofurantoin, fosfomycin. Where did you read fosfomycin? Can you recall and tell me? Fosfomycin. Where did you read this fosfomycin? Let me see who is going to tell. Where did you read fosfomycin? Where did you read fosfomycin? Can you tell me? Can someone tell me where did you read fosfomycin? What is the usage or what it is? Let me see who is going to tell. We have talked about fosfomycin already. Where did we talk about fosfomycin? Try to recollect. Don't just stick to the notes or don't just stick to the whatever we are reading. Fosfomycin. What is your fosfomycin? Can you recollect and tell me? I'll give you time. Fosfomycin. Where did we read fosfomycin till now? No one. No one is remembering where did we read fosfomycin? Revati, Kavita, no one? Miscellaneous drugs in சொல்லி கொஞ்சம் பார்த்தோம். Protein synthesis inhibitor. Yeah, so UTI ku fosfomycin is given, you are right. Okay, so where did we read this fosfomycin? I was asking you. Fosfomycins are nothing but they are also going to be a nucleic acid. They are going to be also a what to tell? They are going to be a ribosomal. Okay, protein synthesis inhibitor. We have seen extra miscellaneous drugs in path. We have seen fosfomycin. Okay, similarly, here also you are going to read fosfomycin. Fosfomycin is also going to be a drug of choice for your uncomplicated UTI, but the main is going to be cotrimoxazole, nitrofurantoin, and fosfomycin. But when it is a complicated, you are going to go for nitrofurantoin, fosfomycin, and your cotrimoxazole, except moxifloxacin. Okay, you can go for any type of fluoroquinolones, ufloxacin, ciprofloxacin. You can go for a norfloxacin in complicated and uncomplicated UTI. But which drug you should never go in a UTI? That is going to be a moxifloxacin. So moxifloxacin you should never go in case of UTI. Write it down. So because okay, why? Because your moxifloxacin is going to go by bile excretion. Anything that is reaching your urine, only then they can help you with urinary tract infection. If they are not going to reach your urinary tract, there is no local action itself. So moxifloxacin is not used. And now coming to the infective diarrhea, norfloxacin and ciprofloxacin are the infective the drug of choice in case of infective diarrhea, norfloxacin or ciprofloxacin. But you can also go for ufloxacin. Can also go for ufloxacin. Now coming to the prophylaxis of meningitis, Haemophilus influenza, you have to go for rifampicin. Whenever there is going to be hemophilia influenza causing meningitis, Haemophilus influenza type of meningitis, what is going to be a drug of choice? Drug of choice is going to be rifampicin. Now, when I have just sent you one PDF where we have some MCQs, if you're going to go and see, I have just sent you some PDF in the group where we have around 200 MCQ. In that, I have mentioned in the part 2 paper, there is going to be question number 57. So in part 2, question number 57, there is a question. Okay, in part 2, question number 57, there is a question asking you prophylactic drug of choice for hemophilus type of meningitis. The answer is going to be rifampicin. The answer is going to be rifampicin. Kindly note it down. Next, coming towards your meningococcal meningitis, the answer is going to be ciprofloxacin or ceftriaxone. Either you can go for ciprofloxacin or ceftriaxone. Can you answer in the chat box? What are the other drugs which we are going to use in meningococcal meningitis or bacterial meningitis? What are the drug combination we are going to give in case of bacterial meningitis? Can you put in the chat box? Let me see. Bacterial meningitis. What is going to be the drug of choice which we are going to give? In case of bacterial meningitis, what is the drug of choice? Can someone put in the chat box? What is the drug of choice in case of bacteria? Ampicillin, okay. But drug of choice, when I'm going to ask drug of choice, you're going to tell me which drug? Bacterial meningitis. Vancomycin, combination lo one correct, meedi rendu drug. Vancomycin, what is the main drug you give? Very good, ceftriaxone. So vancomycin and ceftriaxone, and you're going to give one more drug. You're going to give one more drug to cover listeria. That is your ampicillin. So ampicillin, ceftriaxone, vancomycin is going to be the drug which is given in case of any bacterial meningitis. In the combination you're going to give, and when there is going to be hemophilus influenza type of meningitis, you're going to go for rifampicin, and you can also go for ciprofloxacin. Clear. Now coming to the anti-pseudomonal. So can you tell me what is the anti-pseudomonal drug which you have already seen? Carbapenem, aztreonam. So carbapenem, aztreonam already we saw. Now, and also you saw carboxy and uridopenicillin. Now, and you have also seen ceftizidime, cefoperazone, cefepime. So all these are going to be acting anti-pseudomonal. Anti-pseudomonal. Again, you have your aminoglycoside, which is going to be anti-pseudomonal. Colistin, which is acting anti-pseudomonal. And along with that, you are also going to have ciprofloxacin and levofloxacin. But the problem is, whatever we read till now in the anti-pseudomonal, carboxy or uridopenicillin, ceftazidime, ceftriaxone, cefepime, carbapenem, acidinum, and then you have aminoglycoside. Okay, tag. What is tag group of drugs? Can you name it? Tag group of drugs in aminoglycoside. TAG. What TAG stands for? Can you tell me what is the TAG stands for? T stands for? What is TAG? T stands for? TAG. You have something called as T. You have something called A. Togramycin. It's called tobramycin. Excellent. Next one. Next one. T stands for. A stands for amikacin. Excellent. What does G stands for? Tobramycin, amikacin. G stands for? G is easy. Gentamicin, very good. So these three drugs, again these three drugs are given as a injection only, and colistin given as injection. But the only oral drug which is going to be given as an anti-pseudomonal is going to be a ciprofloxacin or levofloxacin. So ciprofloxacin, levofloxacin is a only oral anti-pseudomonal. I want you all to note it down. Only oral pseudomonal is going to be a ciprofloxacin or levofloxacin. Clear, right? Then coming towards your side effects. So what are the side effects? So only 4 uses we have seen. 4 uses of fluoroquinolone first generation. What are the 4 uses? Uncomplicated UTI, complicated UTI, infective diarrhea, prophylaxis of meningitis, and finally anti-pseudomonal. Clear, right? Now coming to the side effect. Number 1, it can lead to tendon damage. It can lead to tendon damage. Before moving to that, let me also tell you about the second generation. So first generation is going to be your norfloxacin, ciprofloxacin, ufloxacin. We have second generation drug that is going to be levofloxacin, gatifloxacin, and moxifloxacin. So all these are going to be gyrase inhibitor and topoisomerase 4 inhibitor. Gyrase, topoisomerase, renduthing inhibit பண்ணுது. They are going to act on both gram negative as well as gram positive. Gram positive தான் நிறைய more than gram negative. So pneumococcus it is going to act. So what is the example? Respiratory fluoroquinolones. Any infection, respiratory infection caused due to fluoroquinolones, you are going to go for what? So you're going to go for your second generation, that is going to be levofloxacin, gatifloxacin, and moxifloxacin. Okay, now moving towards your side effects. So side effects, tendon damage or cartilage damage. So it is contraindicated in pregnancy. It is contraindicated in children, and there can be rupture of tendon of Achilles. Okay, then coming to, there's an increased chance of seizure as it is a GABA antagonist. You all know that they are also going to be a GABA antagonist. So it is going to be increasing your seizure risk. And which that is the reason there is a ban on gatafloxacin and sparfloxacin. So gatafloxacin and sparfloxacin is banned now. Gatafloxacin led to dysglycemia, and your sparfloxacin led to QT prolongation. Okay, QT prolongation and photosensitivity. Therefore, what are the 2 drugs that are going to be banned in your fluoroquinolones? They're going to ask you gatifloxacin and sparfloxacin. Clear, right? Then comes the 4th one, elimination of urine. It is not safe in your renal failure. What are the drugs? Remember PMT. The PMT drugs are not safe in the your renal failure. What are the drugs? Okay, P-floxacin, moxifloxacin, travofloxacin. What are the three floxacins which you are going to contraindicate in renal failure? Okay, which can be given in renal failure. What are the three fluoroquinolones which can be given in renal failure? It's a PMT. P-floxacin, moxifloxacin, travifloxacin. P-floxacin, moxifloxacin, travifloxacin. Is it clear? These are the three drugs which are going to be given in case of a renal failure. So they are not safe in your liver failure. But what happens? They are not safe in the liver failure. And ultimately what happens? These three drugs cannot be given in UTI, urinary tract infection, cannot be given in UTI. Why? Because they are not going to be soluble in water. They are not going to be coming out in urine. Therefore, what happens? No use, no local action for your moxi or travofloxacin. So there is going to be not useful for your UTI. So what is going to be a drug we are going to give? What is the amount? So you can give 100 mg moxifloxacin daily as a single dose, or you can go for 25 mg per day into 4 doses. 25 mg in 4 doses you can give per day. So this is going to be your thing. Now what happens? So you have to know this important concept. I'm just going to introduce you one important concept, that is a single dose divided dose. What is a single dose and divided dose? See, some drugs you should give single dose. Okay, you should not reduce the dosage. Some group of drugs you can divide and give the dose. Why? Because some drugs are going to be concentration dependent killing. Once you are going to attain 80% of plasma concentration, that will kill the bacteria. So that is concentration dependent killing. Whereas there is this other thing called as time dependent killing. It depends on how much time the concentration of plasma concentration is maintained for that drug. For example, if you're going to maintain for 2 hours, okay, of 40 mg per deciliter concentration, then only the bacteria will die. Those bacteria are called as time dependent killing, and the bacteria which is going to, okay, or the drugs which is going to do a concentration dependent killing. Concentration dependent killing are better. Okay, the drugs, these drugs, single dose drugs are better, have a CDK when they are given as a single dose. Okay, for example, aminoglycoside, rifampicin, fluoroquinolone, அதெல்லாம் வந்து ஃபிக்ஸட் டோஸ். இதுக்கு கீழே நீங்க குறைக்க கூடாது. அமினோகிளைகோசைட் ரெண்டா உடைச்சு மார்னிங் ஆஃப் நைட் ஆஃப் கொடுக்கலாமான்னு கேட்டீங்கன்னா நோ, யூ கேனாட் கிவ். ஓகே, சிமிலர்லி யோர் fluoroquinolone, similarly your rifampicin, they are concentration dependent killing. Whereas divided dose வந்து பாத்தீங்கன்னா they called as time dependent killing. Okay, so it can be divided in the divided dose and given. For example, your beta-lactam group of drugs. So what we will give? We will be having your, okay, for example, amoxicillin, amoxiclav. So most probably how you will take amoxiclav? So morning 1 dose, night 1 dose. Why do you take a morning 1 dose and night 1 dose? Only then the bacteria will be killed, because they are time-dependent killing. If you are going to forget after taking morning, if you are going to forget the dosage at night, then the antibiotic you have taken becomes useless. Okay, so that is called as your time dependent killing. So time dependent killing example is your beta-lactam and 5-fluoro. Okay, you're going to have your 5-FC. Okay, then you're going to have your 5-FC. Clear, right? Do you have any doubt till now? Do you have any doubt till now? So because we have completed antibacterial, 5-fluorocysteine. Okay, it's a 5-flucystosin. 5-flucystosin. So it's nothing but 5-flucystosin. That is going to be again an antifungal medication, 5-fluorocystosin, which we will be discussing later today. So are you all clear with antibacterial? Can you put respond in the chat box if you are all clear with antibacterial, so that I can move towards antifungal and antiviral? Are you all clear? Very good. So with the understanding that you have all understood the antibacterial, so I'll give a short recap. Just listen carefully. So first we started with the protein synthesis inhibitor. Among the protein synthesis inhibitor, we had 30S ribosomal subunit inhibitor and 50S ribosomal subunit inhibitor. So we had only two drugs under 30S ribosomal inhibitor. What are the two drugs? Aminoglycosides and your tetracycline. Then we have small SMALLLC. So these are the drugs which we saw under the heading for 50s ribosomal subunit. Then we moved on to cell membrane inhibitor, cell wall inhibitor. Then we discussed about a very good interesting topic that is going to be your nucleic acid inhibitor. Then we have also discussed about the glycopeptide inhibitors. After completing all these, now we are going to move into the next one, that is going to be your antifungal drug. Are you all ready to move into the antifungal drug? See, antifungal drug, just try to draw this diagram. First, you are going to have a nucleus. Outside the nucleus, you are going to have the second layer. What is that second layer? That is going to be your cell wall, cell membrane. Out of that, you are going to have a cell wall. Okay, 3 layer. So what is your cell wall made up of? Cell wall is made up of beta glucan. So cell wall is made up of beta glucan. Cell wall is made up of beta glucan. So beta glucan இருக்கு. அதுக்கப்புறம் கீழே வந்து cell membrane, blue colorல இருக்கிறது வந்து cell membrane. That is going to be made up of ergosterol. That is going to be made up of ergosterol. So first one is going to be a beta glucan. Second one is going to be your ergosterol. So ergosterol is over. Third one is going to be your nucleic acid. What are the different drugs which you are going to give? Either you can go for the drug that is going to inhibit your beta glucan. So the drug that is going to inhibit your beta glucan. Example is going to be a echinocandin. So the one that is going to inhibit your cell wall synthesis of beta glucan. Example is going to be echinocandin. So what are the examples of echinocandin? Number 1, micafungin, capsofungin. All the drugs that are going to end with the terminology called as fungin are going to be your cell wall inhibitors. Under which class that they come? So under class of, okay, under the class of beta glucan inhibitor, echinocandins. Now we have your cell membrane. So cell membrane is made up of ergosterol. Okay, cell membrane is made up of ergosterol. How is this ergosterol formed? So there is a squalene. This squalene gets converted to lanosterol. So it's going to get converted to lanosterol in the presence of epoxide. Your squalene gets converted into a lanosterol in the presence of epoxide. This lanosterol gets converted to ergosterol in the presence of demethylase. Squalene gets converted to lanosterol in the presence of epoxide. Lanosterol gets converted to ergosterol in the presence of demethylase. So what are the true drugs you have to remember? One is epoxide, one is demethylase. Epoxide converts squalene from your squalene from your lanosterol. So lanosterol and the ergosterol convert பண்றது demethylase. So you have some drugs that are going to inhibit your epoxide. You have some drugs that are going to inhibit your demethylase. The drug that is going to inhibit your epoxide is called as terbinafine, terbinafine. So it's a terbinafine. They are going to inhibit your epoxide. Are you all clear with what is terbinafine? Next, you are going to have something called as azole. What does this azole do? This azole is going to inhibit what? It is going to inhibit your demethylase enzyme. That is going to be your azole group of drug. So now we have read 3 group of drug. Echinocandin inhibits your cell wall synthesis of beta glucan. Next is going to be your terbinafine that is going to inhibit epoxide synthesis. Then you have azoles that is going to inhibit your demethylase enzyme. Clear, right? So 3 enzymes, 3 group of drugs. Clear. Now 4th one, what happens is there can be some drug that is going to inhibit the DNA synthesis. Which is going to inhibit the DNA synthesis? That is your 5-fluorocysteine. 5-fluorocysteine is going to inhibit the DNA synthesis. Second one, some can cause inhibition of mitotic spindle formation in the cell cycle. The drug that is going to cause mitotic spindle formation inhibition is going to be your griseofulvin. So full nadakudhu. So there is no problem in the nucleus. Nucleus is full. But what happens? There is going to be problem in the mitotic spindle formation. So that is called as a griseofulvin. And then we are going to have the last one. That is going to be a sequester ergosterol. Sequester ergosterol, your Amphotericin B. You have your Amphotericin B. What happens is this Amphotericin B will be binding to the ergosterol. When the Amphotericin B is going to bind to the ergosterol, what it does is it is going to form pores. When the Amphotericin B binds with the ergosterol, they are going to form pores in your cell wall. Okay, when it is going to cause pores in the cell wall, what happens is they will be looking like a sponge. That is why you call it as a sponge type of fungal seen in the antifungal drug. Which antifungal drug? Amphotericin B. Are you all clear with this image? This image is going to give you all the drugs whichever you're going to read. So first is going to be your echinocandin. What is the mechanism of action of echinocandin? Let me see who's going to put the answer in the group. So echinocandin, what is going to be the mechanism of action of echinocandin? Can you put in the chat box? What is going to be the mechanism of action of echinocandin? Can you put in the chat box? What is the mechanism of action of echinocandin? Echinocandin. What is the mechanism of action for echinocandin? What is the drug of choice for echinocandin? Come on. What is the drug of choice for echinocandin is my question. What is going to be the mechanism of action of echinocandin? It is going to be a beta-glucan synthesis inhibitor. Very good. What is the mechanism of action of azoles? What is the mechanism of action of azoles? What is the mechanism of action of azoles? Can you tell me what is the mechanism of action of azoles? Mechanism of action of azoles. Azole group of drugs. What is the mechanism of action of azole group of drugs? Demethylase inhibitor. Excellent, Revati. Can you tell me what is going to be the mechanism of action of your terbinafine? What is the mechanism of action of terbinafine? Mechanism of action of terbinafine. Let me see who is going to answer. Mechanism of action of terbinafine. Terbinafine. Only after you answer, I'll move to the next one. Squalene epoxide inhibition. Excellent, excellent. And what is going to be the mechanism of action of 5-fluorocystosin? What is the mechanism of action of 5-fluorocystosin? Can you tell me what is the mechanism of action of 5-fluorocystosin? 5-fluorocystosin. 5-fluorocystosin. DNA synthesis inhibitor. Excellent. So remaining only 2 is there. What is the mechanism of action of griseofulvin? What is the mechanism of action of griseofulvin? Griseofulvin. What is the mechanism of action of griseofulvin? Mechanism of action of griseofulvin. It is going to be a mitotic spindle inhibitor. So mitotic spindle inhibitor. Excellent. So last one. What is the mechanism of action of amphotericin B? What is the mechanism of action of amphotericin B? What does it do? What is the mechanism of action of amphotericin B? What is the mechanism of action of amphotericin B? Last point. Last point. What is the mechanism of action of? It forms pores in the ergosterol. Excellent. So with this, we are completing the basic of antifungal drug. Now we are going to just explain each and every one in detail. First one is going to be our amphotericin B. Can you recall and tell me in one of the condition in your COVID time, during the COVID pandemic, we were using this amphotericin B. Can you recall and tell me in which condition we were using amphotericin B? In one COVID associated condition. In one COVID associated condition, we got this usage of amphotericin B. Mucormycosis, excellent. So amphotericin B is a fungicidal group of drugs. They are broad spectrum. They are used for all your fungus except your dermatophytes. Except your dermatophytes like your nail, skin, hair. Except that everywhere amphotericin B is useful. The route of administration is going to be IV infusion. They are used as a drug of choice in case of mucormycosis. That should be the first one striking in your mind. Second one is going to be a cryptococcal meningitis. So cryptococcal meningitis, you're going to start amphotericin B, but along with amphotericin B, you go for 5-fluorouracil. So that is going to be the initial treatment. After this, what you're going to do, you're going to shift it to the oral drug. What oral drug? Fluconazole. Fluconazole is an oral drug which you're going to give. Any life-threatening fungal infection. In any life-threatening fungal infection, you will be taking amphotericin B. And it's a drug of choice in case of Kala Azar. Do you remember? What is the other drug which can be given in case of Kala Azar, which we discussed earlier? What is the other drug which can be given in Kala Azar? Can you just recall and tell me what is the other drug which can be given in case of Kala Azar? Kala Azarla வேற என்ன drug நம்ம குடுக்கலாம்னு நம்ம பார்த்தோம். Can you recall and tell me? Drug of choice is going to be your amphotericin B accepted. But in Kala Azar, you can give what is the other drug that is going to be prescribed in Kala Azar. What is the other drug that is prescribed in Kala Azar? Excellent. Paromycin. Yes. Paromycin is given in the Kara Azar, but the drug of choice is going to be Amphotericin B. But the drug of choice is going to be Amphotericin B. Excellent, Revati, excellent. And now coming towards the Amphotericin B, how much you're going to give? 10 mg per kg, single dose you're going to give. So oral is going to be your miltefosine. Miltefosine is going to be the oral drug which you're going to give in Kala Azar. Miltefosine is contraindicated in case of pregnancy. Now the question will be asked like this in your MCQ. 53-year-old male who had a black nidus and eschar along the lateral aspect of the knee and lateral aspect of the leg. Okay, forearm leg. So this is diagnosed as Kala Azar. So the patient is pregnant. Okay, so okay, அப்படின்னு ஒரு கேஷன் கொடுத்துருக்கலாம். அப்போ example is Amphotericin B. அதே when the patient is given 27-year-old female pregnant, then you cannot give miltefosine. Oral drug is contraindicated. Miltefosine is contraindicated in case of pregnancy. What are the side effects? Side effects, you're going to have a infusion reaction, a very simple hypersensitivity reaction like every other drug. Then nephrotoxicity. Why nephrotoxicity? Due to hypokalemia or hypomagnesemia, due to causage of hypokalemia or hypomagnesemia. So what you have to do is, you have to make sure that, okay, what is the solution? Instead of giving us an aminoglycoside, you can give it, so instead of giving us a Amphotericin B directly, what you're going to do is you're going to add with the liposomal Amphotericin B. They will be having a minimal systemic effects. Therefore, they will have a less bone marrow suppression compared to that of a veru Amphotericin B. Compared to giving a plain Amphotericin B, you are advised to give a Amphotericin B that is liposomal. Now coming to the drugs that are acting only on dermatophytes. See, remember, dermatophytes la mattu act பண்றது வந்து griseofulvin, terbinafine. So what are the dermatophyte? What are the three areas we call it where we have dermatophyte? Can you name it in the chat box? So what are the three areas of dermatophytes which your Amphotericin B does not function? Can you tell me where your Amphotericin B does not function? Can you tell me in the chat box? What are three dermatophytes? Which three places in your body you call it as dermatophyte? Hair, skin, nail. Excellent. So on the hair, skin, nail, your griseofulvin and terminofin will be acting. See, one should be sidal and one should be static. Who is going to be sidal and who is going to be static? Griseofulvin is going to be bacteriostatic in nature. Okay, so fungostatic in nature, fungi static in nature. Terbinafine is going to be fungicidal in nature. Next question, how to remember this? See, fungi static, you have yes, right? So the drug out of your griseofulvin and terbinafine which has yes in it, that is going to be a griseofulvin. So griseofulvin is static in nature, whereas terbinafine is going to be sidal in nature. So griseofulvin you are going to give only oral drug, whereas terbinafine you are going to give oral as well as topical. You can give oral as well as topical. Clear, right? Now, what is going to be the drug of choice? So griseofulvin is a drug of choice in case of tinea capitis. So in case of tinea capitis, whereas ankylosis, okay, you are going to have any new in the onychomycosis, that is going to be onychomycosis going to be the one that occurs in the nail. There the drug of choice is going to be your terbinafine. So the drug of choice there is going to be your terbinafine. And talking about your nail polish, nowadays the nail polish comes along with your terbinafine. That is going to be your called as cyclopyrax. We call that nail polish as cyclopyrax or amaryltine. Okay, so these nail polish are also available. Now coming to the azole group of drugs. Now we completed terbinafine, griseofulvin, and we have completed the basic the drugs that are going to block your that is going to create a pores, that is going to be Amphotericin B. Now the drugs which is remaining with us going to be number 1 azoles, number 2 we have echinocandins, and number 3 we have 5-fluorocysteine. So first one we are going to discuss among them is going to be your azoles. So azoles you're going to have number 1 ketoconazole. Ketoconazole is an anti-androgenic in nature. Remember, ketoconazole, they are anti-androgenic nature. So that what happens is the patient will be developing gynecomastia on long run usage. Okay, then there is a decrease in the adrenal steroid synthesis. There's a decrease in the adrenal steroid synthesis, and they are a strong cytochrome 3A4 interaction occurs. So there's a strong cytochrome 3A4 inhibitors. So there's a strong cytochrome 3A4 inhibitor. So you have to remember that you're going to use this only in the topical. Then you're going to have a fluconazole. What is fluconazole? fluconazole is there is no ABC of ketoconazole. That is going to be anti-androgen effect or decrease in the adrenal steroid synthesis or strong cytochrome P3A4 inhibition. இது மூணுமே not present in fluconazole. They are drug of choice in 3C. What are the 3C? Number 1, it is going to be a drug of choice in Candida. Number 2, coccidioidomycosis. And number 3, cryptococcosis. Clear, right? Cryptococcosis also it is not given. And what is going to be your Candida? Candida, it is going to be a C albicans. Candida albicans. You're going to have your Candida causi, Candida gibral. Okay, it's going to be a Candida gibraltar. So what are the 3 drugs you're going to, 3 Candida species you're going to remember? Candida albicans, Candida krusei, and Candida gibraltar. So among them, remember Candida albicans, you can go for a topical azole. So you can go for topical azole. But for Candida krusei or gibraltar, so they are resistant to the fluconazole. They are resistant to fluconazole. You can give any other drug apart from the fluconazole. So you go for the itraconazole. In those conditions, you go for itraconazole. And then cut Candida. So what happened? That is going to be oral thrush. So in a topical azole, in case of topical nystatin, you're going to use topical azole and topical nystatin in case of oral thrush. And coming to vulvovaginal candida. Vulvovaginal candida, you use fluconazole. Vulvovaginal candida, use fluconazole. And candidemia, when it is going to be there in the blood, you will not go for fluconazole. Instead, you go for systemic echinocandins. Systemic echinocandins. Clear, right? Then comes the third drug, that is itraconazole. Itraconazole is a drug of choice. So your fluconazole is not a drug of choice in case of cryptococcosis, coccidioidomycosis, and Candida. Similarly, itraconazole is it's a drug of choice in case of a dermatophytes. That is going to be a Tinea capitis onycholicosis. So onycho, you know that it is going to be caused due to terbinafine, whereas Tinea capitis, you are going to give griseofulvin. Onycho, you are going to give terbinafine. For Tinea capitis, you are going to go for griseofulvin. Fourth is going to be voriconazole. Voriconazole is a drug of choice in case of invasive aspergillosis. Voriconazole is a drug of choice in case of invasive aspergillosis. And your posaconazole and isavuconazole. So your posaconazole, isavuconazole. What is this posaconazole, isavuconazole? They are going to be the treatment of choice for mucormycosis. They are the treatment of choice for mucormycosis. They are treatment of choice for mucormycosis. Clear, right? Now coming to the anti-HIV. That's all. And then last one is going to be a certiconazole. Certiconazole, they are going to be the topical azoles with antipruritic and anti-inflammatory action. With this, we are completing antifungal. Do you have any doubt in antifungal? I'll give you 2 minutes. I'll give you 1 minute exactly. Take a water or anything. Let's move towards anti-HIV. Very important and very confusing. Easily forgettable topic is going to be anti-HIV. So now time is 3:13. I'll give you 2 minutes. 3:15. Recollect all the azoles which we have discussed, all the antifungals which we have discussed. At 3:15 again, we will start with the anti-HIV drugs. Okay? Do you want, if you have any doubts, meanwhile, you post it in the chat box. I'm giving you 1 minute just to revise and just to get freshened your mind so that we can go for the anti-HIV. Please don't exit or please don't go for any other work. Just sit, just recall whatever we discussed under the heading of antifungal. Clear? So who are there? Kavita, Revati, Afif, and Siva Sanjeev. I think Siva Sanjeev is new. How is the class, Siva Sanjeev? Do you have any doubt? Is everything clear till now? Can you tell me, Shiva? Is everything clear till now? I hope for Afif, Revati, as well as Kavita, things will be clear till now. Hope so. If you have any doubt, you can post it in the chat box. If you are shy, feeling not good for telling in the chat box, you can just very well give me a PC, or you can just ping me on my personal number so that any doubt, I'll just help you out. No worries. Okay. Okay. So let us start with the anti-HIV group of drugs. So anti-HIV. So first, just start with this. You're going to have a virus. That virus is going to have a nucleus. So nucleus is going to consist of your RNA. Okay, you're going to have a DNA, RNA, everything. Okay, now what happens? This HIV is going to have something called as GP120 and GP41. Okay, it is going to consist of GP120 and GP41. What is this GP120, GP41? They are helpful for sitting over. They are going to be very helpful for coming and getting attached to the receptor which is present in your cell, human cell, called as CCR5. So you have something called a CCR5 and CXCR4. If you read your Robbins excellently, they will be giving this into the infectious disease. How beautifully they will be explaining how your HIV virus coming and sitting on your human cell and how it is entering. See, your HIV virus is going to have the GP41 and GP120. This GP120, GP41 is necessary for coming and sitting over your CCR5. When they come and sit over CCR5, what happens? Now it is going to go enter into CCR5 and they are going to cause inclusion of your HIV, okay, DNA. Now what happens? Slowly your nuclear capsid will not be allowed inside. Your nuclear capsid will not be allowed inside. Instead, what happens is only your nucleus is going to be taken inside. Now what happens? The nucleus is going to enter inside. So you're going to have your nucleus which is going to enter inside. Once the nucleus enters, what happens? It is going to cause reproduction. So there is going to be our RNA. This RNA getting converted into DNA. This DNA is again going to get converted into a protein. That protein is going to activate your immune cell. So when there is activation of immune cell, there is going to be IgG or IgM and IgG which is going to be present. So this IgM or IgG, once again it is going to cause antibody production which is going to come and attaches with your CD4. But what happens is at one particular time this CD4 will get depleted. Slowly there is a depletion of your CD4. This is what entirely happens when there is going to be entry of your HIV virus into your body. Hope you are clear with this. So what we can do is either we can inhibit the entry. How do we inhibit the entry? Number one, we can actually block the we can actually block your GP120. Either we can block your GP120. Who is the drug that is going to block your GP120? Fostemsavir. So Fostemsavir means antiviral. Fostemsavir is a group of drug. Fostemsavir is a drug that is going to inhibit the entry of your HIV virus in the GP120. Okay, what is the drug named? The drug is going to be your Fostemsavir. First drug is over. Fostemsavir. What is the second drug which you are going to remember? The second drug is going to be that is going to inhibit your GP41. So what is the drug? Enfuvirtide. Enfuvirtide. So enfuvirtide is a fusion inhibitor. We call it as fusion inhibitor. Why? Because this is very helpful for fusioning. So you have your enfuvirtide. Number one, it is going to be your, what is the drug? Fostemsavir. Number two is going to be your enfuvirtide. Fostemsavir. Enfuvirtide. Enfuvirtide is given only by subcutaneous route. Now the third one is going to be your CCR5 inhibitor. That is Meraviroc. So idla Meravirocla V looks like a 5, right? V looks like a 5. So Meraviroc. Okay, Meraviroc. That is going to be CCR5. Meraviroc is CCR5. Can you all close your eyes and repeat along with me? Till now we have three drugs. What are the three drugs? Number one, that is going to inhibit your GP120. What is the drug that inhibits your GP120? Fostemsavir. What is the drug that is going to inhibit your GP41? That is going to be your enfuvirtide. Enfuvirtide. What is the drug that is going to get inhibit your CCR5? CCR5 is inhibited by 5 இருக்கும் அந்த drugல என்ன drug? Meraviroc. Okay, so these are called as your entry inhibitors. So these are called as your entry inhibitors. There is another one which is involved. That is going to be a CD4. CD4 is necessary for binding your HIV virus. So அதனால என்ன ஆகுது? CD4 inhibitor is going to be your ibalizumab. Ibalizumab is going to be a CD4 inhibitor. So now the 4 drugs which are used as an anti-cell entry inhibitor are, number one, you are going to have your, number one, you are going to have your idolizumab. So idolizumab, very good, idolizumab. The second drug which you are going to remember is going to be Meraviroc. Third drug which you are going to remember is Enfuvirtide. Fourth drug is going to be Fostemsavir. Are you all clear with these 4 drugs? Do you want to repeat along with me? Again, Fostemsavir number 1, Enfuvirans number 2, number 3 is going to be your Ibalizumab, and what is number 4? Number 4 is going to be your Meraviroc. Number 4 is going to be Meraviroc. Are you all clear? So these are going to be called as a fusion inhibitor. Now coming to the integrase. See, remember your nucleus of your HIV virus is going to have integrase. It is going to have it is polymerase. It is going to have integrase, it is going to have protease, it is going to have polymerase. 3 important enzymes are going to be present inside your HIV virus. So what are the 3 viruses? Again, I am repeating: integrase, there is going to be a polymerase, there is going to be a protease. So now what we are doing is, we are just we are going to talk about the first one, integrase inhibitor. So what does your integrase inhibitor does? It is going to, when the RNA is going to come, by the reverse transcription, what happens? There is going to be a formation of your DNA. This DNA is going to, again, now what happens? This DNA has to get integrated. So they have to integrate with the host DNA. This DNA has to be integrated with the host DNA. Who is going to perform that? That is going to be done by, integrase enzyme. That integrase can be inhibited by the drug called as Gravir. So the drug that is going to end with the last word as Gravin. That is going to be your integrase inhibitor. So first we talked about the 4 drugs. What are the 4 drugs? Can you repeat along with me? Ibalizumab number 1, number 2 Fostemsavir number 2, number 3 Meraviroc number 3, and number 4 is Enfavirtide. So number 4 is going to be Enfavirtide. Enfavirtide is going to be number 4. Now you know those 4 entry inhibitors. And then we are talking about the integrase inhibitor. What is integrase inhibitor? You are going to have your Dolate-Gravir, Doltigravir, Elvitagravir, and then you have Raltegravir. There are 3 Gravir drugs you are going to remember. What are the 3 Gravir drugs? Number 1, Dolutegravir, Elvitagravir, and you have your Raltegravir. Okay, all these 3 are going to be Gravir group of drugs. So what this Gravir group of drugs does? They are going to inhibit your integrase enzyme. They are going to inhibit your integrase enzyme. They are going to be nothing but your Gravir group of drugs. Doltigravir, Elvitagravir, and your Raltegravir. Now you have something called as reverse transcriptase enzyme. This reverse transcriptase enzyme are inhibited by 2 types of reverse transcriptase inhibitor. One is nucleoside reverse transcriptase inhibitor, another non-nucleoside reverse transcriptase inhibitor. You have 2 drugs, nucleoside reverse transcriptase inhibitor and non-nucleoside reverse transcriptase inhibitor. What does these 2 do? Let's see later. Now we will see the next one, that is going to be your protease inhibitor. So I told integrase, polymerase, protease. So protease is going to be it's going to be inhibited by what drug? So remember, before that, your protease, what happens? They are going to be enzyme that is going to they are going to just break down your viral protein, and from the viral protein, after the integration, what happens? They will be breaking down your viral protein. They will be adding these integrated DNA. So integration of DNA we are going to do, right? So அந்த integrate ஆனோனா அந்த வைரஸ் protease மூலமா cleave பண்ணி அந்த புதுசா synthesis ஆன அந்த பார்ட்டை we are going to attach in the middle of your HIV DNA. HIV DNA ரெண்டா உடைக்கணும். உடைச்சு இந்த புதுசா அந்த proteaseல இருக்கிற பார்ட்டை ஆட் பண்ணி we are going to send it out as a enzyme. So that is called as protease enzyme. So what you are going to do, basically you are going to inhibit this protease drug. How do you inhibit this protease drug? By Gravir group of drugs. Gravir na integrase. So G for G, Gravir integrase. So Navir you are going to use in protease. Navir you are going to use in case of protease. What are Navir? Ritonavir, Indinavir, Atazanavir, Nelfinavir. So all these are Navir group of drugs. So Ritonavir, they are going to be a cytochrome P3A4 inhibitor. Cytochrome cytochrome 3A4 inhibitor is going to be your ritonavir. Indinavir, they are going to be renal stones. So indinavir, remember, they will be causing renal stones. Indinavir, the most common cause of renal stone, nephrolithiasis. And you have something called as atazanavir. Remember, atazanavir, it is going to have a least side effect. Atazanavir is going to have least side effect. They can cause hyperglycemia, hyperlipidemia, but it is very least in nature. And coming to the side effect, third one, hyperbilirubinemia. Okay, it can cause hyperbilirubinemia. Okay, now what you have to know the difference between your NRTI and NNRTI. So what is the difference between NRTI and NNRTI? NRTI now competitive inhibition of your renal, okay, RNA transferase. So we are going to competitively inhibit your RNA polymerization, or we can call it as a reverse transcription. So DNA and the RNA convert and the transcription is inhibitor. So reverse transcription is inhibitor in NRTI. Now act on HIV. So how it is going to act? It is going to act both on HIV1 and HIV2. What are the side effects? All mitochondrial toxicity. Do you remember? Where else we saw mitochondrial toxicity? We saw in linezolid. Similarly, this is also going to cause a mitochondrial toxicity. What are the three features of mitochondrial toxicity? Number one, it is going to be your lactic acidosis. Number two, peripheral neuropathy. Number three, your bone marrow suppression. And number four is optic neuritis. So this is present in linezolid. Same way it is also present in the NRTA. It is also present in the NRTA group of drugs. So it's also present in the nucleoside reverse transcriptase inhibitor. Clear, right? Now we go moving towards the one by one. First is a zidovudine. Zidovudine suppresses your bone marrow. That's all. And stabudine. Stabudine is a maximum effect is going to be present in stabudine. Lactic acidosis will be there. Peripheral neuropathy will be there. What is your altagonistic action of zidovudine and stabudine? So remember, zidovudine, stabudine, when you're going to give it together, they are going to antagonize the effect of each other. That you need to remember. And third one is going to be a didanosine. Didanosine, they are going to be a maximum causing pancreatitis, and abacavir is going to cause a hypersensitivity reaction, which can also lead to MI or stroke. Okay, and then you have lamivudine, emtricitabine. Lamivudine, emtricitabine are safest drug. They don't have any peripheral neuropathy. And finally, you're going to have last one, tenofovir. Tenofovir is a nucleoside reverse transcriptase inhibitor. You're going to have decreased the bone marrow damage. There is going to be a renal tubular damage, and there is osteomalacia. Clear, right? Again, can you repeat along with me? What are the NRTA group of drugs? So it is going to be a zidovudine, lamivudine. You're going to have your stuvudine, zidovudine, lamivudine, stuvudine, emtricitabine. Then you're going to have your didanosine. Then you have abacavir. Then you're going to have your tenofovir. Then you're going to have tenofovir. Clear, right? So next comes your non-nucleoside reverse transcriptase inhibitor. They are non-competitive inhibitor. They act on HIV1 alone. And most commonly, they will be having a Stevens-Johnson syndrome, and rashes will be present. Number one is going to be efavirenz. Efavirenz is going to be a side effect. So they are found in the teratogenic and neurotoxic in nature. They will be found in teratogenic and neurotoxic in nature. Coming to the nevirapine. Nevirapine, drug of choice of previous vertical transmission. So remember, first one is efavirenz. Second one is going to be your nevirapine. Efavirenz, nevirapine. Remember, nevirapine is a drug of choice in case of vertical transmission. HIV lady with pregnancy coming to you. Okay, so 6 weeks at least. Okay, if 6 weeks at least, then you will be giving NVP. Okay, you're going to start with NVP. But remember, HARTT, that is going to be your anti-AIDS drug. So retroviral therapy is not contraindicated. Antiretroviral therapy is not contraindicated in case of pregnancy. Antiretroviral therapy should be continued in case of pregnancy. A pregnant lady with HIV is going to come. So first baby, ammaku, you're going to give leflinol. Okay, LEFILONE, leflinol is going to be started as soon as possible. Whereas the child after the birth, you are going to wait for 6 weeks, and then you are going to give NVP. What is NVP? Can you tell me? What is NVP? What does NVP stands for? Anyone? Anyone? Let me see who is going to answer. What is the drug which we give? Nelfinavir. So we will be starting with nelfinavir in these patients. So nelfinavir is a drug of choice which we are going to give in these patients. Okay, and then coming to the HART, so that is going to be your antiretroviral therapy. So antiretroviral therapy is going to, you have to start in all HIV patients. So in all HIV patients, irrespectively, you're going to start with the retroviral therapy. But to என்ன drug கொடுப்பீங்க, that you need to remember. 2 NRTI, okay, nucleoside reverse transcriptase inhibitor plus 1 dolutegravir. 2 nucleoside reverse transcriptase inhibitor, what all you will give? Lamivudine and tenofovir. Lamivudine and tenofovir are going to be the 2 nucleotide inhibitors you are going to give along with your dolutegravir. So in a HIV positive TB, you will go for ATT. In a HIV positive patient, you go for ATT followed by ART. So HIV plus TB in the first 2 weeks ki ATT kudunga, then you come for the ART. Clear? Then comes the post-exposure prophylaxis. Post-exposure prophylaxis always start with, okay, post-exposure prophylaxis always start within 72 hours of exposure. 2 NRTI plus the dolutegravir. That is going to be a drug of choice. Duration 28 days. So in any case, you are going to follow this. Okay, just blindly follow this. Lamivudine plus tenofovir plus dolutegravir. This is a drug of choice in all HART. Okay, except when it is going to be a child who is going to be born 6 weeks, nevirapine can be given. Nevirapine can be given, and if you are going to give lefilone where you will give in a HART pregnant woman, you will be giving lefilone. Okay, so now coming to the pre-exposure prophylaxis, you go for a tenofovir and emtricitabine. For pre-exposure prophylaxis, you go for your tenofovir and emtricitabine. Now coming to the hepatitis B, you all know drug of choice is going to be your entecavir. Remember, so what is the drug of choice in hepatitis B? That is going to be entecavir. Entecavir is a drug of choice in case of your hepatitis B. In case of hepatitis B, what is the drug of choice? You go for your entecavir. What is the drug of choice in case of pregnancy? Tenofovir is a drug of choice. So in HIV, you're going to keep lamivudine, emtricitabine. So HIV plus HCV, hepatitis B, you go for tenofovir. So HBV along with HDV, you go for interferon alpha subcutaneous route. You will be going for interferon alpha subcutaneous route. Now coming to the hepatitis C, which is going to be previously drug of choice, interferon gamma, along with it you go for ribovarin. Ribovarin, R stands for RNA polymerase. I always tell you, rifabutin, rifampicin, ellame RNA polymerase inhibitor. Similarly, your ribovarin is going to be RNA polymerase inhibitor, which is going to cause side effects of hemolysis, Lassa fever, and respiratory syncytial virus can also occur. Now coming to the new oral drug, HCV protease inhibitor, Simiprevir and Paritaprevir. And HCV RNA polymerase inhibitor, you're going to have Dosabuvir and Sofosbuvir. Remember, samosa, dosa. Okay, Sofosbuvir, Dosabuvir. Then you're going to have HCV protein NS5A inhibitor, nucleic synthase 5A inhibitor, that is going to be inhibiting your replication, Ledipasavir and your Diclatasavir. Okay, so then comes your HCV, Sofosbuvir and Lediparvir and Sofosbuvir and Daclatavir. These are the oral HCV drugs that you are going to remember. Now coming back to the last one, that is going to be influenza virus. So influenza virus, you are going to give you have your 2 parts. Can you tell me what are the 2 things that are present in your influenza virus? What are the 2 important components of your influenza virus? Can you tell me? What are the 2 components of influenza virus? Neuroaminidase and neuroaminidase. Can you tell me what are the 2 things that are present? Neuroaminidase and hemagglutinin. Exactly. Very good, Afil. Hemagglutinin and neuroaminidase are the components of your influenza. Among them, neuroaminidase, they are going to prevent virions release. So what are the example? Oseltamivir. Do you all remember? Last few months, most of them are suffering from an influenza virus. Okay, flu virus suffer. For them, the effective drug is going to be Tamiflu. 75 mg BD for 5 days you are going to give. Tamiflu is going to be the drug of choice. And remember, Zanamivir. What is Zanamivir? Zanamivir is going to be inhaled drug. So its side effect is bronchoconstriction. This is given Oseltamivir resistant strain. And you also have your Peramivir. Or do you remember one drug which we are constantly giving in COVID-19? Can someone recall and tell me? In COVID-19, one antiviral we were giving. Can you all recall? Can you all recall one antiviral injection? There were like queues and queues standing inside the in front of King's Hospital in Chennai for this antiviral drug. Can you remember? Can you recall and tell me antiviral drug used in the in your COVID-19? Antiviral used in the COVID-19. Everyone, most of you would have known this. R, it starts with R. Can you fill this? Can you fill this? This antiviral which was used in COVID-19. It's not remantadine. It's not remantadine. It is ending with R. Something that ends VIR. VIR, not another antiviral. Something ending with VIR. Starting with R and ends with R. Let me see who is telling the correct answer. During COVID-19, probably you would be in your 12th standard, okay, or preparing for your NEET PG, NEET UG, right? So what was the drug that was given? Remdesivir. Do you remember now? Remdesivir. So remdesivir is one of the drug which is an antiviral given in case of your COVID-19. That is also given in the case of remdesivir. Okay, that is also going to be given in the case of remdesivir. Actually, this remdesivir is not just remdesivir which is given. We were giving a combination of remdesivir with ritonavir, which is given with a combination of ritonavir. So this ritonavir remdesivir combination is commonly used in case of your in case of your COVID-19. So remember the COVID-19, the drug of choice is going to be remdesivir and ritonavir as far as antiviral is concerned. Now moving on to talk about the anti-helminthic. So we will talk about anti-helminthic and I'll give you 1 hour break. At 5 o'clock, we will again come and assemble. We will start with the CNS, endocrine, hematology. Today, we will be completing CNS, endocrine. Then we will try to cover hematology and neoplastic drugs. So all these 4, we will be starting to cover from your 5 p.m. So 4 to 5, I will give you a break. So just half an hour, kindly stay. We will be trying to complete anti-helminthic. Okay, so now coming to the anti-helminthic, the first anti-helminthic which you are going to remember is tapeworm. So tapeworms are called as cestodes. So just a recollection of your microbiology. So you call it as cestodes. What are the cestodes you have? Taenia solium, Taenia saginata, Taenia latum, H. nana, Echinococcus granulosa. In all these things, in the Taenia solium, Taenia saginata, Taenia latum and H. nana, you're going to go for a drug of choice is praziquantel. So the drug of choice you're going to use here is praziquantel. Praziquantel is a drug of choice in case of Taenia solium, Taenia saginata, Taenia latum and then Haemophilus influenza. Sorry, your H. nana. In your H. nana. Okay, so they are going to be your praziquantel. How does this praziquantel act? Praziquantel is going to act by giving a calcium influx. Whenever there is a calcium influx in all these parasites, what happens? There is a spastic paralysis. Because of the spastic paralysis, there is a death of the parasite which is inside. So that is your Taenia solium, Taenia saginata, Taenia latum and your H. nana. Coming to the Echinococcus granulosa, you go for albendazole. Albendazole is a drug on choice for the Echinococcus granulosa. And neurocysticercosis. In the neurocysticercosis, the drug of choice is albendazole more than praziquantel. So the 3 who are here, have you ever seen the call and tell me? Okay, I'll give you time till the end of the class. Let me see who is going to. Good doctor, excellent. So good doctor. So good doctor series la first case. If you're going to see the first episode, first season, first case, that is going to be your neurocysticercosis. Okay, if you go and watch today, you will be able to learn A to Z of neurocysticercosis. They will be giving all the symptoms. Everything is given as such. And the treatment is also albendazole more than praziquantel, which is given. And you have to treat the patient with steroid. This is a very important point. You need to start treating the patient with steroid before starting with albendazole. So that's what I wanted to tell you all. Then you have your trematodes. Then trematodes, it's going to be flat or flukes, flat flukes. We call it as flat flukes. You have your schistosoma and F. hepatica. Schistosoma, drug of choice is again praziquantel. Hepatica, the drug of choice is tridabenzadole. So you have tridabenzole, tridabendazole. So you have your albendazole, right? Like albendazole, you have tricloalbendazole, triclobendazole. So TRICLO, triclobendazole. Okay, or you can go for bithionol. Okay, this is going to be for trematodes. Okay, now for nematodes, it's going to be Ascaris, Necator. Okay, you have your Trichura, Trichinella, and you have Entrobius. Okay, for Trichinella, the drug of choice is going to be albendazole 400 mg single dose. How does your albendazole functions? We know that praziquantel is going to function by increasing the calcium influx, causing a spastic paralysis. Similarly, your albendazole is going to perform by giving 400 mg single dose. If you are going to give it, is going to inhibit the glucose reuptake. So glucose uptake inhibit panitsna, it is going to cause decrease in the glycogen reserve, and automatically the parasite is going to die. And entrobius is nothing but a pinworm. So that is going to be drug of choice is mebendazole than your albendazole. For praziquantel or guinea worm, so you're going to go metronidazole. Do you remember guinea worm? So we will be going for metronidazole. And for filaria, we will go for lymphatica or your onchocercava. So if it is going to be an onchocerca, it is going to be ivermectin drug of choice. If it is going to be lymphatic, you go for diethyl carbazine, DEC. So DEC is going to be the drug of choice in the lymphatic filariasis. Ivermectin drug of choice in strongyloids, threadworm, oral scabies, like you will take oral, drug of choice in permethrin. So GABA gated calcium channels is going to be inhibited, that leads to flaccid paralysis. Then you have your pyrontel pomade. So pyrontel pomade, it is going to be a drug that is going to be given in, which is going to block your nicotinic sodium channel and causes spastic paralysis. So remember, ivermectin causes flaccid paralysis, whereas your pyromental pomade will be causing a spastic paralysis. This will cause flaccid paralysis of your parasite. Now coming to the malaria, what is the drug of choice you take for malaria? Can you tell me? The malaria you will be going for depending upon what type of species it is. If it is going to be a Plasmodium vivax, you will go for chloroquine sensitive drugs. So chloroquine 10 mg per kg on day 1, day 2, and 5 mg per kg on day 5. Okay, so primaquine 0.25 mg per kg per day for 2 weeks you give. So you are going to give chloroquine and primaquine. Do you remember what is going to be the standard dose? Though this we give in case of your 0.25 mg per kg abdila sonna kuda, what is going to be the standard dose prescribed in our Indian guidelines for this chloroquine and your primaquine in malaria? Can someone tell me what is going to be the dosage of chloroquine and primaquine in malaria? Can you tell me what is the malaria guidelines? Chloroquine, primaquine. Come on, guys, you know this. Actually, you know this. This is a very important topic in the community medicine next year also. So next year in community medicine, this will be a very important topic. Can I just recall and tell me? Let me see who is going to tell. How much primaquine, how much chloroquine is what my question. How much primaquine, what is chloroquine? See here. So for an uncomplicated malaria caused by your Plasmodium vivax, you will be giving chloroquine for 3 days. Okay. And then primaquine for continued for 14 days or 2 weeks. This is going to be given till 14 days. Okay, this is going to chloroquine given for just 3 days. Okay, so day 1, day 2, 10 mg per kg, day 3, 5 mg per kg. Then primaquine, you're going to go for 0.25 mg per kg for 14 days. You're going to go for 0.25 mg per kg for 14 days. You're going to go for. Okay, next we are going to move towards what? Next is going to be your primaquine. What does your primaquine do? Primaquine is going to cause killing your all your hypnozoids. Hypnozoids, they may be stored in the liver, so that is going to be killed, and they will be preventing the relapse. So in your vivax and ovale, they are going to prevent the relapse. Okay, now coming to the side effect. So hemolysin and G6PD deficiency. So they will be causing hemolysin and G6PD deficiency. They are contraindicated in pregnancy. So primaquine causes hemolysis in G6PD deficiency, so contraindicated in the pregnancy. Remember, tefenoquine is the longest T of uses single dose radical cure. Now moving on towards your Plasmodium falciparum. Plasmodium falciparum is going to be a chloroquine resistant artemethin combination therapy is given. Artesunate, artemether. Artesunate is combined with the sulfadoxamine. Artemether is combined with lumifantine. So 100 mg BD for 3 days. This is going to be given artemether and lumifantine. This combination is given in the northeast areas. What are the northeast area? Your Mizoram, your Nagaland, okay, Nagaland and the famous Manipur and all these areas we are going to have give a artemether. Along with artemether we are going to give a lumifantine, but artesunate is the one that is going to be given in case of Chennai people. In case of Chennai, Bangalore, Mumbai, Kerala, all these people are getting artesunate and sulfadoxime pyrimethamine combination. Okay, this is for your chloroquine resistant, that is your Plasmodium falciparum. Coming to the uncomplicated malaria, Vivax and falciparum, CNS involvement complicated malaria, when there is going to be a Vivax and falciparum, when there is a CNS involvement, you are going to start with IV artesunate as a IV. Okay, then your IV quinine, you go for IV artesunate. IV artesunate mudichidu, then you can go for oral artesunate therapy. The same thing, artesunate along with that sulfadoxime pyrimethamine, that combination can be given. But if you are going to give IV quinine, so they will be causing increase in the insulin release and they will be leading to hypoglycemia and black water fever will be occurring and there is going to be a cinch or some. So tinnitus can occur. Okay, malaria in pregnancy. What will be your prophylaxis in malaria? In malaria, what you are going to give for malaria people for pregnancy? Vivax, you give only chloroquine. In falciparum, you are going to give first trimester quinine plus clindamycin. Okay, second and third you can go for artesunate combination therapy. But remember, artesunate combination therapy is contraindicated in first trimester of pregnancy. First trimester of pregnancy. That is a very important point you need to understand. Now coming to the prophylaxis. Prophylaxis, this is given to all the travelers. So for the people who is going to go to the malaria prone area for less than 6 weeks, you go doxycycline. I told you already. For more than 6 weeks, we go for mefloquine once in a week. So what is the duration? Till 4 weeks after going back. So what is the side effects? You have cardiac conduction defect, neuropsychiatric symptoms like insomnia, vivid dreams and psychosis. Now coming to the chloroquine, remember chloroquine is also used, extra malarial uses are there like your rheumatoid arthritis. Long-term chloroquine in the rheumatoid arthritis will lead to, all remember right, bullseye maculopathy. So so in the rheumatoid arthritis, so they are going to take your chloroquine for prolonged period, that will be leading to the chloroquine induced retinopathy, that is going to be a bullseye maculopathy. There are extra intestinal amoebiasis can occur, SLE and then lepra reaction and then photosensitivity or porphyrocutia. So porphyria cutinea. So cutinea, that is going to be causing photosensitivity reaction. With this, we are actually completing, before time itself, I have completed antimicrobials. Now we have completed antimicrobials. So next what we will do is, we will start with the central nervous system, CNS. So next we are going to start with your CNS. So CNS, we will be trying to complete it by we will be joining back at 5 o'clock. Okay, 5 o'clock, come back from 5 to 6. We will 5 to 6:30. We will complete the CNS. Then I will give you a break. Then 6:45 to 8. We will try to complete the endocrine. Okay, we will try to complete the endocrine. After completing endocrine, what happens? Then we will take a break. At again starting from 9:15 to 11:15, we will try to complete hematology and anti-cancer drugs. So today we have to complete the part 1 of your pharmacology. So tomorrow part 2 of pharmacology will be there. Hope you are all good. So hope I have cleared all the things of in your antimicrobials. If you have any doubt, you can ping me at this number. 8667719564 is my number. You can ping me anytime. I'll be helping you all. So join back at 5 o'clock sharply. We will be starting with the central nervous system, CNS drugs. Okay, thank you.